Okay. Uh, Good morning, everyone, and warm welcome to fourth DiaConnect PSG, the dedicated conference on diabetes and pregnancy. We are here to propagate the science robustly for hyperglycemia in pregnancy. We are here to improve the care. We are here to propagate the message from different guidelines, especially DIPSI guidelines, which are acknowledged by WHO, Government of India, which are practical for clinical practice and accepted all across the globe. This is the fourth meeting, first time out of Gujarat in Kolkata, West Bengal. This is a unique platform where faculties from two fields of diabetes practicing and OBGY doctors have crosstalks and to discuss shortcomings of field where we need each other and we need to improve. To support us, we have Dr. Padma Shri, Professor V. Seshia. Unfortunately, he could not join us due to some technical reasons. Dr. Bansi Sabusa, he is traveling somewhere, but he will be joining us soon. Dr. Hema Divakar ma'am, who is current president of DIPSI. Dr. Sunil Gupta, who is immediate past president of DIPSI. Dr. Abhinash Ray, who is president Bengal Obs-Gynae Society. Dr. Biswajyoti Guha, who is secretary Bengal Obs-Gynae Society. Dr. Rajiv Chawla, who is past president of DIPSI and RSSDI board. Dr. Anuj Maheshwari, who is current president of ACP India chapter and very active member of DIPSI. Dr. Bijay Patni, founder president of DRWA here in West Bengal. Dr. Supratik Bhattacharya, who is founder president of AMOS, and none other than my dearest ma'am, Dr. Shalini Jaggi. She is a governing council member of DIPSI and holding many posts of RSSDI, especially in Delhi chapter. And I welcome all delegates and faculties again with overwhelmed heart. And I'm really excited for this two-day conference in diabetes and pregnancy. Again, I welcome you all and hand over the session to Dr. Dharmendra Panchal, who is organizing chairman of PSG.
Thank you. And again, I just welcome all of you on this day. As I can remember still today, in 2019, we started the journey of pregnancy study group when me and Rutul thought of to have such meetings, and with the wholehearted support of all the seniors, to name Salini ma'am, Rajiv sir, V. Sesaya sir's blessings, and all other friends and colleagues. Now, today we are here organizing fourth PSG meeting in Kolkata. It's really a great feeling to welcome you all on this meeting, on this dais, and it's amazing feeling. I would just say to get together two different fraternity with that idea. Which we started, and now bringing all of them into one platform with United Forum, and that's what now it's really being possible. Thank you all of you for your supports, and we are sure that for both of the days we will have a fantastic academic feast and some more insights in the subject of pregnancy and diabetes. Thank you. Would I like to hand over session for further proceeding over to Dr. Rutul.
Yeah, Dr. Amit Kumar De, please proceed further.
Thank you very much for the introduction to the event. A warm welcome to our esteemed faculties, to all the delegates who are watching us in the fourth DiaConnect PSG. We all know that diabetes and pregnancy is always a double-edged sword, and it is something which needs to be managed in a multidisciplinary way. So with this thought in mind, we have an interdisciplinary conference featuring eminent diabetologists, physicians, and obstetricians from across the country. So without much delay, I would like to introduce our eminent faculties, and I would request them to inaugurate the event with a few words. So first, I would like to request our program director, Dr. Shalini Jaggi, to say a few words.
Thank you so much, Dr. Amit, Dr. Rutul, Dharmendra. A very good morning to everyone who's logged in. It's a proud privilege and honor for me to be part of this program in all capacities as a program director and as your friend, colleague. It's been a great journey so far when it comes to the pregnancy study group, a group that started with a small set of like-minded young people who were interested in this field of diabetes and pregnancy, and they decided to actually do something about it. They got together, started the first PSG conference, and last 3 years, we've all been part of the PSG journey and seen it grow. So this is a great step that we've moved out of Ahmedabad and we're trying to go out pan-India, take the message of the PSG group with the blessings of DIPSI, with our mentor, Dr. Seshia, who's always been our guiding force, our mentor, our motivator. So taking his message across to the whole country. And for the first time, we've moved to West Bengal, and I'm very excited to be part of the Bengal conference very soon. And the program, as all of you will see, this is a multidisciplinary approach when it comes to managing diabetes in pregnancy. So I think it's a great blend of physicians, diabetos, and obstetricians and gynecologists, because none of us can manage it alone. We all have to walk the path together. And the whole idea is to make the life of our patient comfortable and to give her a healthy baby. So I think we've nicely curated the program, starting right from preconception counseling, the role of preconception control. We moved on to the differences between pregestational diabetes as well as gestational diabetes, seen how the management is going to happen. So we will be covering, I think, all the topics that are pertinent to this field and of interest to both the physicians and diabetologists, as well as the gynecologists and the obstetricians. And I'm sure you will all enjoy the scientific feast that has been planned for you. The first day is a virtual conference, so all our friends who are not able to meet us physically will be part of the conference. And I'm sure all our experts are luminaries in this field. And I'm sure the delegates will definitely go back richer, learning from the experience and the kind of scientific deliberations that you will see happening in the next 1.5 days to kind of shed more light on this and the way forward when it comes to managing diabetes in pregnancy. And especially, I would request all of you to tune in for Dr. Seshia's address, where he's going to give us a very futuristic vision of the whole idea of why primordial prevention has become so important. We've always talked about diabetes prevention in terms of primary, secondary, and tertiary, but all of that happens after birth. So can we actually nip it in the bud and stop it right there in its track is something that Dr. Seshia has come out with a concept, and I'm sure we will all be wiser and intelligent enough to understand what he's saying. So with that, many thanks. Welcome everyone to this 1.5 days of pure science when it comes to diabetes in pregnancy. And I'm sure you will all enjoy the conference. Thank you so much.
Thank you very much, Dr. Shalini, for the kind introduction to the program, for all your support, and she's been a wonderful mentor to many of us. We move on to our other eminent faculties. I would request Dr. Hema Divakar. She is the president of DIPSI. If ma'am is online, I would request her to say a few words. Do we have Dr. Hema Divakar with us?
She is right now traveling, but I'll ask her. Yeah. Till
then, I think we can move on to Dr. Rajiv Chawla, sir. Sir is the past president of DIPSI. So your words for the event.
Thank you, Dr. Amit, Dr. Dharmender, Dr. Rutul, for this honor and opportunity to be part of very, very fast upcoming, I'll say, diabetes pregnancy study group, which is going pan-India. Best thing is, and what actually gives a lot of pleasure to us is that this is absolutely aligned with DIPSI, and you are following the guidance and the blessings and the teachings from Professor Sheshai, who's mentor to all of us. And this group, which started, I think, almost 4 or 5 years ago, has really made a mark in terms of science. And we have been following all of you over the last 3 to 4 years. And year after year, this is getting a lot of popularity in terms of dissemination of knowledge. And recently, as you move away from Ahmedabad, that again gives a pleasure that you're going pan-India for organizing your conferences and disseminating the knowledge of diabetes in pregnancy, evidence and guidelines. Last year, we, through DIPSI guidelines, we tried to do a number of webinars across the country, which has been again followed beautifully by Drs. Sunil Gupta, also who is immediate past DIPSI president. And I'm sure with Dr. Hema Divakar, who is already now joined as president for DIPSI, I think these learnings are going to be part of teaching to entire country. And there, I think your PSG group, which may be younger group, you people, I don't want to say that you are young in terms of your practice or evidence, but very young in terms of your inception, because DIPSI has been there for almost 25, 30 years now. And I look upon PSG as a baton being passed to the next generation. So it's a real pleasure for us that what we learned from Professor Sheshai, Dr. Balaji, Dr. Hema is there, is being carried forward through us towards our younger generation, our younger colleagues. And this initiative on your part to carry PSG pan-India and doing these conferences, again, extremely very, very important to carry these messages, which may not be possible for all of us as senior people or for, say, Professor Sheshai as patron. But good thing is that Dr. Sheshai still has a lot of insight, and very fact that 6 months ago, he started talking about primordial prevention, which is going to be a pilot project and a future research area of interest to all of us, those who are keen in diabetes in pregnancy group. So I think through all young colleagues, all young friends, I'm sure these teachings will be carried further. And very fact, this is a multidisciplinary conference with gynecologists from Bengal chapter. So I'm sure all the delegates, those who will log in today virtually and physically tomorrow, they are going to have a lot of insight into the subject of diabetes in pregnancy. And our purpose of dissemination of this knowledge will be possibly delivered to the end user. And next day onward, they will be able to rationalize their practice. And that will be in the best interest of the patient. So I really wish entire group, Rutul, Dharmender, Dr. Amit, Dr. Shalini, and the entire PSG group, best of luck. And I'm sure that it is going to be a benchmark conference in the field of diabetes in pregnancy. Best of luck.
Thank you very much, sir, for your kind words, for all your blessings. We have Dr. Hema Divakar with us. Ma'am is the president of DIPSI. Ma'am, over to you.
Namaskar. On behalf of Padma Shri Dr. V. Sheshaya, the patron, Dr. Balaji, the secretary, and myself as the present president of DIPSI and the entire extended DIPSI family, I bring you lots of greetings, good wishes, and lots of strength and power for the action points that the PSG has set out to do. Rutulji just rang up and said, Madam, we already called your name, but you disappeared. So it goes to show symbolically that once is not enough. You need to call out to OBGYNs again and again and again, because we need to be in the picture there, because the insights that we have got now, that though diabetes is a non-communicable disease, it communicates from generation to generation, and it's a pledge by all the OBGYNs to join hands, the sweet connections, as I call them, with the diabetologists of this great country, prove that we are working synergistically, and together we will conquer the primordial prevention of the diabetes in the generations to come. It is our fond dream that to our next generation, we have to give the gift of good health. And thank you so very much. I've put the vehicle on hold. I said, Abhi, ruk jao. I have to give my 2-minute address here and then we move on. So this stopover of the hyperglycemia in pregnancy, more the pregnancy study group studies it, the complexities unraveled jointly by the diabetologists and the OBGYNs will set the pace for the actions in the future. And I wish that we always stay together, work together, and achieve what we have set out to do. Namaskar.
Thank you very much, ma'am, for all your support.
Thank you for joining.
Yes. So bringing PSG DiaConnect to Kolkata, I think we had the role of multiple individuals who are in the frame today, who played a pivotal role in helping us organize this event and will play a significant role in helping us in making this event a big success. So let me introduce President of Bengal Obstetrics. Am I audible? I guess. Yeah.
You are audible.
Yes. So we move on to our president of the Bengal Obstetrics and Gynecological Society, Dr. Avinash Ray. I think sir has been very pivotal in helping us organizing this conference here. His support with all the members of the Bengal Obstetrics and Gynecological Society in forming the agenda. So over to you, Dr. Ray, with your words for the conference. Dr. Avinash Ray. Kindly unmute yourself, Dr. Ray.
Namaskar. I'm audible?
Yes, you are.
Amit? Yes.
Yes.
Namaskar. Good afternoon, everybody. As a president of the Bengal Obstetrics and Gynecological Society, thank you, Dr. Amit Kumar De, the chairman of 4th DiaConnect Pregnancy Study Group, for involving us, the BOGS, in this unique scientific extravaganza. I also thank to Dr. Dharmendra Panchal, the organizing chairman, and Dr. Ratul Goklani, the organizing secretary, to take initiative for such a useful program, which will be very beneficial in gynae specialties in our day-to-day practice. We are so much concerned about the management of pregnancy associated with diabetes. To overcome all the problems of the baby and mother in utero or outside the utero, that is a great challenge for us. Hope today's scientific discussion will generate lots of latest scientific take-home message, and it will be immense help in our day-to-day practice. Thank you once again, dear Amit. Thank you very much. Okay.
Thank you, Dr. Ray. We also have with us Dr. Bishwajyoti Go. He's been an elder brother to me, and he's the secretary of BOGS. Dr. Go, over to you for a few words from your end.
Please unmute yourself, Dr. Guha.
Yes. Am I audible now?
Yes.
Yeah. Good afternoon. Good afternoon to all of you. It's plenty of new faces, plenty of smiling and new faces. My young brother Amit has just said that it has been quite a challenge to bring up this program, because we had to pass through a managing committee in the Bengal Obs and Gynae Society, and then we had to go through a lot of hassles to get this program ready and collaborated with PSG. But now that is on, I must say that all the congratulations goes to Amit and Dr. Rutul for chasing both me and Avinash Da for this, Dr. Avinash Chandra Ray for making this kind of event happen. And I think it's a very innovative thing to have an obstetrician and a gynecologist conference on gestational diabetes or diabetes in pregnancy in particular. Because we know that diabetes in pregnancy is on the rise. Even today, I did a cesarean section on a lady who is 36 weeks and had diabetes with pregnancy. And so we do have lots of patients now coming us with diabetes, and we need to find out a way forward. And I always think that diabetes cannot be managed by me alone. or it cannot be managed by the physician alone. It has to be managed on a joint platform, and it has to be managed by a team which consists of a diabetologist, probably a good diabetic nurse who can explain the diabetic diet to her, and also a gynecologist as well. So these are the main things that we need to highlight in this conference, that the evolution and the experience and the amount of teamwork that we should put in while managing a patient with diabetes in pregnancy. And Dr. As Dr. Ray said, that diabetes in pregnancy has got its unique challenges, and the challenges is the challenge is the fetus, because it becomes, about what happens when a mother loses a baby at 36 weeks of gestation, what we call unexplained fetal loss. And this is something that we cannot explain. This is where our science has failed to find out which baby is going to die in pregnancy in utero and which is not. And that is where we will probably we'll probably find out the new ways forward when we have got lots of artificial intelligence. Actually right now we are working on data. We are sharing data with an artificial intelligence company who will be able to predict which are the babies who are likely to which are the babies who might get stillborn or likely to have an intrauterine fetal death. So that is one of the challenges we still face, because Doppler, CTG, nothing can predict whether that baby is going to stay alive for the next 24 hours or no, or so. And so we actually, this is one of those subjects, diabetes in pregnancy, where we end up delivering a premature baby because of and the chances of having an iatrogenic prematurity are higher than in other medical disorders in pregnancy. The reason being that we are afraid of that unexplained fetal death. So I must thank Dr. Dharmendra Panchal, Dr. Rutul, Dr. Amit Kumar Ray, Dr. Hema Divakar for gracing this occasion, and Dr. Vijay Patni, Dr. Rajiv Chawla, Dr. Shalini, Dr. Vinod, Dr. Swapnil, Dr. Kalpesh, Dr. Kunal, Dr. Sushil, Dr. Dhaval, and all of us that, those who are present today. I must thank my president for giving us, for letting us use this platform today. And I also thank Amit Kumar De for inviting us. Thank you very much. Thank you. And I hope this conference a whole success. Thank you.
Thank you very much, Bishujyotida, for your words. Thank you for all the support. And, diabetes, it's like an epidemic. It's like a pandemic all over. And we need a lot of physicians to manage diabetes. So diabetes is a primary care disease that needs to be managed by physicians. So this conference is for physicians, it's for endocrinologists, it's for gynae-obs, specialty doctors. We have with us Dr. Vijay Patni, sir. Dr. Vijay Patni is the founder president of Diabetes Research Welfare Association, an organization that has been working actively with physicians across West Bengal and spreading messages on diabetes care. So over to Dr. Vijay Patni for his words.
Good afternoon, and thank you, Amit. And it's nice to see so many stalwarts on board. And the best part is that it's nice to connect digitally, though mine is an intermittent, fluctuating network. So on behalf of DRW, I welcome PSG to Kolkata. Partnering PSG for academics is an honor for our organization, particularly on a subject which is so very important and still ignorant as far as the proper approach to managing subjects are concerned. Subjects means the pregnant woman with hyperglycemia. So not only we are addressing the present generation, but also the future generation, if we can really can manage these cases appropriately. So without wasting much of a time, I thank Dr. Rutul, Dr. Amit, Dr. Rajiv Chawla sir, Dr. Salini, and our OBS and Gynae team which have joined us. Thank you all. And I think this will be a very successful event. And hopefully we will be joining tomorrow physically, most of us at Novotel. So thank you once again for giving me this opportunity. And thank you, Amit, once again. Thank you.
Thank you very much, Dr. Patni. And so I think we have covered all the organizations. We also have participation and support from the ACP India chapter. Dr. Anuj Maheshwari is the governor of the ACP India chapter. Unfortunately, I think sir could not join us today, probably because he's traveling. And we also have Dr. Shupratik Bhattacharya from EMOS, which is a new organization working towards obesity, because we know diabetes and obesity coexist, diabesity as we call it, and obesity is also a very important comorbid factors in pregnant mothers with diabetes. So we will have a session from the AMOS team as well. So I think I will request Dr. Shupratik has joined us just. So Dr. Shupratik, welcome, and just your few words from your end.
Big hearty congratulations to you, Dr. Amit, Dr. Rutul, Dr. Dharmendra, and the entire team of PSG. And I'm so glad that you kept the session on AMOS, which is basically focusing on obesity and metabolic medicine and clinical endocrinology, which is again part of the problems that a pregnant woman would come across. To be focusing on the reasons of obesity during pregnancy, and also problems like the thyroid disorders that can happen during pregnancy. So I think it's a mixed bag, and I'm very excited and looking forward to this entire event. So a big hearty congratulations and welcome to Kolkata.
Thank you very much. And again, a welcome to Kolkata to all of you who will be joining us physically for the over the next 24 hours. So I think with this we can start our event, and I would hand it back over to Dr. Rutul Goplani.
Thank you very much, Dr. Amit Dey, for proceeding it so nicely. And I'll ask Dr. Deepak Chudasama to give the vote of thanks for everyone who has joined and who has supported us. We are really overwhelmed and really overjoyed for this amazing forum that you have provided. Thank you.
Thank you, Dr. Rutul. Am I audible?
Yes.
Yes.
Respected dignitaries, doctors, colleagues, and my friends. I am Dr. Deepak Chudasama. Feel honored to pronounce vote of thanks on behalf of the organizing committee of DiaConnect PSG Pregnancy Study Group 2022 at Kolkata. My first thanks to Almighty God for making all of us today to be what we are today. I am humbly thanks to our chief advisor and our mentor, Dr. Bansi Sabu sir, Padma Shri Dr. V. Sesaya, Patron DIPSI, Dr. Hema Divakar ma'am, President DIPSI, Dr. Rajiv Chawla sir, past President DIPSI, Dr. Anuj Maheshwari sir, Governor ACP India Chapter, Dr. Sunil Gupta sir, immediate past President DIPSI, for their valuable presence for the inaugural ceremony PSG 2022. I thank Dr. Bijay Patni, founder and president DRWA, and Dr. Supratik Bhattacharya, chairman CDOC, Dr. Abhinash Ray, president Bengal Obstetric and Gynecological Society, Dr. Biswajyoti Guha, secretary BOGS, for making that possible to grace the inaugural ceremony. I really thank Dr. Salini Jaggi ma'am, our program director, for drafting a wonderful scientific agenda, which I am sure all of you will enjoy. I would like to thank our organizing secretary, Dr. Rutul Goplani, Dr. Program Chairman, Dr. Amit Kumar De, Organizing Chairman, Dr. Dharmendra Panchal, for their continuous support in making this conference a truly scientific feast. A conference is what it is enlightened with distinguished faculty, what it make it. No word to praise would suffice to express our gratitude to our dignitaries, faculties. Here, I would like to give thanks to all of the faculties from different parts of India. I am thankful to all our industry partners who had supported in this meeting with big way and their open-handedness made our conference comfortable. At last but not the least, I would like to thank most important individual for any conference, and that's our delegates. I personally thank each one of you for being present here, and I'm sure you will enjoy the scientific feast. I'm also thankful to all the personnel who are directly or indirectly helped for organizing this wonderful meeting. Once again, thank you all of you from bottom of my heart. Thank you. Jai Hind. Dr. Rutul.
Lastly, we'll have Ganesh Vandana. So it is at the end, but it is beginning of the meeting. So we'll start.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः।
Now, I would request Dr. Amit to start the Hall A further. And thank you everyone for joining and sparing the time in the busy Saturday. I am seeing Shalini ma'am still being there, though she is in between the OPDs, and Dr. Ashish Dengra, who is traveling to Mumbai. Everyone has joined. Dr. Abhinash Ray, thank you very much, sir.
Thank you very much.
Thank you.
Heartiest congratulations to Rutul and Amit and to the team PSG. They are doing very good, great job. Congratulations.
Thank you, Dr. Ashish, for the kind words. Thank you, everyone, for joining in. And I think we should now start our session without much delay. So we are going to start the proceedings in Hall A. And the first session is going to be on GDM from where it begins. And I would like to hand over this session to Dr. Jaideep Rivale from Satara. Over to you, Dr. Jaideep. I hope he has joined us. Dr. Jaideep is there with us? All right. All right.
Hello.
Our chairpersons, Dr. Kalpesh and Dr. Swapnil.
Yes.
Yes. So I think Dr. Kalpesh and Dr. Swapnil, please take over the session, and it's all yours.
Fine.
Stop.
Am I audible?
Yes, you're audible.
Yes.
Everyone else to mute themselves. Yes, thank you.
Yes, a very good afternoon to one and all here. At the outset, I would like to thank the organizers for having us here, specifically Dr. Rutul and Dr. Dharmendra. You have done a wonderful job in organizing this wonderful academic feast. So let us begin the first session today. Our first speaker who is going to be Dr. Raka Sihare. He has done his MD medicine. He is a wonderful dynamic director of Lifeline Madhumit Diabetes Hospital at Raipur. He is currently the president of Global Diabetes Forum. He is EC member of Chhattisgarh State Chapter of RSSDA. He is also a president of Indian
Podiatry Association's Chhattisgarh chapter. He is also president of Rotary Club of Raipur. He is currently ongoing MSc Endocrinology. He has been affiliated to many societies and has been the national faculty for almost all national conferences. So with this, let us begin our first talk. Over to you, Dr. Raka.
Yeah, do we have Dr. Raka joining us? I think Dr. Jaideep has joined us. RX team, can you just confirm from Dr. Raka if he's joining us?
Dr. Raka, she already joined within 5 minutes. So
okay, so in that case, I think what we can do is Dr. Jaideep is there. So Dr. Jaideep, if you can just take over the session and just till Dr. Raka joins in.
Okay, that's great. Thank you, Dr. Amit and team PSG for giving me this opportunity to moderate this session. So I think we have this session for the GDM, where to begin. So Dr. Amit, who is another chairperson, may I know?
Yeah, we have Dr. Swapnil and Dr. Kalvesh as chairpersons. So they have already joined. We just Dr. Raka to join as the speaker. I think he's
okay.
We can have a session of Dr. I think we have recorded session from Dr. Om.
Okay.
Okay. Or else our second speaker of the session is Dr. L. Srinivasa, sir.
No,
so
he won't be able to
the...
come in. Yeah, I think Dr. Raka will take over. So I think we can have the session by Dr. Om, and then Raka has joined, so he's already there.
Okay.
Welcome, Dr. Raka.
Yeah. Hello, everybody. Hi, Rutul. Hi, Amit. Hi, Dharmen. It's better to start with Dr. Om Lakhani because it's a recorded session, so that there should not be a repetition. I'll omit the slides, the same session which he will be telling. Okay. Amit?
Yes, we can do that. So do we have that session ready?
Yeah, I told the team.
RX team, we can have the recorded session by Dr. Om Lakhani. Yes.
Should I introduce him first?
Please go ahead.
Can I have a slide of him?
Hello, everyone. I'm Dr.
Yeah. So our first speaker is Dr. Om Lakhani. He is a consultant endocrinologist. He is working in the Department of Endocrinology in Zydus Hospital, Ahmedabad. He has done MBBS and MD Medicine and DNB Endocrinology. He is honored with the winner of the President of in gold medal in endocrinology. He is the national winner of ESI TAISA in 2016. He was the second runner-up in A.V. Gandhi Award 2017. He was the winner of second gold medal in MD. He was the winner of 5 gold medals in MBBS and winner of API Dr. Vittal Rao Nadgwada for the first best thesis in MD Medicine. And he is the developer of the Notes in Endocrinology app. So we can have now Dr. Om Lakhani's recorded lecture. Thank you.
Om J. Lakhani. I'm a consultant. Hello, everyone. I'm Dr. Om J. Lakhani. I'm a consultant endocrinologist working at Zydus Hospital in Ahmedabad. And I thank the organizers of this very interesting and wonderful conference, Dr. Rutul and Dr. Dharmendra, for having me for this talk today. So today I'm going to discuss gestational diabetes. Where does it come from? Now this is the introduction to the same, and I'm going to keep it brief and to the point. So from this, what I try and understand is we are talking about pathogenesis of gestational diabetes, and that is what I'm going to focus upon. So those who follow me on social media, we have this presentation which we have done, which is called Unifying Theory for the Pathogenesis of Diabetes Mellitus or Hyperglycemia. You can see the QR code. You can use this QR code to see the whole video. But the thesis which we are trying to generate is that while we are trying to divide diabetes mellitus into various subtypes, we are also trying to unify diabetes pathogenesis and try and understand what is the commonality between all these forms of diabetes. So what I believe is that all forms of diabetes or hyperglycemia occurs as a result of an imbalance between insulin production by the beta cells of pancreas and insulin resistance. So let me explain this point further. Right? So you have insulin, you have the insulin production by the beta cells of pancreas. On the other hand, you have insulin resistance. Now, because of obesity or because of ectopic fat deposition, visceral fat, the insulin resistance keeps increasing. But the body doesn't sit quietly. It keeps increasing the insulin production by the beta cell to match for this insulin resistance. But there comes a point of time where the insulin production is not able to match with the insulin resistance, and that is when diabetes occurs. So in all forms of diabetes, this imbalance exists. There is an imbalance between insulin production and insulin resistance. Now in type 1 diabetes, there is very little insulin production. So again, there is this imbalance. So even a slight tip of balance of insulin resistance triggers the onset of type 1 diabetes. Whereas in type 2 diabetes, insulin resistance is the main pathogenesis leading to increased insulin resistance. The body keeps compensating until a point where it cannot compensate any further, and that leads to development of hyperglycemia. So what happens in gestational diabetes? The same thing occurs in gestational diabetes. The patient generally has poor beta cell reserve to start with, but then it is compensated in a non-diabetic state or a non-pregnant state. But in pregnancy, there is increase of insulin resistance. And because of this, the poor beta cell reserve is exposed. So let me explain this point again further. So what happens is in pregnancy, because of various pathogenic factors or various physiological factors, I should say, there is increase of insulin resistance. Pregnancy is a state of increased insulin resistance. But again, in all the women, the beta cell compensates by this by increasing the production of insulin. But in women with poor beta cell reserve, to begin with, in such cases, the beta cell is not able to compensate for the increased insulin resistance, leading to exposure of the same situation, leading to hyperglycemia. This is explained in this cartoon very beautifully. So as you can see, in a normal pregnancy, before pregnancy, there is a compensatory increase of beta cell. During pregnancy, there is increased glucose production and at the same time increased insulin resistance. And after pregnancy, things come back to normal. But in women with gestational diabetes, there is poor beta cell function to begin with, right? And during pregnancy, there is increased insulin resistance, but the beta cell is not able to match up with the increased insulin resistance, leading to gestational diabetes mellitus. This problem often normalizes again after delivery because the insulin resistance immediately after delivery comes down. So this is the process of development of gestational diabetes. Now, what are the factors? So insulin resistance increases during pregnancy in all forms of pregnancy. Why does this happen? Well, there are many theories for this. One is that a hormone called human placental lactogen, it is known to increase insulin resistance. So perhaps this is linked with the increased insulin resistance during pregnancy. It could be because of inflammation. Now there's a concept which is developing, which is known as meta-inflammation. That is inflammation involving all the organs of the body, right? Often associated with obesity and ectopic fat. So it could be meta-inflammation because of maternal obesity, which contributes to this. And then perhaps is the role of TNF alpha. And it is found that higher TNF alpha in pre-pregnancy state is associated with more insulin resistance during pregnancy. So these are all things which contribute to insulin resistance during pregnancy. Of course, the first point is common to all women. This would occur in both obese as well as non-obese women. The other two is associated in obese women who are at a higher risk of developing gestational diabetes. So is this increase in insulin resistance physiological? To a lot of extent, yes. Now remember, in pregnancy, the body is trying to conserve some amount of fuel for the fetus as well. So the increase in insulin resistance is because the body wants to allow more fuel to pass on to the fetus. There is increase in both central, that is at the hepatic level, as well as at the skeletal muscle and adipose tissue level, that is known as peripheral insulin resistance. And overall, it is about 2 to 3 times increased insulin production. So all this is a physiological state, right? So once again, in pregnancy, physiologically, there is physiological increase in insulin resistance. But in normal situation, in normal women, this is compensated by increase in the insulin production by the beta cells. But in women with poor beta cell reserve, if this insulin production does not match the insulin resistance, these women go on to develop gestational diabetes. So what happens to the glucose output during pregnancy? You'll be surprised that in fact the glucose output is also increased during pregnancy, right? There's 30% increase of glucose output in pregnancy. And I'm talking about normal pregnancy. This is mainly driven by the liver. This is what is known as central insulin resistance. But despite this increased basal glucose output, overall the glucose levels are lower because of increased volume or because of increased utilization of the glucose. So overall during pregnancy, there is a state where there is both increase of glucose as well as increase of insulin. So it's a state of insulin resistance as described. So overall, what is the rate limiting step for development of gestational diabetes? Overall, it is the poor baseline beta cell reserve. That is what leads to gestational diabetes. So women with poor baseline beta cell reserve before pregnancy are likely to develop gestational diabetes compared to those women who have good beta cell reserve and can compensate for the increased insulin resistance. So pregnancy is like a stress test for pancreatic beta cell, and this is something which is very important, right? So what it tells us is that this beta cell function is exposed during pregnancy. And the same women are likely to develop diabetes mellitus in future, because in future the beta cell function will keep declining. Even if it does not decline, the insulin resistance may increase because of increased weight gain and obesity at a later date in life. And this would also again lead to diabetes mellitus. So what gestational diabetes does is that it exposes the poor reserve of the beta cell, and that means that these women are likely to develop diabetes mellitus in future as well. So that is something you need to be aware of. So let me summarize what I talked about in this brief presentation. So we said that in mother, there could be pre-pregnancy risk factors like presence of obesity and inflammation and increased TNF alpha. That again, in all pregnancy, there is increased insulin resistance because of human placental lactogen. But if in women with poor beta cell reserve, if there is insufficient insulin production, it ultimately leads to increased endogenous glucose production, increased excessive peripheral insulin resistance, and then role of placenta-related hormone like HPL, which discussed. Overall, this leads to increased glucose production, but reduced glucose uptake, which is the classical sign of insulin resistance. This ultimately leads to hyperglycemia. In a short-term consequence, these women are likely to develop vascular problems like preeclampsia. In a long term, they are likely to develop diabetes mellitus because, like we said, we are exposing the poor beta cell reserve of these women during pregnancy. And to the fetus, there is hyperglycemia and hyperinsulinemia, which lead to macrosomia in a short-term basis. But on a long term, these children are likely to develop obesity and type 2 diabetes. So this was my brief presentation. And again, I thank the organizers for having me for the same. Thank you.
Thank you, Dr. Om Lakhani, sir.
Yeah.
Now I request our next speaker, Dr. Akash Shivhare.
Dr. Raka is there?
Thanks, Dr. Bhupe, Dr. Dharmen Panchal, Dr. Rutul, and Dr. Amit, this is not a triangular connection from Gujarat to Bengal to Chhattisgarh. It's more than that. We know, we know that, and it's a great session that you people are bringing a pregnancy study group in such a national level and international level that we all congratulate you. Before saying anything, because Dr. Om Lakhani has set the tone of the agenda, I'll just share my slides without wasting time. You are visible? My slides are visible to you?
Yes, sir.
Very sorry. So if there is any introduction part or it's over, I have joined late, so I'll go ahead with my talk. Shall I go ahead?
Yes, sir. You can go ahead, sir. It's your introduction has been already given.
Okay. So, friends, Dr. Om Lakhani has very well explained the pathophysiology. I'll try to get an extra mile, and the things which has been said by Dr. Lakhani, I don't want to repeat that. Because gestational diabetes, from where it begins. See, friends, it's a huge burden, and these are the influencing factors that GDM is found higher among. So why and where it begins? It's very common in literates, homemaker, people living in nuclear family, people belonging to middle class, residing in urban area, primies, OBs, and gestational age between 21 to 24 weeks. And the set point is that there is a difference in the balancing act of body between hormones and all. So that's the balance, and we all know that life is totally a balancing act, and these are the physiological changes, and these are the changes in metabolic orchestra, because pregnancy is called a diabetogenic state, and its peak is around 28 to 32 weeks, and the hormonal milieu which it changes behind this whole orchestra is that there is increase in HPL, that is the mechanism of GDM, that is human placental lactogen, and with this cortisol, insulin antagonist, and other things got increased, which further pushes insulin resistance in the body, and glucose crosses the placenta by facilitated diffusion, and fetal blood glucose level closely follow the maternal level. So this is the pathogenesis of GDM. There is this weighing balance, the balance of body, the hormonal balance is totally lost because of going insulin resistance up and insulin secretion down. So this balance is there. Basically handled by our total physiology, and this pregnancy pathophysiology is that glucose is a teratogen at high levels, and it crosses placenta readily while insulin cannot. So there is decreased insulin resistance, increased insulin resistance, decreased insulin secretion, and increased maternal glucose, which further leads to this final complications of GDM. The levels of placental steroid and peptide hormones like estrogen, progesterone, and chorionic somatomamotrophin, HPL, rise linearly throughout the second and third trimesters. And because of these hormones, it confers increased tissue insulin resistance. As their level rises, the demand for early and increased insulin secretion with feeding increasing progressively during pregnancy. So 24-hour mean insulin levels are 50% higher in third trimester. In spite of higher insulin release from the body, the insulin resistance overweighs this balance, and that's why patient is in this diabetogenic state. And this cartoon very well expresses, and this has been explained by Dr. Om Lakhani, so I don't go in this slide, but I'll see the gist of that beta cell undergo hyperplasia and hypertrophy for meeting these metabolic demands of pregnancy. But when this pregnancy phase is over, then it got settles, and this is the classical GDM. But when it continues, then patient turn into type 2 diabetic. But the organs involved, it's not at all a simple uteroplacental axis. Friends, it's more than that. Brain, adipose tissue, liver, gut, placenta, muscle, and these all act in toto. And that's why patients suffer from a long-lasting effects because of insulin resistance, lipolysis, leptin, adiponectin decrease, increase in free fatty acids, and increase in pro-inflammatory cytokines. And Dr. Om Lakhani has very well emphasized on TNF alpha. So these beta cell dysfunction with hyperglycemia continues, and there is a loss of balance. And this all organs act in toto, and they ultimately leads to GDM. So what are the risk factors of GDM? Why some people get GDM and some don't, some metal? What are the maternal characteristics? So each risk factor is either directly or indirectly associated with impaired beta cell function. It can be advanced maternal age, overweight, because advanced age is the criteria, because we are now getting, our girls are more occupied in their careers. So age of marriage is going up and up. So there is advanced maternal age, overweight, obesity, excessive gestational weight gain, westernized diet, ethnicity. Some people are more prone, genetic polymorphism, other diseases like PCOS, intrauterine environment, because low to high birth weight. Family and personal history definitely has a great role because of its genetic polymorphism. So these are the risk factors which further elaborated with associations that there is positive family history of diabetes in parents, having previous birth of an overweight baby of 4 kg or more, previous stillbirth with pancreatic islet hyperplasia, unexplained perinatal loss, polyhydramnios, persistent glycosuria, age I have already told, obesity, PCOS, current use of steroids. Friends, after COVID, we have seen that this steroid has been inadvertently used throughout the globe, and that may be one of the cause that our girls and our females are getting such kind of situations. Essential hypertension or pregnancy-related hypertension, and this vicious cycle of diabetes go on. That's why GDM is taken as a part of vicious cycle of transgeneration obesity and diabetes. These GDM patients, when they go ahead in their life span, then there is a huge effect either in the infant or in the youth part, because this GDM, uncompensated insulin resistance, and this pancreatic beta cell dysfunction risk is increasing the risk of type 2 diabetes in the future. Controlled hyperglycemia in pregnancy will have a better effect, because there is an epigenetic and genetic predisposition to diabetes and obesity. So these are the long-lasting effect of GDM, and I'll conclude my session with this paper abstract, which very well say, published in elsewhere, that this gestational diabetes has a linking epidemiology, excessive gestational weight, adverse pregnancy outcomes, and future metabolic syndrome. These are the very well having a cross-linking association, and the diagnosis of GDM is expected to continue to rise, because GDM unmasks a beta cell defect that persists after pregnancy and typically worsens over time, imparting the increased risk of type 2 diabetes after the index pregnancy. In addition, coexisting obesity and progressive weight gain are the additive factors for progression of type 2 diabetes. So obstetricians, our GDM group, our PSG group, our RSSDI group, and all physicians should play an integrated role in informing GDM women. And it's prudent to talk in this platform about such a devastating effect, where we have to take care of two of the lives, where mother and the fetus and our future population. So while tackling the GDM, we are tackling whole our population. So that's, friends, it's a great talk. And it's a great time to share with you all. Thanks all.
Thank you, Dr. Raka, for this wonderful presentation. And I think presentation was very crystal clear regarding how the GDM pathophysiology and all these things. And if there are any questions, chairperson, are there any questions?
Dr. Om has also joined.
Om is there.
Yeah.
Sorry, I'm on the.
Hello, Dr.
Traveling a little.
Yes, you're audible.
Yeah, so I'm traveling, so I thought, I'll send the presentation over. But we'll be happy to take any questions if, network permits.
Right, sir. Hello.
Chairpersons, are there any questions so that
First of all, the both lecture were very nice and clear. I think the both speaker have explained of the pathophysiology of GDM and the risk factor and how it goes from generation to generation. So the importance of controlling this GDM, they have explained us very well. I think we don't have any questions in the chat box. Dr. Kalpesh Kawar, if you have any question, you
No,
can
we can.
ask.
No, we can move further. The stage is well set by wonderfully explained pathophysiology of GDM by both of the wonderful dynamic speakers. So I think we can move further.
one line I would like to add from the both speakers. I think the Dr. Om Lakhani's presentation, the take-home message was pregnancy is really a stress for the pancreas. So that is, I think, one line summary for the pathophysiology of the GDM.
Yes.
Right.
Thank you. Right. We can move to the next session. Chairpersons, please, because I'm traveling, I will not be able to probably read. So
Thanks to all, Ami, Shefali, Vitrag, everybody, Om, Ashwin. I can see you every smiling face at this afternoon. And thanks to
Good
PSG,
to see you, Dr. Raka.
PSG, Rutul, Panchal, and G is for what? Amit. Amit G. Thank you.
Thank you. And we will move for the next session. And for the next session, we'd like to invite the chairpersons, Dr. Vitrag Shah and Dr. Ashwin Mukundan. Over to you, respected chairpersons, Dr. Vitrag and Dr. Ashwin.
Very good afternoon. I hope I'm audible well.
Yes,
I would like to carry forward the session further without wasting much time. The topic for the next session is the exercise. What are the practical advice that we are giving to the patients? So our first speaker is Dr. Ami Sanghvi. She is MBBS consultant diabetologist. She's a director and consultant diabetologist at Sanghvi Eye and Diabetes Care Center, Mumbai. Please, over to you, Dr. Ami, madam.
Ami, you're on mute.
Very good afternoon to everyone present here. A big thank you to Team PSG, Dr. Rutul, Dr. Dharmendra, Dr. Amit, Dr. Shalini for having us today. I mean, what bigger, what good thing, speaking with your closest friend on the same platform, I'll be talking with Dr. Shefali, and we are going to be having kind of a duologue. So it's not that my presentation is separate and hers is separate. We'll start sharing the slides and we'll present as a duologue from our end.
Yeah.
So, Shefali.
I echo Ami's words. It's an absolute honor to be here. Thank you, everyone, and including Dr. Rutul, Dr. Shalini, Dr. Dharmendra, everyone. And as Ami said, it's an absolute pleasure sharing the stage with her. So, if you permit me, shall I share the screen? Okay. Am I visible?
Yeah.
Perfect. Go ahead, Ami.
Go to the slideshow. Yeah. So the topic given to us today, would I in fact thank the organizers for giving such a wonderful topic on exercise prescription in gestational diabetes. Shefali, next slide. Gone are the days, when even when I remember I was pregnant with my son 16 plus years back, they used to tell us that keep working till the last day of pregnancy. But now what I have seen is scenarios have changed. Females who are getting pregnant now, they like to rest more, they like to pamper themselves more. No harm in doing that. But then there are, you have to keep yourself active. And how do we do that is what me and Shefali are going to be discussing today in this next 20-25 minutes. So what about gestational diabetes? It represents a state of chronic beta cell dysfunction in the face of insulin resistance. Insulin resistance and insulin levels are different prior to pregnancy in women who develop gestational diabetes and those who do not. And that was described by Dr. Om too a while back. Changes in insulin sensitivity are similar in both groups during pregnancy. However, in gestational diabetes, women, the insulin secretion does not increase adequately. Next slide. So the risk factors have already been enumerated in the previous presentations, but let's kind of divide the risk factors into modifiable and non-modifiable. So when we talk about the modifiable one, which are in our hands, we can be taking care of our nutrition, diet, so that we look at our obesity and overweight section, and exercise more. Sedentary lifestyle can be a risk factor. Hypertension can be a risk factor. Whereas non-modifiable, ethnicity, greater maternal age, which we are seeing quite often now, history of gestational diabetes, PCOS, family history of hyperglycemia, and pregnancy-induced hypertension would be the non-modifiable risk factors. Next. So taking care of gestational diabetes is not taking care of only the diet or exercise. It comes as a combo of everything. So diet, exercise, fetal health evaluation, pharmacological treatment, and above all, maternal education all play an important role. What we are going to be focusing is on exercise. So strong mamas definitely bring up stronger babies. And I'm sure when the babies grow up, they would love to say, my mama's strongest. So for that, lifestyle management in GDM is an important factor. Next slide. So when we talk about exercise, what is the role of exercise? When we are asking you to keep going, keep on doing it, keep yourself moving, we are helping you because it compensates for defects in the insulin signaling pathway, reduces the inflammatory state, changes the adipokine profile, upregulates the antioxidative capacity. Next. So it definitely helps. And exercise may be a non-invasive therapeutic option for preventing and managing gestational diabetes that can be readily applied to the antenatal population. Next.
I absolutely agree. A woman really spends 9 months preparing to fall in love for a lifetime. And this 9 months are not easy for her because there are a lot of changes, physiological changes that take place in the body during pregnancy. And that is the reason why we have to be so cautious when you're prescribing an exercise therapy to a pregnant lady. Now, pregnancy hormones will cause relaxation of ligaments which are supporting the joints. Therefore, the stability of the joint lessens. So any kind of jerky movements, high impact movements will cause an added injury to the joints as well. Plus, of course, the baby is growing, the female is growing in size, and the center of gravity then shifts forward. Because of this, there is a little bit of imbalance, especially in jerky movements when the lady is in the last trimester. So shift in the center of gravity along with the laxity of joints makes her more prone to fall. And of course, we know what happens when the pregnant lady has a fall. Similarly, pregnancy is an ever increasing demand of the body, so whether it's micronutrients, whether it is water, whether it is oxygen, whether it is blood supply. So when you start exercising, you're actually directing the oxygen in the blood supply to your muscles and away from the rest of the body. But in pregnancy, this demand supply ratio is kind of, they're fighting with each other. And that is where we have to draw a line and we have to demarcate as to how much can we sacrifice for an exercise and how much is an essentiality for the pregnancy to grow properly. But there are definite benefits of the fetus, benefits to the fetus as well as the infant when you start exercising. So the fetuses will be of a normal weight. So the lesser chances of having a high birth weight or a macrosomia in a GDM patients. There is a lower risk of preterm births as far as the fetus is concerned. If you talk about the placenta, there is increase in the placental viability and the volume. There is increase in the placental growth. The vascular function, which we are so concerned about in GDM, is much better when you have an exercising gestational diabetic patient. The neurodevelopment of the fetus is much better, and it translates into infants having a higher behavioral regulatory ability and orientation as compared to a fetus born to a non-exercising pregnant lady. Similarly, if you talk about the body fat, At the age of 5, children who of the mothers who've been exercising throughout the pregnancy have much lesser body fat as compared to the counterparts, and their language skills, the oral intelligence, all of this is much better when you are having an exercising mother. So, if you talk about the role of exercise in GDM, we know that every kind of diabetic will benefit from exercise. That is, there is no question about that. But there are no current GDM specific guidelines which are available for exercises. But what they say is we need not exercise any extra precautions as far as an exercise regime is concerned, except for hyperglycemia and hypoglycemia, which we'll discuss it in the later slides. If you talk about exercise regime as to be prescribed for the patient, I think obstetrician, the diabetologist, and the physical therapist should come together to formulate a plan. And the plan should be based on the FIT principles of exercise. FIT means frequency, intensity, time, and time.
So exactly, as Dr. Shefali mentioned, that we're looking at the FIT principles. When we talk about the guidelines, how much should be exercise, or what type, or how long, there are no particular guidelines which are talking about the exercise, but there have been recommendations, a few recommendations of how, each part of the FIT formula can be used in a patients with gestational diabetes. Next slide. Shefali?
Yeah, just a second. It's not somehow. Yeah.
So when we go to the next slide, please.
Yeah. Sorry.
No worries.
Is it sharing?
I think we went back. So when we talk about the general guidelines, I'll just start talking. And when we talk about the general guidelines, they say that, the previous slide, they say that you should always start in consultation with your doctor. So ideally, you should be taking an exercise physiologist, which may be difficult in our scenarios, but especially women who have not been, active, who have been previously sedentary before the pregnancy, especially those females should be consulting their medical practitioner of what type of exercise would suit them during the pregnancy. Next slide. And any exercise regimen which starts, we always, be it a gestational, be it a non-diabetic, anyone, you should always start with a warm-up exercise. So warm-up should be, say, around 5 to 10 minutes with a low to moderate intensity aerobic exercise, which would kind of increase the body temperature and reduce the post-exercise muscle soreness and stiffness. This will also, help the body to gradually adjust to the meet of bioenergetics and biomechanical demands of the working component. Again, as warm-up exercise is important, also post-exercise cool down is recommended. Hydration is also important around that part. So if vigorous exercise is performed, especially you have to have a cool down part to reduce the risk of vasovagal response, which can lead to a syncope. Next slide. Now coming to the first part of FIT, the frequency. So when prescribing exercise, you have to take into consideration the women's previous physical activity, the cardiorespiratory fitness, and the strength. So especially for women who have previously been sedentary, it is especially advisable that they avoid exercise in the first trimester and start in the second trimester, by which time their morning sickness, the nausea, fatigue would have settled down and they can get into an exercise routine. Next slide. Also, female who have been having little physical activity should ideally start with 15 minutes of continuous aerobic exercises, say thrice a week, then gradually increase to 30 minutes, say at least 4 to 5 times a week. There is no upper limit recommendation for the time spent in aerobic exercise, but the ACOG advises against exercising for more than 45 minutes continually because of the risk of increased fetal temperature. Next slide.
So we know about the frequency, we know about the timing, but what about the intensity? So the majority of the guidelines, including the ACOG, recommends a moderate intensity aerobic exercises for most of the pregnant ladies. And some patients also do a high intensity short duration interval training. it's the studies haven't shown any kind of adverse effects, but generally, at least I do not advise my patients to do a high intensity exercise as such. But having said that, even a low intensity exercise like yoga and Tai Chi has shown a beneficial effect in both the baby as well as the mother. There is an elevation of mood, there is improvement of the mood, there is increased balance, the lower back pain comes down, the urinary incontinence comes down. So Tai Chi and yoga do have a place in exercise schedule of our patients. What we need to do while when you determine the intensity is first assess the cardiorespiratory fitness of the patient. Now we have to, as Ami has said, we have to find out if the patient is actually exercising and what intensity exercises was she doing pre pregnancy, and then modify it so that it fits her duration during her duration of pregnancy. But as I said, moderate aerobic exercises like walking, jogging, running, these are the ones which are highly recommended. Again, use a heart rate as a guide to see how much intensity exercises you can do. So in during a non-pregnant state, your heart rate can increase to up to 140, 150, 160, which is acceptable. However, during pregnancy, we ideally should have the heart rate of not more than 120 to 125. So the intensity, the best guide to intensity, especially in the era of Fitbits, is to make sure that your heart rate is not accelerating to a point where you cannot, where it is going beyond the control. The other way is, of course, the Borges modified rate of perceived exertion scale. But we also have to remember that as the lady goes bigger, as the pregnancy increases or the duration increases, the intensity of the exercises must come down. So as Ami has rightly mentioned, start with about 30 minutes of exercise at an intensity of about 12 to 14 on the scale of 6 to 20. And if the intensity as the pregnancy advances should reduce, a moderate intensity training is very appropriate for most of the patients, especially the GDM patients. But high intensity resistant training should definitely be avoided because it can increase the chances of urinary incontinence or increase the chances of falls because there's a laxity of the joints. Also, there is a chance of hypovolemia or a hypotension occurring in the patients, or it can also induce Valsalva maneuvers, which puts both the mother and the baby at risk.
Yeah. Shefali?
Yeah.
Yeah. So about the time of exercise, we have all. Are you taking up time?
Yeah. I can't see the timer, but yeah, go ahead.
Yes, you are on time.
Okay.
You're on time. Yes.
Yeah.
Can I go ahead, Shefali?
Yes, please go ahead.
Yeah. Okay. So a variety of exercises ranging from low exerting forces such as, yoga, Tai Chi, already Shefali has mentioned. These exercises do help. Recreational physical activities encourage and has been shown to improve general well-being and the pregnancy outcomes. Now, the programmed exercise is very important as it helps in, to aid in vital and glucose control for our women in gestational diabetes. Exercise guidelines suggest aerobic exercise, to some extent resistance strength training also. They say a combination of both works really well. So, some amount of aerobic exercise because it increases insulin sensitivity, and resistance strength training because increases the muscle mass. So overall, it both helps in increasing the glucose uptake. So both are helpful. Pelvic floor exercises and hydrotherapy have been recommended initially in the later half because, they help improve the muscle tone, the fitness, and help in reducing the peripheral edema. Women who regularly exercise during pregnancy have more positive pregnancy outcomes and fewer negative adverse events. Next slide. So this is what we were talking about, the type of exercise. The exercise guidelines for pregnant ladies, they say that you can prescribe aerobic exercise, which is any activity which would use the large muscle groups in a continuous rhythmic manner, like walking, jogging, aerobic dance, swimming, hydrotherapy exercise, aerobics, rope climb, skipping, hiking, rowing. And to a lesser extent, maybe a prescription of resistance strength training. Next slide. Resistance strength training can also be given. So as a combination of both, it really works well. Although the major societies have recommended the use of resistance training for pregnant women, they are yet to give us any specific guidelines for practice to be prescribed in our patients who have GDM. Next slide. Now, pelvic floor exercises are also shown to reduce incontinence and bladder weakness, which may be seen after pregnancy. And the ACOG reports hydrotherapy, which is one of the most in thing right now, is considered safe during pregnancy because of the potential to improve the positive outcomes and pregnancy management. It helps to improve the fitness of the patient and reduce the peripheral edema. Next slide. So Shipali, what do you think? What would the exercise prescription overview look like?
I think what you've said is summed it up beautifully, because the FIT program gives you an idea as to how you should proceed with a GDM patient who must exercise, but it must be an exercise tailor-made to the patient. So overall, and as you said rightly, a moderate intensity exercise with an involving a large muscle activity in a rhythmic manner, like walking or running or static cycling. I will not put it as cycling, especially on our roads, but at least static cycling will be a good way to tone up the muscles. Similarly, resistance of a low to moderate grade should also help. And as you said, hydrotherapy and Tai Chi and yoga will also benefit our patients. But we must remember that there are some safety tips that we have to caution, we have to use in our patients. So first thing, high impact or high physical contact exercises should be avoided, like water skiing or horse riding. Thankfully, water skiing and skiing is not there so much in India. But we should avoid things which can cause a fall. Second, and more importantly in our country, is we should avoid exercising in very hot climates, especially humid climates like Bombay and Mumbai. So in this kind of climate, there is a definite chance of the patient going into dehydration, and this dehydration can lead to hypotension. Now, the growing fetus, as you rightly said, cannot regulate its temperature in the first trimester, and therefore, if the temperature of the patient goes very high, then the fetus is also exposed to a higher temperature. Having said that, you can do the same exercises in a controlled environment like an AC room. That will definitely benefit both the fetus as well as the mom. Avoid holding your breath, the pranayam, etc., to a long extent. You should avoid that also because it will give extra stress to your pelvic floor. We do not want anything to harm the baby. Avoid lying on the back, especially in the second and the third trimester, because again, that can lead to a problem. Any exercise in which you're standing or sitting in one position for a long time should be avoided. It may lower the blood pressure, it can cause muscle cramps, and it can lead to a lot of other problems as well. Rapid change in movement, wherever it is involved, should be avoided again, because bouncing methods, rapid change in direction, all of this can again accelerate injury to the joints, as well as make the person lose the balance, and this can result in fall as well. One-sided exercises like walking, lunges, or single step up in the third trimester should be again avoided. Most importantly, I think every woman, I'm sure all of us, all the women who have been pregnant know this, that the level of intuition is very high during pregnancy, and it's time that we ask the patient to listen to their body. If it feels good, do it. If it doesn't feel good, you have to stop, no matter what the physical trainer says. Again, most important, do not exert yourself, because you may need to slow down as your pregnancy progresses. Have a good team of your doctor, your diabetologist, as well as your obstetrician and your physical trainer to formulate a good plan. As a general rule, if you want to know the intensity of the exercise, one is the heart rate, which should not go beyond 120, 125. And second, you should be able to hold a conversation when you exercise. If you become breathless when you talk, or if you cannot utter more than 2-3 words, that means you're exercising too strenuously and you need to cut it down. If you were not active before you got pregnant, don't take up sudden strenuous exercises for 45 minutes, etc. You can start slow, as Dr. Ami has said, and then increase the intensity as well as the duration. Increase it gradually to about 3 times in a week. If you have time, you can do split sessions like 30 minutes in the morning and 30 minutes in the night, which will help again. Remember, exercise does not have to be strenuous to be beneficial. Any kind of exercise, if you have any kind of symptoms like vaginal bleeding, dizziness, headache, or preterm labor, amniotic fluid leakage, all of these things, definitely you have to stop the exercise immediately. The gynecologist or the obstetrician will probably put you on bed rest any which way. But in order to ensure that you have a good, healthy, pregnancy, you should exercise if it is possible. Take advice and then exercise. If you are having any kind of problems, you have to tell the patient that you come back to me, let me know, and then we can work on it together. Of course, if there has to be a support system as well. The pregnant lady cannot do running or jogging alone on a treadmill when in the house when she's all alone, because if she has any complications, there should be somebody else to help her out as well. Drink plenty of water before, during, and after your workout. This is the most important thing. Signs of dehydration include dizziness, a racing or a pounding heart, or urination of small amounts of concentrated urine. All of these are signs of dehydration, and dehydration will have an adverse effect on both the baby and the child. Wear a sports bra, wear loose clothing, cotton clothing if possible. Use a belly support belt in case of the 3rd trimester, so that when you're walking or running, you're comfortable. Avoid becoming overheated. So have a temperature controlled room. Exercise with the AC on at a comfortable room temperature. Remember, you don't need to sweat to get the benefits of exercise. What you need to do is you need to listen to your body. As I said, avoid standing still or in any one position for a long time. Avoid lying flat on the back, and do not try and overexert yourself at any point. Now, if you come to gestational diabetes, the most important complication that we face when the patient starts exercising is hypoglycemia. So when the patient is going to go on an exercise regime, we need to advise the patient about how she'll feel when she gets hypoglycemic. Secondly, we need to control and alter our doses of insulin such that she does not fall into hypoglycemia. Of course, she can do self-monitoring of blood glucose, and the physician can be consulted depending upon how it goes. AGP or a CGM is a wonderful tool at our disposal, but if the patient is not willing for that, ask her to take the pre-exercise level blood sugars, and if it is low, then you should have a carbohydrate snack before you even think about exercising, is what should be told. In case of hypoglycemia, treat fast so that the patient does not stay in a hypoglycemic episode for a longer period of time. There is, if the patient is recurrently having fluctuations in the blood sugar, then maybe you can time the exercise schedule such that she is in the postprandial level when she is going to do an exercise. But of course, we cannot have a good intensity exercise after meal.
So, not all patients are advised to exercise. There are some contraindications. Some are absolute contraindications, some are relative ones. So what are the absolute ones is restrictive lung disease, rupture membranes, preeclampsia, pregnancy-induced hypertension, or premature labor, placenta previa, incomplete cervix or cerclage has been done, hemodynamically significant heart disease, or high-order multiple gestation, maybe more than or equal to triplets. There are also relative contraindications where the patient has to understand that if they need to exercise, they have to go slow. If there is a patient is a heavy smoker or history of extremely sedentary lifestyle, orthopedic complications, extreme obesity, now patient is very underweight, poorly controlled type 1 diabetes, and this is a whole list. There is seizure disorder, hyperthyroidism, anemia, twin pregnancy after 28 weeks. So always, as Dr. Shefali also mentioned, always plan your exercise in consultation with your gynecologist, your diabetic physician, and if an exercise physiologist available on board. Next slide. So summarizing, all pregnant women should engage in physical activity and may benefit from planned and programmed exercise. Women with gestational diabetes have extra physiological changes when left unattended to have the potential to increase negative pregnancy outcomes for both mother and child. When used effectively, exercise can be a correct tool for treatment as part of the continuum of care for women with gestational. General guidelines encourage these women to engage in moderate intensity aerobic and strength training along with the recreational physical activity. Exercise programs should be tailored by appropriately trained and qualified individuals. I would just sum up in one line. Always advise your patient. Next slide. Listen to the body. Do not overdo anything. Be it exercise or be it rest, go in the right way. The best way to keep your baby healthy is to keep yourself healthy and happy. Thank you all for your patient hearing.
Thank you.
so
Thank
much.
you. Yeah. Thank you, Dr. Ami and Dr. Shefali, for this extensive exercise on the exercise prescription in the GDM. I think the message was very much clear that the moderate intensity exercise should be advised to the GDM female, but with some precautions, and there are few contraindications for the exercise, and it should be always in consensus with the obstetrician. So, chairpersons, do we have any questions on this very interesting topic? So we can flash that questions.
I cannot see any questions in the chat box, sir. I would like to add excellent coordination between the both speakers. We didn't feel the change in between actually. I was wondering whether it's the same person talking in a different voice. That's how coordinated they were.
Thank you.
They have exercised a lot to prescribe
Yes.
exercise
Yes,
in the
true,
GDM.
true.
Close to you guys.
I would like to add, I ask one thing, Dr. Ami madam. By this time, the pre-conceptional counseling is also that much important. So once it is GDM that we are going to treat, we are going to manage. But what is the role of exercise in regular life that reduces the risk of development of GDM? So what are your thoughts on that?
So I think, exercise is required for everyone. Be it a gestational, be it a non-gestational, be it a diabetic, be it a non-diabetic. Everyone should exercise ideally for 30 to 40 minutes a day, at least 5 times a week. That will, if you are having any family history, it will help you not to progress to the next stage. If you are not having any diseases, it will help you to prevent having any diseases. And if you have any, it will help you to not further go into that disease. So I think, Dr. Vitrag, you have written it out pointedly. The message is loud and clear. If you do not have any complications or comorbidities which are stopping you from exercising, exercise should be a part of our daily routine. As we eat, we need to exercise.
Yes, thank you, madam.
Thank you.
One question to
we are on
Shefali,
time.
madam.
Maybe.
We are a bit late.
Okay. Maybe we can move on
One
to
question.
the next.
Yeah. So thank you, esteemed speakers and chairpersons. And I would like to thank Dr. Rutul, Dr. Amit, and Dr. Dharmen for giving me this opportunity. And thank you all the chairpersons and audience also for being here. Thank you.
Thank you very
Dr.
much.
Jaideep,
Thank you,
and
everyone.
all esteemed speakers and our chairpersons. Now we would like to move ahead for the next session, and we have our moderator here, Dr. Yusuf Khan. Dr. Yusuf Khan, over to you, sir. He's from Hyderabad.
A very good afternoon to everyone. First of all, I would like to congratulate Dr. Rutul Goklani and the entire PSG 2022 team for organizing such a elaborate, discussion on GDM, first of its kind, I would say. And in the previous sessions, we have seen discussions on pathogenesis of GDM and the lifestyle modification part of the GDM. Moving ahead in this session, we'll be looking at the medical management of GDM and pre-GDM. And to chair the session, it's my pleasure to invite Dr. Akash Patel and Dr. Aniket Inamdar. Over to you, Dr. Akash and Dr. Aniket.
I really thank PSG team for inviting me for this great, wonderful conference on especially GDM and its various aspects, and to tackle each and everything in a very detailed and exclusive manner. So this is again an interesting topic about the management of GDM and pre-GDM. Again, we are going into the prevention and how we can prevent those having pre-GDM going into the GDM, and how we can manage them in a very great manner. So for this, we have a great speaker, Dr. Beni Neglu, ma'am. May I introduce her?
Yes, please, please.
Yeah, actually, Dr. Beni, ma'am, she doesn't need any introduction, but it's my privilege to introduce her. She is a director of Dr. Neglu's Diabetes and Thyroid Specialties Center, and she is a consultant diabetologist at Jupiter Hospital, Thane. She's a fellow of American College of Cardiology, Diabetes India, fellow of American College of Physicians and Indian College of Physicians. She is a teaching faculty for fellowship in diabetes at D.Y. Patil University and also at Public Health Foundation of India. She's a founder, president, and organizing chairperson of the WODCON, Women and Diabetes Conference, since last 5 years. And actually, this is one of the best conferences that are organized, especially in this particular area of women and diabetes. So it's a wonderful conference, and Madam is a founder president of this particular conference. And she's a founder and executive committee member of the Association of Diabetes Educators of India since 2006. She's editor of Awakening Diabetes newsletter for the patient education. And she's ex-professor in the Department of Medicine at the Terna Medical College. And she's a speaker at various regional and national conferences in diabetes. It's our privilege to introduce you, ma'am, and over to Beni Neglu, ma'am.
Thank you so much, Aniket. And first of all, let me congratulate the trio. Yes, Dr. Rutul, Dr. Amit, Dr. Panchal, and the entire team. Shalini, my friend, is also there in this.
Mane, can you share me the whole B link? How can I join the whole B in this PSG?
Is there any disturbance here? Hello? Hello?
Yeah, ma'am, you go ahead, please.
Yeah, and and let me congratulate the PSG group because they are not only taking care of the mothers, but the future generation as well. Now, this session is about management. So for the first half, management of pre-GDM will be taken by me, and my good friend, Dr. Abhi Chandani, will take the second half of management in GDM. So just to go back to the basics here, hyperglycemia in pregnancy could be pre-existing diabetes or it could be gestational diabetes. Pre-existing diabetes can be seen in women with type 1 diabetes or type 2 diabetes, or they may be also having pre-GDM in the previous pregnancy and have then become diabetic in their second pregnancy, just towards the second pregnancy. And they could be on OHA, insulin, or on the treatment that is given to in classical treatment in diabetes. And gestational diabetes is a true diabetes, or the classical diabetes, which happens in the 24 to 28 weeks of pregnancy, but it is a dysglycemia at any time during pregnancy, which could be due to pre-existing diabetes, and that dysglycemia could be seen in the first or the second trimester. Just to reiterate that in India, we are seeing dysglycemia in a non-diabetic patient in the first trimester itself, and this has also been shown by DIPSI. To go forward, I'll take these two cases. I'll just give you the history of a 34-year-old obese lady with type 2 diabetes. She presents for follow-up visit. Her blood sugar has been well controlled on metformin. She wants to have a baby now and wants to know if there's any special thing to do that her diabetes will not affect her pregnancy. So what should we advise her, and what about her anti-diabetic medications? So you see, first of all, this is a 34-year-old and she is becoming, she wants to get pregnant, which goes to show that now the age of diabetes is coming down. That is, younger and younger people are getting diabetes, and the age of gestation is going up. So, you know, women used to get pregnant at 19, 20, below the age of 25, and now they're having their first pregnancy after the age of 30 and maybe even 40. So this is clashing, and so we need to have pre-pregnancy planning for these women. Let's see how we advise her. We will see subsequently. Here there's another lady, 26 years of age, known to have type 1 diabetes for the past 13 years. And she comes for pre-pregnancy guidance. What relevant history would you like to elicit, and how should we counsel her? Let's see, we'll start from here. First of all, why do we require pre-pregnancy planning? It's a good thing that both these women came to us for consultation. This is not the scenario in the OPD practice. Only 10% of women come for pre-pregnancy planning. The rest of them actually come after they get pregnant. And you will see the data here globally, 26% of the pregnancies are unplanned. And in India, 90% of the pregnancies are accidental. So we need to advise them when they come in the diabetic stage itself. As soon as you see a young girl who is in the reproductive age, which could be anywhere between menarche towards menopause, then we have to ask whether they are likely to get pregnant in the future, and therefore they should take pre-pregnancy planning for pregnancy. They might come to us for obesity, and they come to us for PCOS. At this stage only, we should alert them. So the relationship between hyperglycemia and pregnancy and adverse perinatal outcomes is known to everyone. Early in pregnancy, there's a risk of miscarriage. There's a greater likelihood of the fetus having congenital malformations. And later in pregnancy, they might get preeclampsia, preterm induction of labor, cesarean section, and delivery complications. So I won't elaborate on all of those. And babies born to type 1 diabetic mothers have a significantly higher rate of being large for gestational age, macrosomia, which is a birth weight more than 400, and neonatal hypoglycemia. So pre-pregnancy planning is required, and therefore we need to optimize the glycemic control before conception, all through conception, and then postpartum to reduce all these risks. So when the woman comes in front, we have to offer information, because they may not even know what the risks are and how much should be their target control of glycemia. You just heard a whole talk on exercise. What about the weight? We need to offer them the care that they require and advise them that they need to plan to become pregnant. And they should start from adolescent and ongoing at every visit. We need to optimize their glycemic control the day they come and meet you, as in these two patients. So the initial discussion should be on the role of diet. And diet, as we know, is medical nutrition therapy. Since I'm discussing pre-GDM, hopefully I think all the patients know about diet, but then you have to also reinforce and recall their diet to see whether they are on the right path. And if they are uncontrolled, I'm sure, I mean, you can see our Indian patient making, you tell them, you know, please stop sugar, jaggery. No, but my neighbor told me that jaggery can be eaten. You know, they all know that they should not, but still they say. So you have to reinforce that diet. And once they become pregnant, it's like treating our type 1 patients. You need to split the meals so that the mother doesn't become hypoglycemic. At the same time, you can give multiple doses of insulin for their rising sugars. Body weight correction is essential prior to pregnancy. Pregnancy is not the time to reduce weight, and therefore, if the woman is not close to the ideal body weight, which you will see that they are not, because you see, ours is the largest childhood obesity in the world, and all our women who are getting pregnant are all overweight. So we have to emphasize the need of weight reduction and exercise and diet to achieve a BMI of less than 25 if possible, or close to that. Review all the medications. So, it's not only diabetic medications, OHAs and insulin, but also the other medication. They may be taking thyroid medication. They might also be taking anti-psychological medication, which most of the youngsters are taking now. Also review whether they are smokers, whether they are on narcotic use. So we need to and too much of alcohol. So we need to actually tell them that this could be bad for their pregnancy. Look at the risks of hypoglycemia and hypoglycemia unawareness. This is especially applicable to type 1 patients because they are the ones who go into repeated hypoglycemia, and therefore we have to see that their glycemic variability is not too high. Talk about nausea and vomiting that can happen in pregnancy, and that can disturb their glycemic control and the risk of having large for gestational weight babies, and also the likelihood of birth trauma, induction of labor, and cesarean section. Neonatal hypoglycemia can be a risk, and therefore they need to feed the baby as early as possible. But I think the most important thing that we need to emphasize is the monitoring, because I have seen in my many years of practice, not only in GDM and pre-GDM, but in general diabetic patients, that those who monitor their sugars are the ones who are best controlled. And if they have not been monitoring, we have to initiate this monitoring in the pre-gestational planning period and explain to them that the monitoring will have to increase in frequency when they get pregnant. So this is the target blood sugar. It is just like a non-pregnant state. So you see A1C less than 7. The ideal A1C, they should be to plan pregnancy should be less than 6.5. But we have to weigh the pros. We have to see whether they don't go into hypoglycemia, look at their comorbidities, and also if they are older diabetics and also older in age, we have to see the risks and benefit. But at all times, the A1C has to be below 7. The greater the A1C beyond 7, you see there's a steep linear curve for congenital abnormalities. The fasting plasma glucose should be between 80 to 130, and the PP should be less than 80. And of course, you need to have less stringent glycemic goals for individual patient appropriately. But once they get pregnant, of course, the goal of target blood sugar control is very, very stringent. So fasting 70 to 95. Dr. Abhichandani will tell you about this. But why I kept this slide is that nowadays we do CGMS, and we need to also talk about glycemic variability, which is very important since it increases this oxidant stress, and that can be detrimental to the fetal. So those who are going for CGMS before pregnancy, if they are not, then we should insist as much as possible, if the patient can afford, that their TIR should be more than 70, TBR should be less than 4%, and the time above range should be less than 15% as much as possible in both type 1 and type 2 diabetes. And not only that, sometimes we need to modify the maternal factors, and we have to target the individual factors, not only glycemia, but also the glycemic variability. And that's where the CGMS comes in. We have to reduce the frequent excursions in blood glucose. Look at the maternal obesity. Losing weight before pregnancy is desired, a BMI less than 25. A gestational weight gain throughout pregnancy should be minimized, and this is in line with the Institute of Medicine guidelines. Dr. Abhichandani will also tell you about this. And the maternal lipids, especially the maternal triglyceride, which rise when the sugars rise, these levels should be brought down by dietary manipulation. And you can see this bar diagram here. The major congenital malformation, stillbirth, neonatal mortality, and perinatal mortality all are high in pre-GDM women who get pregnant if their sugars are not controlled. But fortunately, with organized management and strict blood sugar control, a healthy pregnancy is achievable. And also you can still have a healthy baby. Educate and obtain maximum cooperation from both the partners. I remember, say, 30 years ago, 20 years ago, the lady used to come with the mother and mother-in-law. But nowadays, you see, it's always the husband and the wife who go for pre-pregnancy planning. Even in my otherwise diabetic practice, I always see husband and wife, which is a good thing, because both the partners are getting educated and they can help the mother to have a good pregnancy and a healthy baby. So optimize blood glucose to less than 6.5. Look for the thyroid function. The TSH has to be less than 2.5 in women who have hypothyroid. And PPA antibodies may be required, but of course it is not going to change the line of treatment. However, if there are any abnormalities, we can, kind of say your antibodies are also high at this time, but at all times keep their thyroid function, T3, T4, and TSH in the range, in the target range. If they are hyperthyroid, I think we have to give minimum drugs, minimum medication to these patients, and plan the pregnancy when the medication of hypothyroid is come to the minimum. Check for the immune status, especially the rubella. Also encourage the other team members, the obstetrician, diabetic educator, nutritionist, all of them should be on the same page. If the lady is on OADs, we have to switch them over to insulin if pregnancy is planned. Optimize the blood pressure. We often tend to neglect this. And of course, you have to stop the ACE and the ARBs. You can put them on better drugs, which are congenial for pregnancy. Methyl dopa, labetalol is the drug of choice. Amlodipine, nifedipine can be given. Stop the statins, and folic acid is advised 3 months prior to pregnancy. It is important to look for comorbidities, and amongst them, the PDR and NPDR, or the fundus examination, is very, very vital. If they have an early PDR, it is better to do an intervention before they get pregnant, because during pregnancy, you see there is growth of these blood vessels in the retina that could have a very rapid progression to PDR. And also with the expulsive nature of delivery, these can rupture and give rise to retinal hemorrhages. At every stage in pregnancy, every trimester, this a fundal examination has to be done. Look also at the other comorbidities, whether they have gastroparesis, whether they have neuropathy, whether they have ischemic heart disease. Most women with pre-existing diabetes will need to be on basal bolus insulin protocol in pregnancy. That is the standard of care. A premix insulin can be given when it is convenient, but it is not the ideal way to treat. It is best to give a basal bolus, and sometimes you need to give an extra dose of insulin. But of course, you have to customize it to the patient. Insulin does not cross the placenta. It is safe, effective, and time-tested. It has to be individualized. All human insulin, regular insulin, NPH are safe in pregnancy. Insulin Aspart and Lispro are approved in pregnancy, but there is insufficient data on glulysin. Detamir, which is a basal insulin, is approved by the FDA. Glargine is now found to be safe in pregnancy. Those who are already on glargine, you need not take this basal insulin off. You can continue the glargine also during pregnancy. But insulin degludec the data is not yet there now for use in pregnancy. Both multiple dose insulin and the CGI pumps. The pumps are also reasonable delivery strategies, but neither has been shown to be superior to the other during pregnancy. One must beware when the pump is being used, because there could be pump failure or tubal blockage or give rise to DKA. This is just one slide I wanted to add, potential contraindications to pregnancy, because we are seeing the woman in the pre-gestational period. So ischemic heart disease, heart failure, and heart cardiomyopathy, these can be contraindications. Active proliferative retinopathy, if it is untreated, or renal insufficiency, the creatine clearance is less than 50, or if there's a very heavy proteinuria or the blood pressure is too high despite treatment, or severe gastropathy, because it can give rise to nausea, vomiting, diarrhea. It can just, kind of take the patient out of the control and also give rise to a hypoglycemia that may not be detected. All these contraindications have to be kept in mind. So this is my last slide. A take-home message: you need to have optimal glycemic control preconception for better maternal fetal outcomes in patients with pre-GDM. There has to be preconception care and planning, which is integral for women with diabetes. Offer information, care, and advice to women before they get pregnant, start from adolescent, continue throughout the reproductive life. Advise contraception if the HbA1c is more than 10. Or even higher, or they need to postpone their pregnancy for whatever reason, for other comorbidities. Best is to advise contraception till it is necessary. We should also know when to stop it. Importance of glycemic management: as low, as close to 6.5 is desirable. Contraindications to pregnancy, I already mentioned. Folic acid 3 months prior to pregnancy. Review all the medications. Glycemic targets have to be reached. Self-monitoring has to be enforced, and a structured diabetes education by a good team is essential to have a normal pregnancy and a normal delivery and a healthy baby. Thank you very much. And now I invite Dr. Abhichandani to take over.
Yes, thank you very much, madam, for that very lucid talk. Fantastic coverage. You have done most of the job that I need to do. So thank you for that. And I would request you to stop sharing your screen so that I can start from my end.
Yeah, okay. Yes, sir.
Yeah, I will. Can I request the management people to allow me to share my screen?
Yusuf sir, may I introduce Abhichandani sir?
Your wish, Dr. Aniket. If you want me to, I'll do it.
Yeah, please.
So it's a privilege actually to have two very senior lucid speakers, Benny ma'am and Abhichandani sir. So Dr. V.K. Abhichandani is a diabetes and endocrine physician practicing since 1985 at Ahmedabad, principal investigator in various clinical trials. He's affiliated to ACE and the EASD. He's a life member of the RSSDI and a fellow also for the Indian Society of Hypertension and the Research Trust of Diabetes India. Guest speaker at various regional, national, and international conferences. Has been a regional faculty, and he has authored chapters on management of diabetes, initiation of insulin, stress-induced diabetes, and workup of a diabetic patient with suspected ischemic heart disease. And he has published many articles. So it's my pleasure to invite Dr. V.K. Abhichandani for the next talk.
Thank you, Dr. Yusuf. Thanks a lot for all your kind words of introduction. And now I need to... Are my slides visible?
Yes, sir.
Yes.
Yes, sir.
Yeah, so very good afternoon, everyone, and thanks a million for allowing an old man in this youthful team. I mean, I have been also luckily a part of PSG since last 3-4 years. So I'm going to start where Madam ended very elegantly. So I'm going to cover the topic of gestational diabetes. GDM is defined as any degree of glucose intolerance with onset or first recognition during pregnancy. And GDM represents a stage of chronic beta cell dysfunction and is a milestone in the development of type 2 diabetes. And this, the second line has been, endorsed by DIPSI in year 2020-21. And I think it holds a lot of importance because that's why we see very malignant conversion rate of GDM ladies in a couple of years into the frank type 2 diabetes spectrum. And as very correctly pointed out by Madam, when we address GDM, we are going to prevent 2 new generations of type 2 diabetes, the mother and the child to be born. So I'm going to utilize 3 cases from my humble practice. I'll start with my first case. Mrs. RDP, a 28-year-old primary gravida woman from Ahmedabad. Her family history and personal history were unremarkable. Non-smoker, obviously, and non-alcoholic, but that really is not the rule anymore. Many young ladies do occasionally smoke and drink. Pre-gestational body weight was a decent 55 kg and a BMI of 22.6 kilogram. And thanks to her, she was hardly having any appreciable height, not the ideal height, short lady, 156 centimeter. So an OGTT with 75 gram of glucose was performed at 24 weeks of gestational age when she weighed 62 kg and had a BMI of 25.5 kg per meter square. So this was till now she had gained the weight in ideal manner. And at the OGT, the fasting serum sugar was 99 milligram per deciliter with 1 and 2 hour glycemia at 137 milligram and 118 milligram per deciliter respectively. So we applied the criteria of International Association of Diabetes in Pregnancy Study Group and made a diagnosis of GDM as a fasting sugar. Any single reading out of the 3 abnormal reading is perceived as evidence of GDM. And the patient received instruction in self-monitoring of blood glucose in our clinic, was given nutritional and lifestyle recommendations, and started performing 6-point daily blood glucose profiles. A week later, fasting and preprandial capillary blood glucose levels were found to be below 90 milligram per deciliter on most days, with only 1 2-hour postprandial reading slightly exceeding 120 milligram and being read at 124 milligram per deciliter. Now, beyond this slide, I am going to present an experience that I have had, novel experience with, which is an actual case from my practice. And this is just a quick look at the glycemic targets in pregnancy. Both ADA and DIPSI concur when it comes to 2-hour targets, but then ADA has also a 1-hour insertion of less than or equal to 140 milligram per deciliter. And as she flatly refused insulin initiation, she was explained the benefits of replacing 15 gram of her rice batter or wheat atta intake twice per day by raw or that is green jackfruit atta, which is available online. And after 3 weeks of additional regular use of green jackfruit atta brand 365, these were her readings. A 7-point, in fact, this time we requested for a 7-point SMBG. You can see everything hale and hearty and no early morning hypoglycemia. Now I'll proceed to the next case. A 24-year-old vegetarian primary gravida is diagnosed to have GDM during the 26th week of gestation. She is sedentary by nature, height 160 centimeter, weight huge, 90 kg, giving her a BMI of 35.2. She had done fasting sugar at home, which was 84. But we, when she presented to us in the clinic, we followed the DIPSI challenge, and her readings 2 hours after 75 gram glucose in non-fasting state was 181 milligram. And that's how we made a diagnosis of GDM. And now we are all confronted with that million-dollar question. What advice do we give her regarding diet and exercise? Madam has very, very elegantly covered most of this, but still I need to touch some of these points when we are concentrating on GDM. So there is a quintet management model described in the net, and I have acknowledged the source, 2015 article, which says, and it's still in the same way we pursue this, ladies: diet, exercise, maternal education, and therapies, mostly insulin in our country, and fetal health evaluation is also of equal importance. So medical nutrition therapy happens to be the cornerstone of management of GDM because it ensures adequate nutrition, ensures adequate weight gain, prevents ketosis, prevents postprandial spikes, and thereby glycemic variability. And exercise, insulin, and a debatable role of oral anti-diabetic agents and psychosocial assessment and counseling form the other important options and arms available of the management strategy. So something about GDM diet. Diet is usually recommended at 30 kilocalorie per kilogram in normal weight ladies, 24 kilocalorie per kilogram for overweight women, and 12 kilocalorie per kilogram for morbidly obese women. The case number 2 that we saw, she had a BMI of 35.2. She would probably attract this low calorie diet. And diet should contain, in general, carbohydrate 50 to 55% while avoiding simple sugars, protein 20% at the rate of 1.1 gram per kilogram ideal body weight. So I have just inserted the ideal body weight formula in for women at the bottom. Fat should contribute not more than 25 to 30% of the lady's diet. And fiber is always a welcome addition, 20 to 40 grams per day. Frequent small meals. This has already been alluded to by Dr. Benny Madam. But in GDM, this really, again, is a very appealing strategy. Frequent small meal regimens, 2 to 3 hourly, to avoid hypoglycemia and minimize glycemic variability. Bedtime snacking to prevent ketosis overnight is also important to be followed. And adequate hydration, at least 2 liters of water per day, while avoiding fresh fruit juices, filtered fruit juice. Now, something about micronutrients during hyperglycemia and pregnancy. This will cover any first-time notice hyperglycemia, irrespective of the trimester. And the recommendation remains similar for women with and without diabetes. So folate at 570 micrograms per day, calcium 1000 milligram per day, iron 27 milligram per day, vitamin B12 2.75 micrograms per day. And these are sourced from ICMR NIN 2020 document. And Endocrine Society of India recommends supplementation of vitamin D at a dose of 1000 international units per day in pregnant women after 12 weeks of pregnancy. And sometimes, and I would also like to request our honorable moderator and chairperson at the end, what is the take? We sometimes recommend from day one, the moment we come to know that the lady has conceived, we do recommend a supplement of vitamin D in minimum doses per day. Something regarding artificial sweeteners during hyperglycemia and pregnancy. So sucralose, stevia, and aspartame are considered safe for limited consumption during HIP. They cannot be taken in very large quantities. Stevia is considered a natural non-caloric sweetener. Sucralose is considered non-nutritive sweetener, few or no calories. And aspartame is a nutritive sweetener, which adds some calories, but far, far less than sugar. And something about physical activity, though there has been a full session on this, but I would still allude to this few lines. Unless contraindicated, physical activity should be included in a pregnant woman's daily regimen, whether she is a established diabetic, whether or not she develops GDM, still every pregnant woman should exercise and break up extended periods of sedentariness. And regular moderate intensity physical activity like walking can help to reduce glucose levels in patients with GDM. And our own Anjana Madam, the proud daughter of Honorable Professor V. Mohan Sir, my mentor, has way back in 2016 came out with this important, important observation for all of us that recreational walking was associated with improved neonatal outcomes in Indian women with GDM. And this was published in an important journal, Index Journal, Diabetes Research and Clinical Practice. It comes from the idea way back in 2016. Cardiovascular training with weight bearing limited to the upper body. And this is the reason behind this specific recommendation is to avoid mechanical stress on the abdominal region. So slide dedicated to ideal weight gain during hyperglycemia and pregnancy. So if the lady is underweight, let's say less than 18 BMI, she can be allowed to gain up to 13.5 kgs, 11 to 13.5 kgs. And like the lady I referred to in case number 2, morbidly obese, more than 35 BMI, her weight gain preferably should be limited to less than 3.5 kgs throughout the 9 months of gestation. And then you can look at the ideal body weight situation, 18 to 24 BMI. And such ladies can be allowed to gain up anywhere from 8 to 11 kgs of body weight during the 9 months of gestation. Now I come to the third and the last case of my presentation. Mrs. N, a 32-year-old second gravida, is found to have GDM at 27 weeks of gestation. Her first pregnancy was uneventful, healthy. She was advised lifestyle and diet changes, and she meticulously adhered to all these instructions. And after 2 weeks, her blood sugars were as follows. Fasting sugar was 96 milligram per deciliter. 2 hour post-breakfast, okay, was 159 milligram per deciliter. So, do these figures satisfy us? Is her glycemic control adequate? And we all agree it is not. So, what should be the next line of treatment we should be offering her? That would be insulin initiation in our country. So, a slide dedicated to insulin therapy. A lot has been spoken by my very learned colleague, Dr. Benny Madam. So insulin therapy has to be individualized, that we need to remember. Many women with GDM have significant postprandial glucose elevations following just one of their meals. So such ladies will do well with a single dose of rapid-acting analog or regular human insulin given before that meal. And few GDM ladies may require basal plus, that is one basal plus one prandial dose of insulin, or basal bolus, that might be one basal and 2 or 3 prandial doses insulin as warranted by their SMBG readings. And a small reference to pre-mix based regimens, which though may sound very convenient to use, but they do not offer any flexibility in terms of titrating the individual components of the formulation, the premix formulation, even including the co-formulation of isodecast. So they are not of much favor. We normally stick to in GDM. First look at the postprandials, pick up the meal with the highest postprandial excursion, address that, and then if then the repeat SMBG demand, then we go on adding insulins, either basal. If fastings are high, naturally we will be settling for a basal analog at that time. The last slide, what about status of oral hypoglycemic agents in hyperglycemia in pregnancy? So due to efficacy and safety concerns, though metformin enjoys category B classification, but it does cross placenta. Comparatively, glyburide, that is glibenclamide, crosses less in amount, but then it is classified as category C. These are all B and C are pointers to the potential hazards of consuming such medicines. And metformin is allowed by ADA and even DIPSI. If the lady has been on metformin, for example, non-diabetic lady, for a gynecological indication like PCOS, if the lady has been on metformin, the standard approach is to allow metformin for first 4 months of gestation and then ease it out. And if the lady insists, she still stands the chance of requiring support of additional insulin therapy. But the official dictum is that due to efficacy and safety concerns, the AD and DIPSI do not recommend oral anti-hyperglycemic agents for GDM or pre-existing type 2 diabetes. Now, the first case, one sentence regarding the first case. It was just a relative, sort of a relative, very close family friend who trusted me. And this particular product, that green jackfruit atta, my wife has been using since ages. Her glycemia has come under very good control. Medicines have gone down. So I was enthused to offer that GDM lady who was not open to taking insulin at all with that one single postprandial escalation. So I think it has been an individual experience, and I wanted to humbly share with all of you. And here I end my presentation. There are no major takeaways except that pursue GDM vigorously, screen ladies at the first contact. That's very important. Even if the lady lands up in our obstetrician gynecologist place or in her family doctor's place, or in our clinic, as soon as missed periods or pregnancy is confirmed, the first contact is the ideal time to screen that lady for her sugar levels. Sometimes we take help of HbA1c also whenever there is a strong family history, for example, and a strong suspicion of madam referred to early trimester, the first trimester detection of hyperglycemia in pregnancy. In such cases, in let's say within first 8 weeks, I would, or first 12 weeks, I would also tend to additionally do HbA1c, and perhaps that might help us in pointing out to a missed pre-existing diabetes story. So screen, pursue, and make sure you vigorously follow these ladies. I have to speak only about medical management. So beyond that, normally we screen prior to discharge, keep such ladies convince them to stay in the hospital with the help of our obstetricians for 2 days more, a day or two, and pursue their sugars postpartum, and request them to, or follow them up and make sure they undergo a GTT again at 6 weeks. And
yes, sir. We are going to our detailed session for postpartum.
Yeah, so I'm ending here. Thank you very much for all your patience, and thank you for giving me this opportunity.
Would just request moderator if we can proceed further.
That was a very intriguing session, and Benny ma'am and Abhichandani sir touched upon every aspect of medical management of pre-GDM and GDM. Especially Benny ma'am, I would like to say that reinforcement of the diet, that was a very important aspect that you highlighted, because many a times patients do know what to take and what not to take, but still they ask questions or try to confuse you. So reinforcing the diet is very important. And I would just like to ask one question to Benny ma'am regarding the pre-gestational counseling. What would be the optimum or the right time for this counseling and modification of the therapy?
As I said earlier, actually patients do not come to us. Only 10% of the women come to us for pre-gestational counseling. The rest of them actually get pregnant and then they come for, but we should catch all young women who are going to plan their pregnancy even at a later stage. So if they're coming for treatment for obesity, or they're coming for management of PCOS, at that time only we should make them aware that when you get pregnant or you plan to get pregnant, please take advice from us. You need not tell them all the deliberation that I said just now, but that they have to come to us for advice for the pregnancy.
Especially about the use of metformin, because PCOS anyway we are continuing metformin, but non-PCOS ladies in the pre-gestational time, do we recommend them to continue metformin or down taper the dose or altogether stop metformin and switch them over to insulin?
Ideally, actually, it depends on their blood sugar. So if the blood sugar is very high, we put them on insulin and we continue metformin for some time till it stabilizes. And then when they're going closer to pregnancy, we take them off their metformin. But many of the patients actually do not want to discontinue metformin. I think metformin is now also quite safe, found to be safe in many studies. And so we have to tell all the risks associated with metformin to the patient. And if she agrees with the risk and you have a good dialogue with the patient, I think it is okay if she continues. If the sugars are so high, if she has obesity, which is marked, it is all, and she has PCOS, for which she has to continue the metformin at least in the first trimester, and all obstetricians continue it after that. Even if we want to stop it, they will continue it. And they say that, this woman will get a miscarriage if you stop it. So I think we are knowing more and more about metformin. It is relatively safe.
That's true, Benny ma'am. And as
Dr. Yusuf, can I add to that bit?
Yes, sir, please.
Metformin story. Yeah. So that meat follow-up study, meat tofu study, has thrown up certain questionable findings as regards the use of metformin. And two things: it's secreted in the milk to the tune of 17%, And secondly, the use of metformin has been found to be in when children of born to such ladies are pursued, the use has been found to be correlated with early childhood, paradoxically, childhood obesity and insulin resistance. So that has not been explained clearly, but the lot of literature is available to highlight this particular hazard, and that is why ADA and I think most of the bodies are of the opinion it is safest to, at least during pregnancy and even prior to pregnancy, as madam said, if hyperglycemia is of a magnitude, please convince the lady and switch her to insulins and bring her to a goal around 6.5.
We all see in our practice that many of the pregnant ladies are obese or overweight, and they have a lot of insulin resistance, and in spite of increasing the dose of insulin, they still have high sugars. So inevitably,
Dr. Yusuf, we are running almost 25 minutes late, so please move forward to the next session. Please.
Thank you so much.
We started also late. So
yeah.
We started also late.
Running
Anyway,
late, so
thank you
yes,
very much.
yes.
Thank
No,
you.
thank you.
Thank you, sir. Yeah.
Thank you, sir, and Benny ma'am.
Thank you so much for this.
Thank you, madam.
So moving ahead, the next session would be on postpartum GDM management. And to chair the session, I would like to invite Dr. Praveen Gangadhara from Bangalore and Dr. Rukhaya Surya from, she's from
Mumbai. Yes. Mumbai. Yeah.
Mumbai. So over to you, Dr. Praveen and Dr. Rukhaya.
Thank you, Dr. Yusuf. Thank you, PSG team, for inviting me for this meet. It's my pleasure to be part of the PSG, the third annual conference. So first off, I think we had a good depth discussion about the medical management of GDM by both Dr. Benny ma'am and Dr. Vinod sir. So moving on, very important topic, the postpartum management. And to shed some light on this topic, we have Dr. Maulik Kinariwala. Sir is MD Medicine, PGDDM UK. He's a consultant diabetologist and physician, having more than 15 years of experience. He's also a certified postgraduate diploma diabetes management from Middlesex University, UK, certified CCBM, as well as other certificate in thyroid disorders. He's also member of executive committee in APA. He's member of RSSDI, member of All India Association for Advancing Research and Obesity. He has a book written on, sorry, I'm not able to tell that, but he's almost part of many clinical trials and part of many national and international conferences as a moderator, chairperson, and a speaker. He organizes various health programs and social activities for needy people. To speak more about the topic, I would like to call upon Dr. Maulik, and he would be talking about the postpartum management.
Okay. Thank you, Dr. Praveen, for kind words. And again, I would like to thank you, Dr. Rutul Thakkar, as well as the Dr. Dharmendra Panchal, for just giving me opportunity to deliver talk in today's web-based platform, particularly as far as the GDM is concerned, right? My slide is visible?
Yeah, it's visible, Dr. Maulik.
Okay. And sir, am I audible?
Audible. All good.
Okay, sir. Okay. Can anyone share the screen?
Probably can try moving the slides. Yeah.
Okay, fine. See, today I'm going to deliver talk on the postpartum GDM management. And as far as the postpartum GDM management is concerned, we all know the slide is not moving. Next, please. Okay, fine. See, we all know when a life gets seeded in a mother womb, its age, dates, wealth, education, and death all are determined right here. The statement is given by the Chanakya, and we all know that's why we have to take care of the mother as well as when mother is going to become, just like a woman is going to become pregnant. We are going to take care in such a way that we will take care of the future outcome also. Next, please. See, we all know the diabetes in pregnancy, there are two categories. One is a pure GDM. It's called the gestational diabetes 2 GDM, we can say, when the diabetes is diagnosed during the pregnancy. And one is a pre-GDM, when the patient basically pregnancy with pre-existing diabetes like type 1 or type 2. Next, please. I'm going to start my case presentation with a true GDM case. And my other co-speaker is going to talk about the patient having a pre-GDM, when patient having a type 1 and type 2, how we are going to take care of the postpartum. This is a classical case, 20 years old pregnant lady who's a BMI 30 kg, presented with the history of the GDM. The OGTT was done at the 24 weeks of pregnancy. The fasting sugar was 117, first hour is 217, and second hour is 180. And patient was referred to us for the management of the diabetes. When patient came to us, we have taken a real history. There was no any family history of diabetes. There is a priming. There was no any history of the abortion or miscarriage. There is no other associated like disorder like thyroid or obesity. Advice for the lifestyle modification, just like MNT and physical activity, what we are usually going to advise when patient is going to come to first timers. After 10 days, when we call the patient and follow up with the SMG report, look at the reading. The fasting sugar is near 200. Post-meal is 192 and post-meal 2 hour sugar is 170. We have advised the plantar insulin in view of the high PPG, but patient is not willing for insulin at the time. We have also advised for the EGP for better glycemic monitoring, but patient is not going to convince. Next, please. After 10 days, when we have done the basically the just doing the SMG report, you can see here fasting is reasonable is going to came to 95. Post-meal sugar is 164 milligram and post-meal sugar is 150 milligram per deciliter with the on the metformin 250 milligram PID because patient was not going to convince for the insulin. And we have again advised for plantar insulin for better management, but patient is not going to ready to for take insulin. The dose of metformin is going to up titrated, and we have given the metformin 5 milligram PID. Still, sugar is not going to control. No, now the detailed counseling was done for the future outcome, and ultimately patient is going to convince for the insulin initiation. We have initiated Lispro 2 units before the breakfast, 3 before the lunch, and 3 before the meal. And the dose of insulin was titrated as per the SMBG level till the date of delivery. And by that time, sugar was very controlled. Look at the last figure. Fasting is came to 94. Reasonably is going to good control. Post meal 1 hour sugar is 138, and post meal 2 hour sugar is 124. Next, please. This is a usual story we are going to see in day and day out of our clinical practice. And after delivery, within 2 to 3 days, the insulin requirement almost going to become nil. Patient was going to discharge by gynecologist on metformin with advice to do follow-up with your diabetes doctor after 10 days with SMG reports. Again, basically, patient is going to advise to do OGTT after 1.5 months of delivery. Next, please. But this is the basically ground reality, and we are going to see a lot many set of patients basically in our clinical practice. But usually, we have observed that there are very few patients they are going to come in follow. Now, how we can going for the better management for the as far as the postpartum level of the basically mother glycemic status as well as for the offspring. There is a busy recommendation, and there was a basically guidelines by that how we can assess of the mother glycemic status in a postpartum stage. In most of the time, the GDM diabetes usually going to resolve after delivery. Insulin requirement usually is going to come down completely, or sometimes is going to reduce significantly. Patient was going to having a higher dose. Even though, however, it can be persist in 5 to 10% of cases, sometimes they are going to be represent as an unrecognized pre-existent diabetes. And blood glucose monitoring during this 48 hours after delivery is going to definitely help to determine the future outcome. And when fasting sugar is going to more than 120 or casual random sugar, if you are going to get more than 200 milligram, definitely we have to just knock down our patient is going to having a future risk of the type 2 diabetes. Now, what other things we have to keep in mind? When the woman having a prior GDM or IGT or IFG, they are having a underlying severity risk factor also. If you are going to intervene in proper way, you are going to identify, going to give the proper treatment, and definitely planning pregnancy in women. Developing the diabetes after GDM should reduce the subsequent early fetal loss and major congenital malformation. Next, please. Immediate postpartum management of the offspring care. This is all about what we have discussed for the maternal side, mother side. Now, something we have to take care of the offspring. Women with the GDM should be encouraged to breastfeeding immediately after delivery in order to avoid the risk of the neonatal hypoglycemia. That we all know the risk of the hypoglycemia is always to be outside, but we have to basically promote and we have to encourage a woman with GDM to give the breastfeeding immediately. And at least is to be continue for at least 3 to 4 months postpartum in order to prevent the future risk of the childhood obesity and diabetes in the offspring. Also, it is going to help in terms of the reduce the risk of the type 2 diabetes and hypertension in the mother also. We have to monitor the neonatal capillary blood glucose at least at the 1 hour after delivery and before each of the first 4 breastfeed. If value is going to less than 36 milligram per deciliter, it ultimately going to having a signs of the severe hypoglycemia. We have to give top feed if baby is going to take it, or we have to give either glucose water or IV dextrose. And again, if baby is macrosomic, we have to check the calcium level on the second day. It's all about the offspring side. Now we all know what are the short-term and long-term complications for mother and offspring due to GDM. I am going to focus on more in postpartum level. If the basically the mother, if you're going to say the future risk of the recurrent GDM and type 2 diabetes always to be high, and same way also basically in offspring side, there are the long-term outcome. There will be an increased risk of the obesity. There will be also increased risk of the future risk of the type 1 and type 2 diabetes, even the metabolic syndrome also. That's why we have to address aggressively. We have to monitor. We have to do the close follow-up in the postpartum state of the mother. By this way, we can reduce the future risk of the type 2 diabetes as far as the maternal side, and also we can take care of the baby also. Next, please. What are the risks of the future diabetes? You can see here, the woman who are getting a GDM, they are having a high risk of the developing type 2 diabetes in the future, that we all are knowing, and rate of the conversion rate varies from 35 to 60% over a period of 10 years. This patient is going to having a risk of the diabetes at any time in next 10 years after delivery. What the recent Indian data is going to show, out of the 5 women, 1 woman with the GDM is going to progress to dysglycemia in form of IGT or diabetes within the 1 year of the delivery. And similar way, there will be a 70% of risk in the next 5 years. Again, the obesity, waist circumference, and the BMI are the strongest orthopoietic measure is going to be required to development of type 2 diabetes in the woman with the GDM. Next, please. Ultimately, I can say the gestational diabetes it acts as a driver of the type 2 diabetes. When the pregnant woman with diabetes, if they are going to deliver the baby girl, ultimately it's going to grow, and future risk of the young woman with diabetes. And when she is going to become pregnant, again, basically they are going to having a chances to basically transfer the risk of diabetes in the 3rd generation. Ultimately, it's a vicious cycle. What are the risk factors for the progression to diabetes? Those who are having a overweight, obesity, particularly those having a strong family history of the diabetes. Then GDM is going to diagnose in the first trimester. Those patients, they require the insulin during the pregnancy on top of the oral anti-diabetic drug like metformin or diet alone. For some time, patients are going to require the pre-meal insulin as far as for fasting application is concerned, and patient may be having a persistent even IGT after delivery. They all are having a risk of the progression of the future diabetes. Means when we are going to counteract during the GDM management or in this situation, we have to keep our opening eye. We have to keep basically very vigilant, because these all are patients having a risk of the future diabetes. Means they require close monitoring and close follow-up. And remember, sir, one thing, women when having a GDM, they are having a higher risk of the developing cardiovascular disease as compared to women with those having no history of the GDM at the younger age. That's why we have basically guidelines recommendation how to basically going to take assessment of the postpartum basically GDM. We have to do ideally OGTT 75 gram oral glucose tolerance test at the end of the 6 weeks to 8 weeks after the delivery, and we have to just to level the OGTT. If OG is going to become normal, then definitely, but there is no any basically major variable thing, but still the patient is going to require the discipline, healthy behavior, modified lifestyle, and we have to close to follow up every end of the 1 year. Suppose somebody patient is going to land up with the IGT, definitely the lifetime modifications to be required. On top of that, you can consider metformin. But when patient is going to label having a type 2 diabetes, definitely patient is going to require the insulin on basically metformin plus lifetime modification if patient having a very high sugar. If they are not going to manage with the lifetime modification and metformin, we have to basically go for insulin till the patient is going to deliver the patient is going to feeding their baby. Next, please. We all know, I am not going to detailing about it. What are the normal level of the OGTT? What is IGT? What is IFG? And what is diabetes? These are the reading we are going to come to. I am not going to describe in detailing it. Next, please. How we can manage the diabetes during lactation phase? This is again the very important thing. Remember that the insulin is only the basically remain the choice of drug when the mother is going to basically feed their baby. But sometimes basically mother is going to little bit disturbed if they require the lot of basically the counseling, then insulin during the management of the GDM. At that time, patient is not going to ready for that. But the metformin you can consider, because the metformin is going to secrete in the breast milk, but there are little bit very minimal side effect. Try to avoid the insulin, all other OADs, even patient having a pre-existing type of diabetes, not to use this type of OAD. Only you can go for the insulin. Any patient is not going to require, you can consider metformin, but still the data has to be required for the further management. Now, how we can prevent basically all the strategy? Ultimately, patients require the good lifestyle modification, dietary plan. If patient having obesity, they require the weight loss. Regular, they require the exercise. And suppose if patient having a labeling pre-diabetes after post-delivery, then you can consider metformin, especially such type of the category of the woman. And also we have to take care of additional cardiovascular factor like hypertension, obesity, or any other metabolic syndrome. Next, please. By this way, we can prevent all these things. Is there any data or studies going to be there how the lifestyle modification is going to prevent the future of GDM? Yes, you can see here. It's a Finnish gestational diabetes prevention study, and the study was done, and just they have come to know that by doing the proper lifestyle intervention, we can reduce the 39% of incidence of the GDM in a high-risk pregnant woman. Next, please. Ultimately, this is an all table. I can just go into summarize in A to G form how we can manage the postpartum basically for the maternal as well as for offspring side. A is assessment, means they require the regular follow-up with the OGTT at the end of the 6 and 8 weeks of the delivery. We have to encourage breastfeeding. The contraception has to be required advice in proper way. Ultimately, future risk of the early onset of diabetes, we can prevent it. Dietary modification is required in proper way with the help of the nutritionists and dietitians. Exercise and physical activity is going to be promoted. We require the family involvement because lots of time we have observed the husband sometimes is not going to basically involve after the basically post GDM, and ultimately mother is going to take care of the baby and she is going to be busy and they are not going to do the follow-up advice what we have given the recommendation during the time of the gestational follow-up, and ultimately we have to design some goal and that we have to basically given the explanation in proper way. Look at the left corner slides. Here, the recommendation is given by the ADA 2022, even the 2015 NICE guidelines they've given. What are the short-term follow-up and what are long-term follow-up? They all are going to come to conclusion. The patient, those having GDM, they require the close follow-up basically up to the 6 to 12 weeks after delivery. And again, if they are going to having a normal or euglycemia, even though they require at least basically once in a year for next 3 years for regular follow-up, just to see the trend, either they are going to convert in pre-DM or diabetes. Next, please. This all about basically the discussion what we have basically came to know the postpartum management for the maternal side as well as offspring side. Now, what are the benefits of postpartum follow-up? If you are doing the proper postpartum follow-up, ultimately we can prevent the future risk of the GDM and diabetes also. We can also early detect the diabetes and pre-diabetes. Subsequently, we can reduce the risk of the future CV events also, and we can also prevent or delaying the complication of diabetes. There are the lot many benefits as far as if you are going to do proper postpartum follow-up. Next, please. What are the barriers? There are a lot of barriers. As far as the education side, patient basically still having a lack of understanding. They are not going to having a awareness of the risk of the type 2 diabetes. Some there are socioeconomic stigma is going to be there. Sometimes basically after going to deliver baby, the mother is going to transport them to their MICA and they are not going to come to know. They are not going to do follow-up. Lack of family support already I have discussed.
One minute
healthcare
more.
System, sir, just within 2 minutes I am going to finish. The healthcare system also is going to be having a major issue. There are poor bridging from the antepartum and postpartum care, and also there would be very poor communication between the obstetric gynecologist as well as primary care physician, and because of that we are going to be a lot of troubles. What could be strategy for that? We can give the patient reminder like phone calls or text message or email. We can also go for the verbal or written counseling education during the time of the gestational management, and also we can give flexible appointment time so patient is not going to having a lot of spend to time in OPDs because they are also going to be busy to take care of their babies. And by telemedicine also nowadays you can contact your patients and you can do close follow-up. What I basically recommend and what I going to basically advise for the junior colleagues and all the clinicians, I think almost we are doing, but if we are not doing that, we have to start to do in our clinical practice. If we are going to just run the gestational clinic, we have to recognize the scope and significance of future risk of diabetes, and we have to promote universal testing. This is the number one. Second thing, we have to keep reinforcing to the mother about their future risk of diabetes. We have to encourage the breastfeeding, discuss about the planned pregnancy and preconception care, keep reminding the patient to have regular follow-up after her GDM pregnancy, and keeps an eyes on babies of mother with GDM, and also going to communicate with your pediatricians. This is the thing we have to keep in mind. And the last slides basically I am going to say, so we have, next please, we have to basically maintain basically the diabetic patients in such a way that the baby is not going to feel that her mother is going to having a risk of diabetes. If you are going to do in proper way, then definitely by this way we can prevent the future risk of the obesity and diabetes of the offspring. This is from the my side, how we can going to take care of the true GDM patient as far as the basically postpartum is concerned. And now just I am going to hand over to the the chairperson for inviting next speaker.
Thank you, Dr. Maulik. Thank you, Dr. Maulik, for the precise talk on the postpartum management. As we know that we are running a little short of time, we need to be little catch up in the coming session. So I'll just hand over to my next co-chairperson to introduce the next speaker.
Thank you.
Dr. Rukia.
Thank you, Dr. And thank you, Dr. Maulik here. At the outset, I would like to thank Dr. Rutul and the PSG team. I think since morning, we are doing a great, fantastic, sessions which are going on. And with this GDM sessions that we have going on, I would like to invite our next speaker. Can we have the slide, please? So the next speaker is Dr. Subhashish Ghosh. After Dr. Maulik speaking on postpartum gestational management in a GDM patient, Dr. Subhashish is going to talk about basically postpartum management in type 1 patient and type 2 patient. Dr. Ghosh is a doctor currently. He's a junior consultant in general medicine at Calcutta Heart Clinic and Hospital. And he's also a tutor at the Department of the General Medicine, Diamond Harbour Government Medical College and Hospital. Over to you, Dr. Ghosh. Can we have the slides? Dr. Subhashish, will you be sharing the slides or someone at the back end?
Hello.
Subhashish, sharing your screen, and it's better you don't use.
You can share your slide.
You can start sharing.
So, can you hear me now?
Yes, you are audible.
Okay, actually, Dr. Maulik has summed up the whole issue of postpartum GDM management entirely. So, to me, as an internist, GDM postpartum GDM patients are actually a very keystone to identify the future cardiovascular burden in our population, especially in women population actually. So it's a state of the GDM is a state of actually a chronic beta cell dysfunction along with probably a insulin resistance. And when when the baby is delivered,
can we have the slides?
That,
sorry to interrupt.
The sugar level comes down.
The RX team, can you share the slides on his behalf?
Management diabetes, the symposium. Doctor, since we can, if you can just sum it up and tell us in short, Dr. Maulik.
Yes, ma'am.
Yes.
See, the postpartum GDM, basically we have to keep in mind either patient having a true GDM or pre-existing type 1 or type 2 diabetes. If patient having a true GDM, already I have basically spoken my part. But when patient having a pre-existing type 2 diabetes, definitely we have to see the glycemic status after the delivery. and preferably patient is going to treat with the metformin previously, then we have to continue the metformin, and depending upon the clinical needs to be required, we can go for the insulin at least till the basically the lactation phase is going to over. Most of the time we have observed our basically the female patient, they are not going to convince for the insulin, but if the requirement is going to be there and we can able to achieve the glycemic control with the lifetime modification, with the diet plan as well as physical activity with metformin, we have to basically convince them, and for at least for another 6 months to 1 year till the baby is going to feed, we have to take care of the better glycemic control, right? Yeah. Number one. And for type 1 definitely there is no doubt at all, patient is always want to go into basal bolus therapy, and almost during the time of the gestation phase also they are on the basal bolus therapy, so we have to continue in the same way what the patient is going to be there. But the GDM patient, true GDM patient, we have to become very aggressively, because these are the basically patients having a future risk of the other pre-diabetes and the diabetes type 2. If we can able to assess in a proper way, we can able to do proper counseling, and we require a close follow-up, and if we can able to do it, then and then we can reduce the future risk of the pre-diabetes as well as the type 2 diabetes. This is from my side. Otherwise, all the detailing discussion is going to done since basically morning, and there is no any other new thing as far as for the basically the postpartum management of GDM is concerned. And I would like to pass the message to basically our Obgynecology society. There may we have to require some basically linking system, because most of the time what madam basically we are facing the problem, the once the baby is going to deliver, then even though we are going to give the return counseling, the explanation to their husbands, they require at least the OGTT after end of the 1.5 month of delivery or your birthday of the baby boy or baby girl, even though basically only 10 to 15% patient of the true GDM, they are going to coming for this follow-up. Ultimate patient is going to just discontinue from the loop. After 2-3 years, again, they are going to become pregnant. They then suddenly came to know that there is now they are going to convert, some patient is going to convert either true GDM, pre-diabetes, or some type patient is going to come into diabetes type 2, and they are having a problem from the preconceptual child, or I can say basically when they are going to pregnant and then can come to know having a diabetes. I think we have to basically make it some strong channel. By this way, at least we can do the follow-up of patient in proper way, we can assess in proper way, and we can take care of the future risk of the not to going to develop diabetes of the mother, as well as for we can take care of the third generation also, I can say. This is from my side.
Yeah, so postpartum control is not just sugar. We also need to make sure that during the lactation and the contraception part of it is completely taught to the patient. And the habits that we instill to the patient during pregnancy, we want them to continue with the similar habits even later, so that the future risk of, developing diabetes is prevented.
Exactly.
Yes. Okay. So Dr. Subhashish, is he back?
His slide is visible.
But I don't. Okay, so over to the next. Dr. Yusuf Khan, can you take it further from here?
Yeah, so in the last 2 sessions, we have seen the pathogenesis of GDM till the medical management of pre-GDM, GDM, and the postpartum period. So I thank the chairpersons and the speakers for the lucid talk. And with this, we end this session.
Thank you. Thank you, Dr. Yusuf Khan, for moderating the session. And here we will move for the next session. And next section regarding on macronutrients and that role in GDM. I would like to invite Dr. Ritu Johri to moderate the session. Over to you, Dr. Ritu.
Thank you so much. First of all, a very, very warm good evening to one and all. And I would like to start by thanking Team PSG, Dr. Dharmendra, Dr. Rutul, and Dr. Amit for this elaborate and extensive setup. And I think it's brilliantly going so far. We've been talking about, the diet. We started with what is GDM. We've set the stage of what is required when we talk about diet and nutrition. And when it comes to nutrition, I think the macro and the micronutrients play a very, very important role for these kind of patients, because they have 2 lives entwined in one. So this is a very different kind of a session. We have a practical approach discussion on the topic of macronutrients by Dr. Dakshata and Dr. Ruby Sound. So I would, without any further ado, invite the chairpersons and request them to introduce both the doctors quickly in a line. So Dr. Mayanka Singhal and Dr. Smita Jha, please.
Yes. Thank you, Ritu. And good afternoon, everybody, and welcome to this nutrition symposium. And today our topic is macronutrients consideration in pregnancy, GDM. And I would like to invite dietitian Ruby Sound to giving the talk. Dietitian Ruby is the founder of the Eatwise Nutrition and Wellness Clinic. She's the dietitian at Sangeeta Maternity Hospital. She's certified NLP practitioner. She's certified Pilates trainer. She's managing committee member, the PCOS Society. She's member of Nutrition Society of India. She's a member of Nutrition Society UK. She's member of AFST, PF and DAI, member of Probiotic Society of India. She's also member of AERO and she's a recipient of Women of the Year 2015 Health and Wellness Expert. So over to Ruby Sound.
Ruby, you can start and then you can introduce the concept. Yeah.
Good evening, one and all. Thank you for this opportunity. We are glad we're talking about nutrition at length. We've been hearing from all the speakers. With me today, I have Dr. Dakshita Patyay, who is going to join hands with me to take you through this journey. I'm going to share the slides and both of us together are going to take you through all. And before this, both of us want to together thank the entire team of PSG for inviting us. I go ahead by sharing the screen now.
So Ruby, to just make it clear, it's not joining hand, it's hand holding. You're going to hold my hand through the journey. Thank you, Dr. Rutul, Dr. Amit Ray, and Dr. Dharmendra Panchal, and congratulations in advance for the super success of the Congress. We are going to approach this topic in a little different way. Role of nutritionist in managing GDM, we know, is the main cornerstone of the therapy. 90% of the GDM are managed by only medical nutrition therapy. So I think the role of Ruby in this presentation is going to be 90%. So just take you through the slides. Ruby, can we go to the next slide? Sorry, you have the control.
Yes.
Okay, so diagnostic criteria, everybody is very clear. Everything is being already discussed, but I want that slide, Ruby, that once again, I'm going to insist that, everybody we shouldn't be getting, confused between WHO, IID, PSG, ADA, DIPSI. It's DIPSI, and DIPSI in India. It's 75-gram glucose, very clear. No, it can be non-fasting OGTT. So in rural setup or in busy gynecology clinic where the appointments are very difficult, it can be done on the OPD basis. Even if patient has eaten, she is non-fasting, it can be done. And the cutoff is 140. So this is very clear. Next slide. So glycemic targets, we all know, but 120 is a magic figure. We should know that 120 is a figure where if it is less than 120, then 2 hours post-glucose less than 120. If it is more than 140, okay, the diagnosis of GDM is done. And then you give trial of 2 weeks to 4 weeks for medical nutrition therapy. And if still the targets are below 150, targets come below 150, then it's only medical nutrition therapy and we don't require any medical management. And what are the glycemic goals? Basically to achieve good glycemic control. And why do we treat GDM? We basically treat GDM to prevent complications, maternal and fetal, to prevent ketosis, to prevent hypoglycemia, and to prevent hyperglycemia, and to have a better maternal and fetal growth. And you can see the whole lot of complications nowadays with so much of advancement and technology and newer insulins and monitoring technique. We don't get to see this stillbirth and macrosomia and life-threatening hypoglycemia in neonates. Thanks to conferences like this. Next slide. So as I advised that OGTT more than 140 post 75-gram glucose, MNT for 2 weeks. And if it is more than 120, then it is physical exercise and medical management. Everything has to be started along, the medical management has to be started along with MNT and physical exercise. But if it is less than 120, you are able to achieve 120 with MNT, then no need for medical management. Next slide, please.
So it is basically a carbohydrate controlled meal plan which provides adequate nutrition with appropriate weight gain and fetal well-being. You have to keep in mind the cultural preferences. A South Indian patient, you cannot say that low carbs, no idli, no dosa. You have to, give the preference to the culture and achieve normoglycemia, preventing nutritional ketosis. This is very, very important. Next slide, please. So patients who are going to receive MNT, they are going to require, fewer patients are going to require insulin therapy. If they adhere to their MNT, they will have definitely decrease in HbA1c. Perinatal complications among the infants are going to be less, and lower birth weight, lower percentage for gestational age, less macrosomia. These are the things which we are going to advise. So as I mentioned at the beginning of the lecture, that more than 90% of the GDM can be managed by MNT. Next slide, please. And this is just a small study, of GDM, 436 women and non-diabetic women, 254 women. They were, given a very good MNT to GDM patients, and there was a group where MNT was not given. And early diagnosis of GDM, which is very crucial, and early MNT intervention seemed to be beneficial in this study. Next slide, please. So if 90% GDM are going to be managed with MNT, I think nutritionists are the cornerstone of the therapy. With this, I invite Ruby to take ahead this lecture. So Ruby, you're going to hold my hand throughout the presentation.
Thank you, Dr. Akshata, for covering the few points before I go to the main practical aspects. Because now, as you said, that for diagnostic criteria also, we have DIPSI as the main guiding force for us. Similarly, there are several MNT guidelines given by different societies all over the world, but we are going to stick to some guidelines given by Indian Ministry of Health and Welfare India, and also looking at the suggestions coming from DIPSI and the ADA. Here are the main micronutrient division that we look at. When we look at MNT, as you said earlier, that it is a controlled carbohydrate diet, we should also consider the other two macronutrients, which is carbohydrate, besides carbohydrate, proteins and fats. So how is the macronutrient distribution very, very important, and what should be the ideal distribution? Now, typically we know that as an Indian, our diets are predominantly carbohydrate based. More than 60% of our diet, whether north, south, east or west, even the START study by Dr. Shashank Joshi showed that more than 60% of our diet is carbohydrate based. So for an MNT for GDM, ideally the amount of carbohydrate in your diet should be not more than 50%. Anywhere between 40 to 50% is acceptable. The protein in your diet for a GDM patient should typically be 20%, and fat should not exceed 30% of fat. So we will first focus mainly on the carbohydrate because that's going to influence the glycemic excursions. We are first looking at the total calories, whether carbohydrates, proteins or fats. Put together, the calories are also going to have an impact on the blood glucose levels. Now, how many calories are sufficient? We need to give calories so that there is optimum growth and development of the fetus. We need to avoid the postprandial hyperglycemia, and we need to avoid excessive weight gain of the mother as well. So the ICMR NASH and the NIN guidelines of 2020 very clearly say that in the first trimester, there is no need to increase calorie intake. However, going further in the second trimester, 350 kilocalories should be increased, which should continue for third trimester also. Only if there is a twin pregnancy, the calories should be increased by 700 kilocalories per day. Otherwise, you must stick to this kind of a chart, which will tell you how many calories should be given. So this is very easy and handy for doctors and dietitians to calculate the energy requirement during the pregnancy. Now, if it's a sedentary where most of the patients are sedentary in our urban setup, 1900 kilocalorie is required for during pregnancy. But depending upon whether she's obese, she's underweight, normal weight, or we can adjust the caloric intake. So addition of 500 calories is given to those who are underweight, and you must reduce 500 kilocalories per day if the patient is in the obese category or BMI about 24 as well. However, we know that for obese patients, we are a little more worried that the question is, do we make her lose weight? Do we cut down her calories? So it's very important to understand that in women with GDM, the excessive weight gain has been associated with increased risk of hypertension, cesarean section, and the loss of gestational age babies. And a meta-analysis concluded that it's extremely important to prevent excessive weight gain in the GDM pregnancies. What happens is when the patient has already gained her weight, which is desired, it's very, very important to make sure that the weight doesn't go further beyond this. Stabilization is extremely important. So how many calories do we give to a patient who is obese and she has a GDM? we must reduce calories only 30 to 35% in our total caloric consumption on a daily basis. That is not only going to improve our sugars, but also reduce the plasma triglyceride level. Make sure that the diet is somewhere between 1600 to 1800 kilocalories without leading to ketosis. Giving a diet which is 50% lesser than a total current intake actually is going to lead to ketosis, which must be avoided. So no diet less than 1500 kilocalories should be given to GDM patients. And we all know the risks of ketosis. Now, if we divide the macronutrients, carb, protein, and fat in the total caloric intake, the concentration should be mainly on the type of carbohydrates, because the post-meal blood glucose level is going to depend completely on the kind of amount, the type of carbohydrate, how much amount is being eaten in a meal, and what is the digestion and absorption of the carbohydrate, particular in a meal or a given snack, because that's going to directly have an impact on the blood glucose postprandial. So we need to divide the carbohydrates according to the caloric requirement of the individual. So how do we calculate how many carbohydrates do we give and how do we distribute throughout the day? As we know, not more than 50%. And now we usually see women taking 3 to 4 meals. But for GDM patients especially, make sure that the patient is given 3 meals plus 2 to 4 snacks per day. That could include a bedtime snack as well. All in all, not more than 175 grams of carbohydrate is appropriate for the fetal growth and the cerebral development on the function of the child as well. So there's no need to cut down the carbohydrates beyond that. However, if you go very, very low, less than 39% of carbohydrate, it may result in a higher birth weight. And a low carbohydrate means the diet will be either high in proteins or maybe high in fat also, which can again increase the risk of GDM and at-risk women. So keeping it this bracket of 40 to 50% is ideal. And distributing is very, very important. Again, there are the current the patient's current glycemic status will help us divide the carbohydrate intake. However, in general, the major 3 meals, breakfast, lunch, and dinner, should have not more than 30% of carbohydrate. Like 20% for breakfast, 20% for lunch, and 30% for dinner. And the snacks in between, like a mid-morning snack, a mid-evening snack, and a bedtime snack, should not have more than 10% of carbohydrates coming from the total intake. This is especially very, very important for those who are in insulin. And to educate the patient on how and how much carbohydrate they should take, one must educate the patient that one serving is actually 15 grams of carbohydrate, which we call it as 1 carb unit. So just teach the patient 1 cup of unit means 1 slice of either a chapati, 1 medium-sized chapati, or it could be 1 cup of curd, or it could be 1 fruit like an small apple or a sweet lime or an orange. It could also be half a potato, or it could also be, if the patient is allowed bread, could be 1 slice of bread. Potato also is considered as a high glycemic index carbohydrate, which should be considered here. So if the patient has to be given 45 grams at 1 meal, which is 3 servings, that is 15 into 3 is 45 for breakfast, lunch, and dinner. And both the snacks, mid-morning and mid-evening, should have only 1 to 2 serving, means 30 grams of each only. That is how we will adjust the carbohydrate counting. So it's not only the amount of carbohydrate we should focus on, we should also look at the type of carbohydrate. So especially the simple carbohydrates, which are like sweets, processed fruit juices, and aerated drinks, which are going to spurge the blood sugar levels, are completely no-no for these patients. The focus should be on the complex carbohydrates, especially those which are low in glycemic index. This kind of a chart is self-explanatory, which can be given to the patients. There are 3 types of carbohydrates: low in GI, high in GI, and moderate GI. So in every food group, for example, if you look at the right-hand side, if you see the set of vegetables here, you'll find that the boiled potato is the highest in terms of GI, whereas other vegetables are low in GI. Among the fruits, you'll find watermelon being the highest in terms of GI, and other fruits, apple, orange, even banana and the mango. Again, the amount and the type, the variety of the fruit will decide. And looking at the roti and the wheat and the cereals, if you look at the bread, any type of bread other than the whole grain bread is either a high or a medium GI bread. Looking at other rice varieties, you can allow the patient to have either a mulgiri rice, a barley rice, or basmati rice, which is a medium GI rice. No to a kolam rice or a small grain rice, which is very bad. So this kind of a red, orange, and green signaling system can be shared with the patients, which will allow them to choose which food from which particular food group. That's very, very important, because many guidelines on MNT for GDM have recommended a low to moderate GI. A meta-analysis of 5 randomized clinical trials with 302 patients also showed that low GI reduced the risk of macrosomia. Another meta-analysis involving 1,985 women showed that low GI has a positive effect on the maternal outcomes and avoids the adverse outcome on the newborns as well. This systemic review, which very clearly indicates that as compared to the low GI total energy restriction and the low carbohydrate, only low GI is the best in terms of the outcome. Another limit trial similarly gives us a hands-on for the low GI diet. Choosing the amount of fiber, especially the soluble fiber, up to 28 grams is going to really have a blunting response on the proglycemic response. So suggest the patient to take fruits, isabgol, flax seeds, oat bran, and pulses which have got the skin like a whole pulse. Proteins, how much do we give? Only 9.5 grams in addition during the second trimester and 22 grams in the third trimester. So it's not only going to add protein, but also blunt the postprandial spikes. Now, giving fibrous dals, like the dals with the husk, is going to increase the fiber and the protein growth. So as the pregnancy advances, change the ratio from cereal to pulse to increase the pulse and reduce the cereal. For example, in a dal khichdi, increase the amount of dal and reduce the amount of rice as the trimester progresses. It's also going to increase the satiety value of that particular meal. How do we achieve the total protein intake? Give the patient 2 to 3 cups of dal, a thick pulse, 2 egg whites for those who are non-vegetarian, and about 1 cup, also about 150 grams of chicken or fish for the non-vegetarians. And the type of protein also has been in light in recent past. There has been a debate whether animal protein or plant protein is better. And there are some studies which show that plant protein is much, much better because of the kind of branch chain amino acids and the other amino acids present in the animal protein. So some studies suggest preference of plant protein over the animal protein. So you can add any type of protein to your meals in different forms like powders or milk or nuts are a very good source of protein which can be given to the patients. And when it comes to fat, the last macronutrient of the discussion, yes, adding more fats is going to increase the weight of these patients. So focus on fats which are healthier fats. Make sure that the saturated fats are less than 10%, not more than 30 grams of vegetable fat. Only 20 ml, that is 4 teaspoons of cooking oil is allowed per day. There should be good focus on the omega-6 and the omega-3 ratio. And up to 200 milligrams of DHA is very essential, especially in the patients who are pregnant. And certain of good fats which should be suggested during the pregnancy is MUFA. So what you can do is you can include these nuts, olive oil, or any snack made out of this, which is enriched in MUFA. Giving omega-3 either in the form of walnuts or chia seeds or fish is a very good option. Of course, choosing the fish in pregnancy is extremely important to avoid low mercury fishes such as pomfret travas, catfish, and up to 350 grams of fish can be kept on a weekly basis. Avoid all the bad fats and keep the saturated fats less than 10%. The intake of coconut oil should be moderate. The total dietary cholesterol, which is usually found in the animal fat, should be less than 300 ml. All the vanaspatis, the ghee, and the red meat should be completely restricted in these diets. And I think once we understand the type of carbohydrate, proteins, and fat, we will be able to give a better and an easy to comply diet plan to the patients. I will continue by giving you certain practical tips. So there are 4 practical tools that I can give to all of you, which we usually practice in our OPD setup. One is breakfast split, how to split your breakfast, the meal frequency, how to choose which macronutrient first, and the double plate method. Now, first, if I show you the concept of split the breakfast, suppose this patient is consuming about 3 uttapams or 4 idlis, suggest the patients that split into 2 with a difference of 1 hour. Studies have shown that distribution of carbohydrates at the breakfast is going to help improve the post-meal excursion. So instead of having 3 uttapams at one time, take 1.5 uttapam at say about 9 o'clock in the morning, and an hour late you can have the remaining 1.5 uttapams or 2 idlis in the gap of 2 hours each. There are other breakfast options, giving egg and giving paneer, which will reduce the glycemic index, and that will help reducing the postprandial blood glucose levels. And so it's very, very important in the morning because of the increased insulin resistance secondary to the dawn phenomena, which is commonly seen. Okay, and these women have a deficiency in the first phase insulin secretion, and to match this insulin deficiency, we need to have smaller quantity of food, less number of carbohydrates at one time. It's important to give less food and in a split form. The other trick is not to give only 3 major meals. Besides breakfast, lunch, and dinner, give 2 more meals. So if you can see this blue line, which the patient takes only 3 meals, there is a huge spike. However, as compared to that, if you give meals regularly after every 3 hours, the spike is not so high. The patient tends to eat lesser amount of food as well as less amount of carbohydrate. Ingestion gives this kind of a blunting response. The third very important is a sequence of eating, which we usually, tell every patient who comes for counseling that first, whether it's breakfast, lunch, or dinner, include proteins in the diet as much as possible. Whether these are eggs, nuts, curd, paneer, or dals, that's going to actually give you more satiety also and reduces the glides. After that, you can take your cereal based, whether it is your chapati or whether it is your poha, upma, or South Indian idlis. The sequence of eating should be very, very critical. And same as for the lunch and dinner. First, you take the fiber and the protein, whether it is a bhaji or the salad, that should go first. After 5-10 minutes, then you should start eating your chapati with the remaining bhaji or the remaining dal. But the rice and the chapati should come in the second. So this should be the order of the eating. Another way to explain a patient is especially those who have a greater appetite, tell them to take the plate which is only 9 inches in diameter. Very easy to understand. Fill half your plate with vegetables first. And these should be non-starchy, not a potato. A lot of green vegetables, a lot of other vegetables can be added. Only 1/4 of your plate should have carbohydrates, whether it is a chapati or bread or rice. And the remaining 1/4 should focus on the dal or the chicken or the fish. And in addition to that, the patient can be allowed to take curd or buttermilk with both the meals. I think if we implement this, we will be able to solve cases like this. So Dakshita, I would request you to share this
so Ruby,
case.
Can we just go through this one case? She's an elderly primary, 36-year-old female, 66 kg, not very overweight, I would say. She already had history of PCOS, hypothyroidism, and she has, conceived through ART. And now this is 20 weeks of gestation. Sugar fasting around 124, OGTT is showing 157, and A1C around 6.7. Naturally, she's 36-year-old. Any pregnancy is precious, but this pregnancy is precious. Mom is diabetic and father had fatty liver disease. Next slide. So this is her diet sheet looks like. Very high carb. You can see, I'm not going to read it with the constraint of time, but if you see, dinner is always rice. After dinner, she's having something sweet at the 28th week of gestation as well. So I would like you to give her some practical tips so that she can adhere to the diet sheet.
Yeah, so we may not see junk or too much sugar because she's not having sugar in the milk. Okay, only 1 teaspoon of sugar in the cup of tea. Like I discussed the previous slides, how do we utilize or implement those principles in this time? So what we can do is begin the day with not with a carbohydrate-rich toast or rusk or biscuit, but with some amount of fat and protein. So nuts would be the ideal choice. That is some almonds, some walnuts can give good amount of fat and protein both, and that will not spike up the blood glucose early in the morning. Now, her breakfast, which usually looks like a simple carbohydrate like sabudana, and there's rice-based idlis or bread sometimes. And there's also, along with that, 1 cup of tea with sugar, and sometimes she also eats bread and jam. Here, we can always give her better suggestions to include protein, like I suggested earlier. Whatever breakfast is given, split into 2. The quantity should be, so she can have part of the breakfast at 9:30, the remaining part at 10:30. We need to split this. You can avoid tea along with the breakfast because anemia is also a big concern to us. So combining tea with food is not going to be the right way to eat. Now looking at the next meal of hers, she has a lunch at 12:45 and she eats a banana after her lunch or with her lunch every day, which is actually going to increase the glycemic load of the meal. So this should be avoided. And with chapati and vegetable, a protein and some salad can be added to reduce the glycemic load of this meal. Directly after lunch, her 3 o'clock meal actually is some nashta, which is like a poha or a Maggi or bale or chips. All these refined carbohydrates should be out of this. She can either take a protein supplement with milk or some nuts again at this time. She has a large gap between 3 p.m. and 9 p.m. So in between the 2 meals, we can include a mid-evening snack. So which can be either a complex carb or a protein-rich snack at 5:30. It could either be a protein-rich or a boiled egg also, or some paneer. 100 grams can be taken at this time. Now, dinner, of course, is slightly late, can be shifted to 7:30, 8 p.m. As Dr. Dakshita said, it's majorly rice-based. We need to make sure that she has more vegetables in the dinner and avoid rice on a daily basis. That can be once or twice a week. We can include chapati or even a millet-based meal can be included in there. But lump sum amount of vegetables and fiber has to be there, though this is a protein-rich meal. Because we know that a mistake is to consume after one piece of chocolate or ice cream or cry. We can look at snacks. We can look at munching some peanuts at this time. Walking, if she's doing only after the dinner, we must encourage that she walks after the major meal, which is lunch as well. So lunch, dinner, meal walk can be very, very helpful. So only doing a minor changes will help us and not completely 360-degree changing her that. So that's what is very, very important. She will adhere to the diet only if she is given only slight changes. And when you're giving counseling to such a patient, ensure you check her previous blood sugar reading. If she is facing nausea, vomiting, we need to do the necessary changes. Give a very, very simple diet, like the suggestion which I told you right now is very simple to follow. And you can also give it in a very local language. Whichever food is available locally, you must only suggest to her. If she's a North Indian, you cannot force her to take idlis. If she's a South Indian, you cannot force her to take parathas. So slight changes with the change of ingredient will be very, very helpful. Give her a list what she needs to eat rather than what she does not need to eat. And follow it up to understand whether there is an improvement in the blood sugar reading. That's how we will be able to modify diet for her.
I think, Robi, we can skip next 4 or 5 slides, which are, standard slides, and we can straight away go to the discussion so that Dr. Smita Shah, Dr. Ritu, Smita ma'am, everybody can join. Dr. Panchal, Dr. Day, he's here. So in 5 minutes, we can just take the challenges which we are facing. The last slide, if we can.
So here, if the patients are of different regions, we must modify the diet as per where they belong to and the locally foods which are available. That really make the adherence and compliance very, very big. Because for every GDM patient, we need to individualize the diet plan. But there are some very, very important challenges that we all face that I think we will discuss at length now. There are many issues and points that we can take up right now.
Yeah, since Ritu is here, Ritu is known to be a technology queen. So Ritu, what is your experience about CGMS, especially patients who are on the nutrition therapy, who are not on insulin or any, for that matter, metformin as well. So what are your experiences about CGMS, use of CGMS in patients?
Absolutely.
With respect to carbs.
I think very, very critical to have, if the patient is counseled well and if the patient is really ready, CGMS is like a boon. Because, for patients in practice, when they also see the value of looking at their glucose in real time and are able to make changes to their insulin or to their diet as well, then it really makes a lot of difference in being able to bring up the kind of control that we're looking at, the A1C or the sugar control as well. So definitely CGMS is kind of a boon for both the doctor as well as the patient when it comes for GDM. But yes, the bigger question is the affordability and the understanding of the patient and the relatives. So you may use, 1 or 2 sensors during the entire 3-trimester course, but definitely the first trimester and the 3rd trimester are some places where the guidance on nutrition becomes absolutely easy if you can do the CGMS. Patients do understand the value of, the kind of dietary call that Ruby has just given us tips on, or like you were also mentioning that, there are literatures which talk about how to get that optimal control.
Yes. Smita ma'am, the practical issues. Can I ask my question to Smita ma'am?
Yes.
So, ma'am, the science is different. We advise diet to the most motivated diabetic patient who is a GDM patient. But finally, It is social and cultural background as well. She is probably daughter-in-law in that house or a mother of one child. So, how difficult do you find this macronutrient redistribution for her? In the whole diet plan. Do you change the whole kitchen recipe of that family, or only for her the customized diet sheet is given?
No, actually, at the first meeting, at the first time when she come to me, we generally guide him regarding the most probably in our Gujarat, all the patients are using more carbohydrate diet, So we focus on carbohydrate restriction first and explain the effects of the carbohydrate on the postprandial blood sugar. And they put him in the ambulatory glucose profile. So when we put them on the AGP, so definitely they will check. And after 1 week, we call them and we show the results of their diet. Okay, what you have done? We prescribe them the protein breakfast and they are not having protein breakfast, so their sugar will be go up. And we show them, hey, you have take poha in the breakfast and you can see the spike in your blood sugar. So we have to motivate them, we have to educate them, and continuous glucose monitoring. It will
I
have.
would like to add something here to what Smita Ben is saying. So all these changes, like, to change the protein and all, I think if we just change the recipe of the food ingredient, just that. So
Yes,
she doesn't have to cook
of course.
a separate, the
Separately,
entire
yeah,
family
the
decides to cook
Modification as per
separate
cultural
poha.
diet and the modification, that is most important. If the patient is you say that they are a rice eater, so we change in the rice and put some dal and all kinds of the preparation. We have so many diet recipes that include the fiber and low glycemic index, so we give them the recipes and that like and dislike, because in the pregnancy they don't eat the food that they don't like. So we, as per that, we have so many, we prepare the so many recipes for that, and we give them the recipes which low glycemic index, and they can help them. So that is the we treat them.
Ritu, I think you are keeping track of time. Are we done, or do we have some time?
We'll just, in the interest of time, we'll just take one last question.
Yes.
So you want to ask something, or maybe I have just one simple question. I think, very clearly you all have been practicing, and like you mentioned, Dr. Dakshata, that, the nutrition becomes the most essential piece when it comes to, managing the glycemic values of these patients. So Ruby, last question to you. How do you see patients picking up these practical tips? Because, we've been talking since morning that the most important thing is acceptability by the patient. That is utmost important. We may talk A to Z about what is needed to be done, what are the recommendations, but how do you see the adaptiveness of these patients to actually imbibe these cultural tips?
Well, in real setup, you'll find that among all the pregnant women, those who are GDM are the best patients for all of us in terms of compliance to the diet. And most of them are GDM, either they have a history of PCOS or they have a late pregnancy. Most of them have the reason. So for them, pregnancy is very, very, very precious. And not only her, it's the entire family who knows this and who's undergone the whole ART process. That's why I took this case, which is undergone an ART. For such a patient, everything will be up to the T. Her adherence and compliance will be exactly as per what you suggest. So even whether doing a CGM or changing the ingredients of the recipe, everything is possible, provided the entire family comes together and wants his child to be healthy and the mother to be child. So my suggestion to all those who are pregnant, the counseling should not be given only to the woman who is pregnant, but also to the other family members, her husband and a mother-in-law or a caregiver, so that everybody accepts it. That is the ultimate key for adherence and compliance. And do not change the diet plan 360 degrees. We change step by step, and as the sugar improves, her compliance becomes better and better. Her CGM is but the CGM, convincing someone for CGM is not very easy. But if it is done, it also saves her multiple pricks, which is also a very, very great advantage of doing a CGMS. So I think the only basic is keep it very, very simple, local, regional, and very economical. I think that's and a complete synchrony between the treating team, the doctor, which is either an endo or a diabetologist, and a gynecologist, who will convince her the same thing, and a diabetes educator if she's in place. Put together, I think it's not such a difficult diet. It's just a diet with slight modifications.
Wonderful. I think that's brilliant. Last closing line by Dr. Dakshata on your key takeaway message for macronutrients in GDM.
Yeah, I think last line is teaching GDM patient macronutrient distribution is very important. But I think teaching macronutrient distribution to all the pubertal girls who are between 7 to 10 standards, who are going to develop PCOD or probably GDM or probably obesity, will take us long way. So grassroots prevention level should happen at the school level when they are, on the process of becoming a woman. Thank you so much.
Brilliant. Thank you so much, Dr. Dakshata. Thank you all for helping us to try to get on time. So with that, we will move on.
Thank you, Ruby.
Thank you, everyone. Thank you, Dr. Dakshata.
Thank you. It was a good session, Ruby and Dakshata.
Thank you.
Thank you, chairpersons, for beautifully conducting this session. And we would like to move on to the next session, which again is in line with nutrition, where we're talking about micronutrients in consideration in GDM. So may I request Paheli Bhatt and Dr. Raja Selvarajan
eminent chairpersons to take the session further with our speakers for the session.
Sure, thank you. So our first speaker is Heti Verma. She is a registered dietitian and a certified diabetes educator. She is the founder of Nutritive Roots, and she is based out of Ahmedabad. She is an active member of IDA and IAPN. Corporate counseling she carries out with Panasonic, PwC, Healthify Me, Welspun, ITC, as well as Aprica. She has been associated with Aprica Healthcare Private Limited. She is providing training to medical staff for diabetes management at a pan-India level. And she is also an outside faculty to various institutes. So we welcome Heti Verma for her presentation.
A very good evening to everyone. Am I audible?
Yes, you are. Yeah.
Not able to start my video. I'll just share my screen. Is the screen visible?
Yes, it is.
Okay. Great pleasure to be a part of PSG again. I was a part in the first conference. Good to see everybody here. The topic here that we are going to talk about is very, not touched upon so frequently, and we miss out as clinicians and as medical practitioners. We hear a lot about carbohydrate management, but we miss out on the micronutrients. And as we know, very importantly, that all the preterm defects, talking about all the birth defects, that has to be, as the GDM itself is a complication. GDM itself is a complication. The macronutrient management is equally important to prevent side effects during gestational diabetes and pregnancy. We look upon all the major for controlling the pregnancy-induced hypertension. As you know, it is important for the muscular development and the bone development. Zinc, again, important, which is not looked upon. The RDA values, though is increased only by 1.5 milligram during pregnancy, but also is required equally on a daily basis. Folate, the most important element, which is almost twofold increased during the time of pregnancy. Very important in controlling the birth defects. If the folate levels are low, it might lead to preterm babies, also megaloblastic anemia in pregnant women, and later on also cause anemia in the child. Similarly, iron, though the levels are not, requirement is not increased much, but as you know, in the Indian scenario is very important, as every woman, almost 50% of women come with iron deficiency. So the start itself is very important for us, that we are taking care and checking up all the micronutrient status, especially the ferritin levels, the B12 levels, when the patient comes in. Magnesium also on a regular basis is important. A low magnesium level is classified with preterm birth defects, preeclampsia also. Vitamin C having antioxidant properties also can lead to, the high, because during gestational diabetes there is large amount of oxidative stress. So it's important that we are giving up all the types of micronutrients that de-stress the oxidation, and it is also important for the intrauterine growth. Vitamin A again is not taken in a higher amount. In fact, you might have all heard of about also not giving raw papaya to pregnant women. Many of us hear about that. That's because of the excess amount of vitamin A. So vitamin A should be given in the optimal amount naturally. We do not give any kind of excessive vitamin supplements. Here in the table, we have also mentioned the form in which the multivitamin or the particular supplement the particular micronutrient should be supplemented. The second table suggests the major, these are the, I would say, the mini micro ones, which are again the B complex vitamins. We usually give a Obligasool or a multivitamin where we see that, all the micronutrients are taken care of. But as medical staff, as nutritionists, we should also take care that not only these B complex vitamins are just given as supplements, but also naturally. So individually, Dr. Kancha would be taking up each of them.
A very good evening to one and all, and it's a great pleasure again for being invited at PSG. I'm Dr. Akanksha Patra. I'm an endocrinologist from Surat. So we have tried today to incorporate the importance of micronutrients in pregnant females, and typically we'll be bringing you forward with a very interesting case, which we as endos and gynecologists see day in and out, but there were some minor mistakes which could land that patient into major complications. But to give a highlight of really how important these vitamins and minerals are, we'll be trying to give you a highlight of everyone in detail. First one would be the calcium. So it has a major role as an antihypertensive agent, not being classified as an antihypertensive agent, but it has a beautiful effect of preventing PIH for that matter. And also, if there is preeclampsia, it again with magnesium and calcium, both of them play a very vital role in prevention and also in helping the treatment part for the same. So the most important thing why the requirement of calcium increases is because around 300 milligrams per day of calcium is absorbed by the child from the 30th week of pregnancy in a major form. And the most important challenge with respect to malnourishment for calcium would be landing our patients into PIH, and that has dreaded complications, as we all know. And just supplying optimal dose of calcium is going to help us in preventing the risk of preeclampsia. And it has been documented in multiple studies that it could help us in reducing the risk of preterm births by 24% and risk of PIH by 55% in pregnant females. Again, it has a great role in immunomodulation also, as we know, and it has been also documented that it has a very vital role in pancreatic insulin secretion, which is of grave importance, typically in females right now from the first trimester itself. With respect to one more, implication of the same through the RCTs that we wanted to highlight was that one of the RCTs showed that 70 pregnant women were given vitamin D and calcium doses to their optimal requirement, and that proved beneficial not only in improving the glycemic status, preventing glycemic fluctuations, improving lipid oxidation, and preventing the oxidative stress in GDM females. Next, please. Yeah. Second, to give you a highlight again of the most important factor of using vitamin D is the doctor of skeletal health. We can say it as that, and it has been documented that around 60% of pregnant female are D3 deficient, and vitamin D has been has been having a lot of pleiotropic benefits, just not skeletal health. And it is actually having a lot of anti-inflammatory properties that we could really document even during the time of COVID, where it helped us salvage a lot of patients who were who could be prevented from going into complications. So not only that, it also helps in having optimal insulin sensitivity in patients with good vitamin D levels, and also has regulating cell proliferation, differentiation, and better glucose metabolism. Lesser the vitamin D, the patient is at higher risk of developing GDM. And vitamin D, through its multiple implications, it also helps in preventing visceral adiposity, and which is a very key factor in preventing GDM. Next, please. Another very important mineral, for that matter, to discuss would be about the B9 vitamin folate. And folate has been, a very important factor again for known as a savior of, for the for preventing birth complications. And typically, we know it is a very important vitamin for managing the cell division and DNA synthesis. So it has been very well documented that 5 milligram per day of folate is a must to be started actually 3 months prior to planning pregnancy, and it could reduce the risk of birth defects by 78%. And insufficient folates obviously not only has a poor implication on females with respect to increasing GDM incidence, but also on the health of children. And the deficiency could implicate into developing neural tube defects, Down syndromes, preterm deliveries, and elevated homocysteine levels. So it has to be sought for at timely initiation of this is very important. Next, please. There are multiple sources of folate that we could tell our female patients to be taking during pregnancy and even before planning pregnancy. All luciferous vegetables you can clearly see, and typically the broccoli, the chickpeas, and the lentils, spinach have been found to be quite enriched with folate, and they are a great go. And even tomatoes and strawberries, walnuts are also a great go for our patients. The most important thing is whenever we are supplying folate, we cannot miss B12. And when we are supplying B12, we cannot folate. They are the sibling supplements, as they both of them manage the one carbon metabolism, which is very much important, as they act as the methyl donors in their diet. And everything begins with DNA methylation. And DNA methylation is actually going to reciprocate into gene expression. So if the beginning of the DNA methylation is at defect with responding to reduced amount of actual requirement of B12 and folate, which is not supplied well, it could implicate into genetic mutations. And imbalance in the B12 and folate levels actually are the very are at a very prime importance now for creating the visceral adiposity because of disturbance of one carbon metabolism. And it has been also seen in multiple studies that lower the maternal folate levels, it indirectly corresponded to increased adiposity in children. And low B12 level in mother predicted high insulin resistance in babies, which is again, it's a very preventable thing for us, and we should be more and more forward for giving this very important supplementation, vitamin supplementation to our patients. And it has been now we are documenting more and more children who have a lot of visceral adiposity. They also have very less B12 levels and folate levels. Next, please. Hiti, you can take forward.
Sure. Yes. So talking about the two most, as we know, like Dr. Akansha just said, vitamin B12 as well as talking about iron, they go simultaneously. As far as anemia is concerned, we know that we have all types of anemia, and majority, 50% of the pregnant women are found to be anemic in India. So talking about gestational diabetes, also we have to look upon that iron levels are taken care of, as iron is very, very important in child development. It's also important for all the kinds of enzymatic processes which involve the brain development of the child as well. So from the very start, we have to make sure that iron, B12 and as well as folate are given together, depending upon the levels. So iron and calcium, few tips that we should take care of, as we know that iron and calcium have a complete opposite absorption mechanism. So they should be and should not contradict each other. So iron and calcium should be taken at least a gap of 3 hours. Usually clinicians try to place the iron supplements like early in the morning, which are taken empty stomach, and calcium is usually given after meals, post lunch, at least by more than 3 hours of gap. We usually recommend like at least 6 hours. So either post lunch or post dinner. Vitamin C always helps in increasing iron absorption. That is why we try to practice that we ask our patients to squeeze lemon in all your major meals, because iron sources mainly come from whole grains. The richest source of iron is dates. But considering all our whole grains and pulses are also good sources, So whenever our patients are taking your main lunches and dinners, try to advise them to squeeze a full lemon in it for better iron absorption. Also, early in the morning, if your patients are taking a little bit of nuts and seeds, they are also good sources of iron. So vitamin C, lemon water, along with on an empty stomach, will increase the iron absorption even more. Again, studies showed that extremely low levels of iron of GDM women was found compared to normal pregnant women in a 2012 study. Similarly, I found a study from an Indian data, in fact from Coimbatore, on zinc and magnesium as well, showing again comparison between the control group, that was the pregnant women, versus GDM patients, and we could see the mean levels of both serum zinc and magnesium was lower in cases of GDM as compared to normal pregnant women. So can you see the difference almost by one gram or more? So zinc again is important as an enzymatic, zinc and magnesium both as an enzymatic action, and also they have an action action of insulin. The Christopher graphic studies, when we see at the micro level of zinc, we can of insulin, we can see that zinc crystals are also found. So it has a very close relation, both zinc with insulin, and also zinc has a role in the maternal and fetal tissue accumulation. Magnesium similarly is important in carbohydrate metabolism and is also an activator of many enzymes in insulin dependent for the absorption of glucose. So again, the study showed low magnesium, serum magnesium levels in GDM patient compared to the control group. Few iron-rich sources and covered zinc-rich sources are mainly from your nuts and seeds, legumes again. Egg yolk is the richest source, I would say, for all B complexes, for all zinc, magnesium, all minerals. Egg yolk is the richest source. Similarly, for magnesium, poultry-rich sources, even avocados, some nuts and seeds are good rich sources of magnesium. Where a few of the minerals, if we talk about, which we don't look up on, are mercury, where we have to be extremely cautious in case of patients for all pregnant women, because high mercury sources can cause dangerous, cause deaths also. So fishes such as sharks, swordfish, tilefish, and mackerel, which are high in mercury, should be completely avoided. And even if patients are taking fishes, somebody who's a non-vegetarian, you would limit it to only 1.5 gram per fortnight, that is once in 15 days. Chromium is a very essential, again, and many studies are coming up, but not enough data to prove it right. But chromium picolate is the picolinate. Am I right, Dr. Kanchan? Chromium picolinate, right?
Yeah.
Is the most absorbent form of chromium, and many studies are coming up where chromium has also shown significant results in insulin signaling. But there is not enough data. In fact, beryllium salts also present in like small amounts in dill seeds, black pepper. It's usually a metal which is found very low amount in the food sources, but so enough data is not there, but studies have shown that it helps to reduce the glucose levels in diabetic patients. Omega-3 fatty acids, as we know, as I said and started, that the entire gestational phase and gestational diabetes is a case of very high oxidative stress. So all antioxidant agents, especially omega-3, EPA and DHA will be very good and important, and also for the neurodevelopment of the child, also important in vasodilation, reducing the inflammation. And last but not the least, even few supplementing of probiotics and bioinositol, especially in the case of GDMs which having a comorbidity of PCOS. It is good that we, at the early stage, we are giving iron-inositol.
Okay, so we'll quickly run through the case. I'll be just giving you the synopsis of the case that we had prepared. We had a case of a 27-year-old primary gravida who presented to us in the second trimester during her 20th week of gestation, and she was diagnosed with GDM with the fasting sugars of 80 and postprandial sugars of 210. And she had typical symptoms of fatigue, breathlessness, constipation, vulvovaginitis, and tingling sensation in feet. And on physical symptoms, it showed she had periorbital edema and non-pitting pedal edema, and dryness of skin and grade 1 goiter. Next, please. This patient actually, in her first trimester itself, was diagnosed with hypothyroidism, and there were some implications with respect to the proper guidance which she was not given, and that we'll try to highlight.
Sorry.
All right. So talking about her physical characteristics, typically stubby looking woman with a BMI of 30, and she had a comorbidity of PCOD with her parents both being diabetics and mother being a case of autoimmune hypothyroid. Next, please. When you check her lab parameters, when you check her lab parameters, in the first trimester, when she was looked upon by the physician, her hemoglobin was just 10.5. Her fasting sugars were normal, and her postprandial sugars were normal. Her HbA1c was also normal. TSH was high, for which she was prescribed 75 micrograms of thyroxine. Her anti-TP antibodies were positive, more than 1300. She was deficient in B12, in calcium, and vitamin D. In second trimester, when she presented to us, she told us that she was given thyroxine 75 micrograms, optimal calcium and iron supplementation, but still her iron was low. Her sugars were, for first time coming into the GDM range with 20 weeks of gestation, and HbA1c also cropped up to 5.9%. TSH was still not under control, even in spite of giving 75 micrograms of eltroxin. And B12 was still in the sub levels of 350. Calcium was okay, and vitamin D was also still in the insufficient range. Next, please. Then we tried to understand the patient's, how this patient was taking the supplementation and the thyroxine. So what happened was, this patient was taking thyroxine in the morning when she got up, but she was taking almonds and jeera water along with eltroxin. This was the first mistake that she was taking, that she was doing. Secondly, she was taking calcium and iron together. She was not keeping the gap, as Heti was trying to highlight, that there has to be a gap of minimum 3 hours between iron and calcium. And also, this female did not keep even the gap of 2 hours, which is required between eltroxin and any supplementation like iron or calcium. These were the two major mistakes this patient was making. And for her insulin, for her sugar controls, she was prescribed bolus insulin for her postprandial sugar spikes. And this patient was made to understand when she presented to us that what was the dietary intervention that had to be made. The macronutrient portions have been beautifully discussed. But with respect to micronutrients, the timing which was very much important between iron and calcium was explained to her. The timing which had to be kept between thyroxine and the supplementation was educated to her, and natural substances which could increase her iron levels and calcium levels, because we typically understand that patients with autoimmune hypothyroidism also have antiparietal antibodies which could land these patients into less vitamin B12 levels and poor absorption of iron. And for that matter, such patients require proper counseling, and the mistakes were rectified for that patient, and we got better results for that. Heti would just like to conclude with the dietary interventions that you made with that patient, please.
Yes.
A quick jiffy, yeah.
Yeah. So, like Dr. Kansha also mentioned, her dietary patterns of eating were already disrupted, and moreover, the major meals also were very high carbohydrate rich. Like you can see that, she was mainly eating carbs. So, there was lack of fruits and vegetables in the diet mainly. No salads in her major meals, and in fact, her calcium intake, natural calcium intake, was also very poor. She was majorly taking khakras, bhakris, and rice throughout the day, and her overall protein intake was only 35 grams per day. Macronutrient status also, we can see that all fruits, vegetables, calcium, all of them are lacking. So, for the dietary interventions, we were increasing her fiber, and the patient was also highly constipated. So, to improve that, we increased water intake as well as fiber intake. since the patient used to crave a lot of sugar and also see that the sugar levels were high postprandial of the meals, we try to incorporate natural sugars for her in the form of milkshakes and khajur in the diet in the form of natural sugar, which is also high in iron. In fact, if you are incorporating spinach in the form of blanched form and not crushing it also in the daily diet and giving it, or maybe doing a green juice therapy also helps overall the hemoglobin status because the hemoglobin was also very low. So we try to incorporate all these measures for improving her micronutrient status and adding lemon to both the meals, like I had explained. So overall, concluding, when we are talking about improving the micronutrient status for gestational diabetes and overall pregnant women, we should make sure that apart from taking the normal nutritional meals, they are also taking natural mineral-rich foods that is mainly and nutrient dense also, that is mainly coming off your natural mineral coming from fruits. In fact, you can also include coconut water, nariyal pani, very, very important. Once in a day or maybe just one piece of coconut, the patient can start during the day, start her day with it. Practicing exercise also is equally important as it will also help in regulating and improving the metabolic status and the metabolism of the patient. It's very important that we are practicing good hygiene methods also, like washing of the vegetables and fruits in a right way so that the absorption is again good and whatever the patient is ingesting is in a pure and a good form. And regular follow-up is definitely a must with the entire team, not only the physician, the nutritionist, all of them. In fact, the diabetes educator also in case of high glucose levels. Thank you.
Thank you so much, Dr. Heti. Dr. Raja, over to you. You don't have any question, but for the constraint of time, we would like to keep it just to one.
Okay. Excellent presentation by both the speakers. In fact, I have one question to Dr. Akansha. Dr. Akansha was a very crisp presentation. I would like to hear from you whether do we follow any pre-gestational assessment of these micronutrients? We talk about supplementation once the patient gets pregnant, or probably many times we fail to do that as well at the rural setup. Do we have any set guidelines, or do we tend to practice a pre-gestation or a pre-pregnancy micronutrient assessment?
Thank you, Dr. Raja, for that question. And I think we very well understand that now most of the females are quite aware about planning pregnancy and preconceptional counseling. So when they are now coming to their gynecologist, most of the time they are obviously screened for pre-gestational diabetes nowadays. So for that matter, because PCOD is quite common, so that is a very important factor. And when these females are being tested for sugar levels, they are very much also tested for their hemoglobin levels, the iron concentration, and the folate and the B12 levels and calcium levels. But there are, as of what I know, the CBC is something which is mandatory and which is being done for all the patients, but not the other vitamins like B12 and folate are not being done. But we, as we see in our Indian population, most of our females, even from very highly refined, societies, they are still having iron deficiencies, still having B12, vitamin D deficiencies. So they are not being, implicated to have these before planning pregnancy. But nowadays, the gynecologists are quite proactive, and they, even before planning pregnancy, they try to implicate these things. I think 3 months before the pregnancy, the gynacs through which we work with, they work in coordination with us. And PCOD females are quite very well maintained with their levels because they are already having good follow-ups with us. But not all females, depending on the place where every female is.
Excellent. I think the takeaway is there are multiple papers which are coming out implicating the pre-pregnancy micronutrient addressal has shown to reduce the incidence of GDM, and as well as probably if they are having a diabetes, I don't know if the GDM sets and the complications related to GDM as such has come down significantly. There are multiple studies across our borders, but I don't find anything from our soil. The one study, I think, from CMC, which has come down, has shown both macro and micro being deficient grossly across all our pregnant women across the, I think that should be the figure across the country as well. I think we should stress up on addressing the micronutrient and the macronutrient deficiencies even before the plan for pregnancy. As doctor said, possibly a preconceptional counseling is where this has to be ideally kick-started and should be the way it should be taken forward. Excellent talks by both the speakers. I am done with my questions. I think it was excellent. Thank you.
Thank you so much, Dr. Raja. I think brilliantly covered the entire piece on both macro and micronutrients. Thank you so much. And thank you so much, organizers, for giving us this brilliant opportunity. With that, without further ado, I would like to pass on the baton to Dr. Supratik Bhattacharya for taking us for the next big session. Over to you, Dr. Supratik.
Hello, everyone. Give me a minute. I'm trying to get connected to the audio.
And you're audible, Dr. Supratik.
Am I audible at the moment?
Yes, you are audible.
Okay. So thank you so much, Dr. Rutul, Dr. Dharmendra, Dr. Amit, for inviting us and having this symposium today. I think it's very pertinent in today's context where we are talking about pregnancy, and we are highlighting all the complications and areas that are related to pregnancy. So I think in this context, obesity becomes very, very pertinent, and so does the endocrine problems that arise during pregnancy per se. So for this, we have our chairpersons, Dr. Sonali and Dr. Paiki Saxena, for this particular session. And I'm very glad that all our AMOS members are on board. So we have all of these three that we talked about, Dr. Amit, Dr. Rutul, and Dr. Dharmendra are part of this AMOS family, and so is Dr. Minal. And I see Dr. Arun here. So a warm welcome to all of you. And I'll let the session be taken over by the chairpersons.
Chairperson, Dr. Sonali.
She online? I think.
Dr. Supratik, you may introduce our speaker.
So just as a context, so AMOS started out as a group of like-minded people who has interest in research and academics, especially in the field of obesity medicine and clinical endocrinology per se. And for this, we have our first speaker for the session, Dr. Minal Mohin, who's a thorough academician. She is now the consultant and head of Department of Endocrinology at Manipal Hospital, Jaipur. And she has her own center, which is a Shashakt Endocrine Center. And she has got many achievements in the form of being a mentor of Team India. So this is one of the international competitions that has been won as a part of the competition of the ACP India chapter, and also pioneer of the Cloud Clinic venture among us COVID-19. And she has been editor of Meribeats, reviewer of JAPI, founder secretary of Metabolic Club, founder Women Practitioners Club, one of the founder members of AMOS, and governing council member of RSSDI Rajasthan chapter, and scientific convener of Epicon 2022. So with all these achievements in place, it's an absolute honor to have you, Dr. Minal. So we will start with your session, please.
First of all, thank you so much, the PSG group, Dr. Rutul, Dr. Amit, Dr. Dharmendra, for inviting me on this platform. And AMOS family is, yes, our very own family. So all my AMOS family members are here. But Supratik, there will be a little modification. I would request you to also introduce Dr. Arun Raghavan, because it's a joint talk, but with Dr. Arun. And Dr. Arun would be taking the first half of the talk, and I will be picking up after him.
Sure. So if I can have, yes, perfect. So again, a very good friend of ours, Dr. Arun Raghavan, and a thorough academician, and he's now the director, consultant diabetologist, and intensivist at Dr. Ramachandran's Diabetes Hospitals, and he's also the co-founder of Dia Home. He has done his graduation from Sri Ramchandra Medical College and general medicine from Sri Balaji Medical College, and underwent training for and research at prestigious Yale University, USA, training for diabetes at CMC, Vellore, and diploma also in diabetes and endocrinology from Cardiff University. He has also got critical care training at Madras Medical College and Apollo Hospital and Chennai, and obtained fellowship in intensive care. So it's conferred the fellowship by International Medical Academy, FEMSA, and also membership from the Royal College of Physicians. And he was also awarded the doctoral degree. He has done a PhD for his original research from MGR Medical University. And I think we are happy with all the information that we have on board. And it's absolute pleasure to invite you to speak on the topic, please. Dr. Arun.
Thank you, Dr. Supratik, for your kind introduction. I'm very happy to be part of this August gathering. I would also like to take the opportunity to thank Dr. Rutul, Dr. Amit for inviting me to be part of this academic feast. And I would also like to congratulate the organizing committee for curating such wonderful topics the next 2 days. And I'm also happy to share the platform with Dr. Minal. So with this introduction, let me start sharing my slides. Just a minute. All right. I hope my slide deck is visible. My slide deck is visible?
Yes, perfect.
Thank you so much. So what I'm going to do for the next few minutes is I'm going to navigate you through some of the data that we have over the years about what could be the ideal weight for someone who's planning pregnancy and someone who's going through pregnancy. I'm going to show you, navigate you through some of the data and also understand what obesity, what impact it has on pregnancy. And subsequently, Dr. Minal Mohit would deliberate on the science behind obesity. So all of us understand that women in general are quite vulnerable at two important milestones in terms of gaining weight. One, of course, during pregnancy and other during menopause. Now, during pregnancy, I think gaining weight is something which often it is overlooked about. We kind of neglect gaining weight. Although we know that pregnancy is this part of the world very well celebrated. Most of the times it's overwhelming. It's a very overfed state. I think a lot of times we kind of attribute overfed state, gaining weight to probably a better prosperity or a better health. What we need to understand is that, overweight or gaining weight has a profound impact, not just during the term of pregnancy, not just on the offspring alone. It has an intergenerational healthcare consequence for both the mother and offspring for many, many years to come. I'm going to shed more light on that. And we understand that obesity itself is the root cause for most adverse outcomes that are encountered during pregnancy. Obesity itself increases the risk of GDM by about 4 to 9 folds. And obesity represents an altered hormonal and an inflammatory state along with the function of adipose tissue. We know that the adipose tissue does release peptides which kind of slow down the platelet degradation as well as increases a prothrombotic state. We also know that the adipose tissue releases peptides such as the interleukin 6, which also kind of modulates the release of CRP. All these increases the cardiovascular risk. We also know that the obesity, GDM have risk factors in the birth of the offspring, starting from macrosomia, starting from birth injuries, premature births, both large for gestational age as well as small for gestational age complications, as well as shoulder dystocia, so on and so forth. So there are multiple problems that the offsprings encounter during the birth, as well as I mentioned, there is long-term intergenerational complications for both the mother and the offspring. as much as having complications such as having overt type 2 diabetes, where the GDM itself increased the risk for overt diabetes by about 8 to 10 folds, as well as the risk of hypertension, cardiovascular disease, osteoarthritis, even malignancies such as endometrial cancers, breast carcinomas, as well as colonic cancer. So it increases so many complications even in the lifespan of the mother. And as I mentioned, even not just during the birth of the offspring, even in the life, it increases the lifetime risk of metabolic syndrome, type 2 diabetes, hypertension, so on and so forth, as well as the entire cycle repeats when the offspring undergoes pregnancy in her lifestyle, so on and so forth. Although we know that the risk factors for obesity as well as metabolic syndrome could be multifactorial, the intrauterine environment is very, very critical in terms of determining the lifetime risk of a metabolic syndrome. So this shows you data over the years about the association of obesity with macrosomia, hypertension, gestational diabetes, pre-birth, as well as cesarean C-section. We can see that there's a strong association between obesity and gestational diabetes. As I mentioned, it increases the risk of gestational diabetes anywhere between 4 to about 9 times. We also have data from a Canadian study that over 50% of gestational diabetes can be actually precluded by mitigating gestational weight gain alone. Only with this, we can prevent over 50% of gestational diabetes. So that's the impact of moderating or maintaining or optimizing weight gain through the pregnancy. So the first guidelines was proposed by Institute of Medicine 1990. What we are seeing here is the revised guidelines, which was proposed in 2009, which categorized body weight into 4 categories: those with lower BMI, those with normal BMI, those for overweight between 25 and 29, and those with the obese over the BMI of about 30. Now, the recommendation, the thumb rule for weight gain is anywhere between 4 to 6 pounds during the first trimester and 1 pound every week thereafter. So that's the thumb rule. That's the recommended weight gain. Of course, subjects who are obese or overweight, the weight gain is less moderate, less compared to those who are underweight. There is no recommendation for weight reduction. It is only about weight maintenance, stability, even for subjects who are overweight and those who are obese. Now, this study shows you the relevance of the recommendation that we just saw, the Institute of Medicine's recommendation in terms of optimizing weight through the journey of a pregnancy. Here, this compares subjects who achieved weight below the recommendation to those who achieved weight, who had weight much more than the recommendation from the IOM. So as you can see from the data, the C-section, the risk of having more severe diabetes and more intensive therapy was, of course, much higher in those subjects who had much more weight gain than the recommendation. In contrast to those who had a lower weight gain, were able to manage their diabetes quite successfully with only nutrition. They had lower incidence of cesarean section. However, they actually had lower birth weight as well as small for gestational age births. So it just shows you, of course, reinforces the fact that proper nutrition and proper weight is indeed required for the development of fetal tissues, as well as creating reserves for lactation during the postpartum phase. Now, this Chinese study actually sheds light, kind of decodes whether these kind of recommendations that we saw, the IOM recommendations, is for the Caucasian population. It is a recommendation which was from the United States. So does that apply for Asian subjects is what this study kind of decodes. We know that the Asian phenotype is quite distinct, which is different from the West Caucasian phenotype. So here we had different BMI cutoffs in the Chinese subjects, had the lower stringent cutoffs compared to the proposed IOM BMI. And what was seen is that according to the lower BMI cutoff, these subjects had a lower risks of macrosomia as well as large for gestational age. However, there were not much of the significant difference in risks of preterm, low birth weight, as well as small for gestational age. So this study kind of opens up the discussion that probably in this part of the world, perhaps we need to have a stringent BMI cutoffs than what is being proposed from the IOM. This is a new study which shows that about 1/3 subjects in the GDM group had excess gestational weight gain with reference to the IOM recommendations. Almost about 1/3 of them seem to have excess weight gain. And now when you look at the risk for large for gestational age was significantly higher in subjects who had normal glucose tolerance but had excessive gestational weight gain, and also those who had adequate weight gain but who had gestational diabetes. And if you look at the odds ratio was twice in those subjects who not only had excessive weight gain but also had gestational diabetes. So subjects who had both gestational diabetes as well as excessive weight gain had twofold increased risk of having large for gestational age infants. So this is another study which kind of decodes, makes us, the recommendation that we saw is for normal gestation. Can we apply this for GDM is what this study decrypts. So looked at having a lower cutoffs in terms of the weight gain during the course of pregnancy, such as 1 kg as well as 2 kgs. And the 2 kg reduction had a lower prevalence of LG and macrosomia delivery. So this kind of speculates that subjects who are diagnosed with gestational diabetes should have tighter weight goal strategies compared to the actual recommendations as such. So those who are diagnosed with gestational diabetes, what are the effects of the treatment as such? We are cognizant of the fact that, of course, the sulfonylureas is going to contribute to weight gain. Insulin is also going to contribute to weight gain. What the study demonstrated is insulin contributed to much more weight gain than subjects who are on sulfonylurea, and the least weight gain was seen with those subjects who are able to manage their blood sugar levels only through nutrition. And another data that we learned from the study is that those subjects who had better glucose control had better weight scale than compared to those who had uncontrolled blood sugars. Those who had uncontrolled blood sugars had much higher weight gain according to the recommendation than compared to those who had actually optimum blood sugar control. So this again corroborates with all the findings that we've seen earlier. This is a study from Japan, which shed light on that both the pre-gestational BMI as well as the gestational weight gain are both important in association with the infant birth weight. They're significantly, as you can see, the statistical is very significant compared to when you look at both the pre-gestational BMI as well as the weight gain which happens through the pregnancy. And if you look at subjects who had a BMI over 25 pre-gestation, even in those subjects who had a normal weight gain, the BMI pre-gestation alone had an association with the infant birth weight. Similarly, those who had a normal BMI before pregnancy but had a much higher weight gain compared to the recommendation also had an association with infant birth weight. So this kind of corroborates from the earlier findings that both the pre-birth weight gain as well as the weight gain that happens through the course of the pregnancy are both important in the association with infant birth weight. Now, how do we control the weight gain that happens? I mean, back to the basics, as we can see through multiple studies that have shown the way. I think going back to fundamentals of the nutrition as well as physical activity, in fact, is the cornerstone in terms of optimizing weight through the journey of pregnancy. We've seen again enough data to show that even early pregnancy exercise reduces the incidence of GDM by about 28%. Even exercise during early pregnancy within the first trimester also reduces. So we've seen a lot of enlightening sessions on the nutrition. So I'm not going to deliberate much on that, but just some key takeaways: increase fruits and vegetables of at least about 400 grams per day, and less than 10% of total energy intake from sugars, and less than 30% of total energy from fats. And what is important is also to return to normal weight within about 6 months after delivery, because those who continue beyond 6 months are likely to retain weight lifelong. And again, the data shows that those who have achieved, those who have gained weight more than the recommendation from the IOM are also likely to retain weight post-pregnancy. So there is a lot of scope. Of course, there is only about, the data again shows only about 17 to 18% are actually following the recommendations. So obviously this is not enough. Much work needs to be done in terms of percolating this message, reinforcing how important nutrition, physical activity is. Of course, there are a lot of gaps, but at this point in time, the landscape has indeed changed. We have a lot of fitness trackers. We do have the CGMS, and there are a lot of studies underway which would which would kind of pave way for more better outcomes. We'll get more data in the near future to see how better we can improve outcomes in pregnancy. So with this, I would like to pass on the baton to Dr. Minal. Thank you.
Thank you, Dr. Arun. And before I take it up from you, I would ask the permission of the moderator. Would he like to intervene, or should I jump?
Yeah. So Dr. Minal, please continue with this session, and we'll take up any questions that we have at the end of the session.
Right. So thank you, Dr. Arun. You've set the platform just perfect for me. And just continuing from your session, you have talked about obesity and pregnancy, the weight gain, the Institute of Medicine study, and the newer targets, newer guidelines. So just to talk, what exactly is the science behind obesity? Whether we are talking of pregnancy, during pregnancy, or without pregnancy, even in men, because it's a PSG symposium, we will be focusing more on pregnancy, pregnancy and weight gain. But otherwise also, let's first understand what is the science behind obesity. So to put it in a very simple language, maybe it is just like, okay, the intake should match the output. And if the intake is not matching the output, there is something like savings account, and the savings account goes on building up. Right. So what is the role of the brain? What is the brain sitting up there doing? Doesn't the brain know that this is not the weight that we need to put on? So we actually eat in 3 phases. One is a homeostatic eating. That is, you eat when you are hungry. So when you're hungry, you eat. And this is the point of time when you actually eat whatever is served. If you are served salads, you will eat salads. If you are served fruits, you will eat fruits. And otherwise, even if you know the things are wrong for you, if you are served non-nutritional and calorie-dense food, you will end up eating the calorie-dense food. So this is homeostatic eating. After the homeostatic eating, there is something called hedonic eating. So, Dr. Arun, can we move on? Can we move to the next slide, please? So this is the hedonic eating. Now, after eating a plate of salad, when you are hungry, and after eating a plate of nutritious, calorie-dense food, your brain now knows what is the pleasure of eating. So your brain has registered that the salad was just filling my stomach, but not filling my brain. But this delicious food, or the food delicacies, are filling my brain as well as my stomach. And they're also filling my adipose tissue. So there is something called a hedonic eating, that we eat because of pleasure. And there are hormones for hedonic eating as well as for homeostatic eating. So for homeostatic eating, we have something called a balance between leptin and ghrelin. Ghrelin is your hungry hormone, which tells you that, yes, I am hungry. Whereas hedonic eating is a result of your dopamine, which tells you, wow, I like it. I like a burger or a chocolate or some ice cream. I don't like a plate of salads, of course, and the greens definitely not. But this is homeostatic eating. And now we are talking of hedonic eating. Now there's something called the intelligent part of you, what Dr. Arun was telling, the research. There is something called executive function of the brain. You know what is pleasure eating, you know what is homeostatic eating, but there is something called what to do, the deciding factor, or the executive eating. So it is the executive eating which tells you, go for your homeostatic eating only. Don't go for hedonic eating. So we have to actually, as a part of the brain management or intelligent management, we have to carry out or maintain a balance between homeostatic eating and the hedonic eating. But when the two actually fail, when the balance fails, our behavior or the behavioral tilt goes in favor of hedonic eating, then that is perfectly the time of pregnancy, when women actually have all their food fads, and that food fads are happily served by the entire family. Rather, the women is suggested that what they should be eating or what they should not be eating. So that is the time when the entire family is suggesting for going for a hedonic eating. And as a result, women during pregnancy not only end up gaining weight, which is the target weight, but the target is often overshot. The recommended weight gain in a normal pregnancy with ideal body weight is somewhere around 11 kgs, but any average Indian women end up gaining somewhere around 15 kgs in every pregnancy. And that weight gain is never lost back to the normal pre-pregnancy weight. And at that point of time, there is another pregnancy after, say, 2 years gap or a 3 years gap, and another 15 kg is put on. So that is how the weight goes on building up. What are the complications associated with obesity? That we all know, the metabolic complications. And the list remains the same, whether it is a pregnant state or a non-pregnant state. Rather, in pregnancy, the challenge is that the similar metabolic complications are also transmitted by epigenetic mechanism to the next generation. And you will be surprised, but if it is a female fetus, then the similar pattern of metabolic derangement is transmitted to the third generation, because the ovum which are there in the female fetus are also affected. So the 3 generations are actually affected by metabolic complications if the woman puts on extra weight or the metabolic complications set in during pregnancy. So now, moving back to the house, and of course, Arun, you will help me here by just jumping inside along with me. Do you think this weight gain, which is actually recommended since ages, and all our grannies have been telling us, eat more, eat for 2, you have to fulfill the food for 2 now, eat properly and eat more, eat double, gain weight, all our obstetricians sitting in the house maybe, or even our colleagues, they have been telling all our pregnant women, your weight gain is not proper, eat more, put on some weight. Do you think this weight gain can be safely limited in pregnancy, or is the pregnancy going to be affected if we really cut down on the weight gain which is recommended during pregnancy?
Rightly said, but of course, I think this myth, I think we should largely overcome. We should burst this myth, and we should, as I was also mentioning through my talk, I think a lot of education and awareness should be enforced in actually optimizing weight gain through pregnancy.
Correct. So this last point, advise target gain accurately. So we as doctors have a very big responsibility of setting individualized targets for all your pregnant patients, depending upon your pre-pregnancy BMI. So depending upon your pre-pregnancy BMI, draw a chart and send the patient home with the appropriate target that they are supposed to gain or may not gain during pregnancy. So next would be Arun. My next question would be, though you have talked about the IOM guidelines, that is the Institute of Medicine guidelines or the recommendations, do you really agree that these entire guidelines can be extrapolated or projected to the entire population on Earth, especially the Indian scenario?
Yes, ma'am. Like I showed the Chinese study, in fact, over there, the stringent lower BMI cutoffs had better outcomes in the Chinese subjects. So I think, of course, if you cannot directly extrapolate, we need to kind of personalize according to the Indian setting. We may need to have much stringent BMI cutoffs than what has been recommended by the IOM.
So I think that can go a very long way, Dr. Arun, if the PSG group decides to come together and we can find out our own Indian recommendations or the pregnancy target weight gain recommendations, and we can work out something and have our own guidelines very soon.
Yeah.
So moving to the next question, very important question that really stands for all of us, because we are not obstetricians, we are physicians. So the most important question is that the patient is back to us after delivery and she is now with us with an increased BMI and another additional 5 kg weight. So how can we actually work out and make our patient go to their pre-pregnancy weight So what exactly are the important recommendations very crisply that we suggest our patients to get back as early as possible to their pre-pregnancy weight? So you've shown a thank you slide, but you need to answer. So what are the major recommendations are? Number one, please breastfeed. Lactation is promoted and at least for 2 years. Then begin your exercise and diet control immediately. Break the age-old myths of eating a lot of ghee, laddu, and gond or something, which is a very traditional food here, and with a lot of ghee and a lot of sugars. So please break all those myths. No ghee and sugars are required for your healthy outcome of the pregnancy or healthy outcome of the baby and the mother. Continue lactation and begin your exercise as early as possible. Come back to your pre-pregnancy weight and rather utilize your pregnancy period to lose some weight rather than gaining weight, which goes a very long way in preventing your and your baby's metabolic future. Thank you.
Right. So thank you so much for your input, Dr. Minal and Dr. Arun. So I'm going to have some open-ended questions which both of you can answer, so please take your turns and whoever wants to chip in. We also have Dr. Swati Srivastava here. So she might ask a few questions as well. But I think we'll start off by asking you a tricky situation, which I come across very commonly in my clinical practice. It's when an obese individual comes to you saying that she wants to become, she's thinking of planning family and she wants to do it right away. And, and also we see that, probably she's in a region where, the sugars are high and you are a bit worried about how the sugars are going to be during the pregnancy as well. So, what would be your call? Would you be addressing obesity at that point of time, or would you be prioritizing the pregnancy? And how would you watch the weight? And what would be the healthy weight gain over the various trimesters that you're looking at?
Dr. Arun, would you like to take it?
Sure, ma'am. Yeah.
Dr. Arvind Jagdisha is also here. Dr. Faraj is here. So Dr. Rajesh is here. So wonderful. So we have the entire Ramos team
Dr.
here.
Arun is muted.
I'm on mute, ma'am. I think I'm on. Yeah. Thank you. Thank you for the question. So I think you raised a very pertinent issue there. Now that's a catch-22 situation. I think a lot of factors come into play, including.
So, Dr. Arun is talking.
Am I audible? Yes. Yeah.
Arun, I think you're muted. Could you please check, because?
No, I think a lot of them can hear me.
Yeah, I can hear you.
Yes, you are audible, perfectly audible.
Audible. Yeah. Sorry. All right. So I think a lot of factors come into play. Of course, we need our obstetricians, our colleagues' advice also on that front. Multiple factors, including the subject's age. So many factors come into play. But if you ask from a metabolic physician's perspective, of course, I would like to, first look at lifestyle modification, get some pounds down, shed some kilos. As I've shown through some of the data, that pre-gestational BMI does have a profound impact during the gestation period, as well as on the birth of the offspring. So it is very, very important that we address weight even before conception. So that would be my perspective, my take. But of course, you need our colleagues, obstetrician colleagues, as well as, it's a multifactorial intervention about that. And as you said about the weight gain, and if they do, contract pregnancy, of course, those subjects, as I again showed through my presentation, who are either overweight or who are obese, the general recommendation through the pregnancy is no weight loss. It is about, weight stability, maintenance of weight. That's what is actually recommended. We understand about 30 to 35% of weight gain is actually attributed to the fetus and the placenta. The remaining weight is attributed to the fat, lean mass, as well as the water. So we need to optimize weight gain in those subjects who are either overweight or who are obese.
Yes, I think that is very rightly taken. So, Dr. Supratik, if we have an option of a planned pregnancy, then we will recommend the lady to lose some weight and enter. If ideal BMI may not be possible, if as you are putting it up as a very obese lady, so we will definitely request her to work on her lifestyle initially. But if it is not a planned pregnancy, and if she happens to visit your clinic only after she has already conceived in the first trimester, maybe, then the recommendations would be that avoid gaining much weight, or at least do not gain weight more than 4 to 5 kg during the entire 3 trimesters by focusing on diet mainly, because exercise is again one part where we are limited during pregnancy. We'll have to follow the advice of the obstetricians again, that how much of the exercise is recommended because of her uterus status. We really don't know that part. But one more additional input I can share with the house, or maybe the house can enlighten me. This type of cases are one of the worthy cases where, because you are saying she is diabetic also, we can take the opportunity to continue with metformin along with insulin, so that we can at least control her appetite and we can control her further some weight gain. That is one of the recommendations that I think we all would agree upon. But otherwise, only thing that goes very long way is the diet.
I think that's very pertinent what you said. So clinically, what I usually do is counsel the patient and say if you can defer. So I am in favor of using a GLP-1 receptor analog in this scenario to bring down the body weight for some time. I also talk about contraceptives, that they need to use contraceptives so that they don't conceive at that point of time. And once I'm satisfied with the weight loss, then I advise them to plan their pregnancy. So that's how I take things forward. The second question, and I think this we'll keep it short because we have 2 more speakers on board. So my second question is, once you have delivered, so how do you help the person to achieve the pre-pregnancy weight? So what are the multidisciplinary approach that we can sort of take on board to help her achieve the pre-pregnancy weight?
Again, I will ask Dr. Arun to first take it up.
Sure. So as Dr. Madam has earlier pointed out, I think much needs to be done about shattering the myths of overfeeding, particularly during the lactation phase. I think that itself could preclude much of the weight gain. And having said all this, I think resuming physical activity early after delivery is probably the best way forward. And we need to also educate that much of the weight, you have to achieve the pre-pregnancy weight within 6 months. That's what data shows. Because beyond 6 months, they tend to, most often than not, they tend to retain the weight that they have gained through the pregnancy. So again, going back to the fundamentals in terms of resuming physical activity as early as possible and with proper nutrition will be the best way forward.
Right. So here again, Dr. Supratik, first two important points remain. One is you talked about contraception. So again, the role of which contraception in obese women is a very important topic. Even if pre-pregnancy or after pregnancy, again, if we are talking of post-pregnancy maintenance, then at least she should not conceive earlier soon. So again, the role of contraception comes in. So this time we have to advise accordingly the barrier methods or the contraception which does not make her gain further weight, one thing. Secondly, again, now comes the role of your medicines also, the GLP-1 RA, physical activity, and now we can actually put her on very stringent diet regimes also. And after 6 weeks, even if it's a cesarean section, after 6 weeks, she can pick up her physical activity. So diet, physical activity, and medicinal support will be the key methods to make her come back to her prepartum, pre-pregnancy weight, or maybe even less.
Thank you so much, and big thanks to both the speakers. And I think we'll close this session here. we had a good discussion, and maybe when we meet, we can take this discussion forward. So Kolkata is waiting you, whoever is joining us physically. Over a cup of tea or coffee, we can have these discussions again. So now for the next session, and thank you, Dr. Arun, and thank you, Dr. Minal, once again. Moving forward, we do have Dr. Swati and Dr. Arvinda and Dr. Rajesh. So I would kindly ask Dr. Swati and Dr. Rajesh to please take over and here on introduce the speakers and the next session for us, please.
Just to intervene, thank you so much, the organizers, and I would be moving out because I have a flight to catch. So thank you, Dr. Supratik, and thank you, the PSG team, for inviting me here. Thank you, Dr. Arun, for all your efforts.
Thank you so much.
It was really a pleasure.
It was a pleasure. It was my pleasure as well. Thank you so much.
Thank you, Dr. Supratik. And thanks the PSG team. I think you're doing an excellent job.
Before Dr. Swati begins, let me introduce Dr. Swati formally. So again, thoroughly academic, and it's an honor to have her on board this Amos team as well as this session. She is now the professor and unit head, and she's also head and consultant thyroid clinic, SMS Medical College, Jaipur. And she will be chairing as well as moderating this session. We also have our very good friend, Dr. Rajesh Deshmane, chairing this session. Is a very eminent diabetologist and metabolic physician at Sri Mahalakshmi Diatom Institute in Kolhapur. And again, it's an honor to have him on board. So over to you, chairpersons.
Thank you very much, Dr. Supratik. And that's what I was saying, that the PSG group is doing a wonderful activity because studying reproductive medicine, and especially in the pregnancy period, is a place where probably many of the clinicians need to brush up their skills to be on board this. And now, as we move on to the next symposium, that is the PCOS and the GDM trap. The trap. So this is a very interesting topic, because PCOS, as we know, is something which is one of the very commonly occurring disorders as age group women. So this is one of the, it has a lot of problems. The young lady has aesthetic problems when she is an adolescent, then she has reproductive problems. Then as she goes into the third, fourth decades, she has metabolic problems, she has cardiovascular problems when she is 50s and 60s. And then overall, her entire quality of life is much affected by the PCOS. How much does this PCOS affect the pregnancy, and what is the relation between GDM and PCOS? That is what we are going to see. We have two eminent speakers. Dr. Nandita Arun is going to be the first. She has done diploma in diabetology from UK. She is the director and consultant hospitals. She did an undergraduation in the prestigious Sri Ramachandra Medical College and attained gold medal in that, in preventive and social medicine, with post-graduation in medicine, general medicine at Sri Ramachandra Medical College again. She underwent training and research with the prestigious, and she has many fellowships and awards to her merit. She has done warrior also. She was given award. Invite Dr. Nandita Arun to kindly start her down. Dr. Nandita Arun has joined.
I am here, yes. Good evening. Thank you, madam, for your introduction. The first speaker, so Dr. Faraz and me were supposed to do, I think the first part of it is going to be covered by Dr. Faraz, and the latter half is by me. Would you like to introduce Dr. Faraz?
Yeah. So Dr. Faraz Farishta. Oh, okay. So the other co-chair, would you like to? Do we have the other co-chair? with us? Dr. Rajesh Deshmani?
Yes, I'm here. I'm here.
Yeah,
So
Dr.
it's my
Rajesh.
pleasure to introduce
Please.
Dr. Paraj Farista. He is a professor and practicing at endocrine and diabetes at Hyderabad. So he's, I think he just received RSSDI Fellowship Award in last month only. So without wasting time, I think we should start his presentation.
Yeah, thank you for that warm introduction. I hope my slides are visible.
Yes, your slides are visible and voice is also clear.
Yeah, thank you. So I think continuing with what my fellow colleagues have been talking about, everything revolves around obesity. One thing which you will find very common in all the, I would say, at least today's topics is obesity. So PCOS again is something revolving around obesity and insulin resistance. So whenever we talk about PCOS, generally we talk about for infertility, we talk about young females. So but today I'm going to talk about 3 clinical cases. So PCOS is we have to look at across the lifespan. Some quick facts about PCOS. You will see PCOD was first recognized in 1935. About 4 in 10 women have PCOS are overweight. Most of the time it is 5 out of the 10. So we can have females without obesity also having PCOS. And most of the time, yes, we see this in young females. This is a very interesting survey, the nationwide PCOS survey. You will see the data. It says 1 in 15 PCOS affects the woman worldwide. Approximately 50% of women with PCOS suffer from obesity. Some important facts which I would like to highlight: 25% of Indian women did not know about PCOS. 65% of women are not aware of PCOS symptoms. And 35% of the women have never spoken about PCOS. Forget about the males. You will see 60% of the men do not know what PCOS is. So if the female is suffering from it and she does not know the symptoms, then I do not feel that, yes, probably males also will not be knowing much about it. So it affects 1 in 10 women. You will see 10 to 15% women estimated to have PCOS. 50% of the women of PCOS going undiagnosed. So this is again a very important parameter. We keep on talking about diabetes being undiagnosed, but you will see the rate is also very high with PCOS as well. 50% of women with PCOS will develop type 2 diabetes, pre-diabetes before the age of 40, prone for developing GDM, which my fellow colleague Dr. Anita is going to speak about. 13.8 billion estimated annual cost to the American healthcare. We do not have much data about the Indian ones. 3-time increased risk of women with PCOS developing endometrial cancer. So everything with hirsutism is not PCOS. I think most of us, whenever we see either a hirsutism or we see an acanthosis nigricans, most of the time, yes, the first diagnosis which comes is insulin resistance. And by default, we all are probably more attracted towards the PCOD. So here, let me get out the differential diagnosis. For hirsutism and anovulation, yes, PCOS stands first. It could be an ovarian tumor. It could be iatrogenic androgen administration. It could be obesity, simple obesity-induced hyperandrogenic anovulation. It could be a congenital adrenal hyperplasia and other, I would say, forgotten syndromes, which we always have to consider as the Cushing's and prolactinoma. So coming to my case 1, this is a 23-year-old woman with an anabolic appearance, BMI, she's obese. She's having hirsutism. There is no clitoromegaly. She's having grade 2 acne. She's having labs which are mildly elevated. You will see the testosterone is on the higher side. The DHEA is on the higher side. A1C is still much better. So she is not yet prone for, I would say, into that diabetic range. Before jumping on to the management and diagnosis, let me get out a point. What are the other causes of hirsutism? So there are drugs. Commonly, we use few of them. So it is important that we know about it. Androgens alone or with estrogens, anabolic steroids. Clinically, I would say we all know minoxidil, phenytoin. So if you have a patient with epilepsy, do not forget phenytoin or diazoxide or cyclosporin. So how do you diagnose PCOS? I think now most of us use the Rotterdam criteria, which says the patient should have 2 out of the 3. One is either oligomenorrhea, second is hyperandrogenism. So that could be either clinically or biochemical. So a patient could present to you clinically. The third would be a polycystic ovary on US, that is the ultrasound. You should have at least greater than 10 ml size and more than 20 follicles. So this is also a very important parameter. Let me make this factor very clear. In a country like India, you can still diagnose PCOS without an ultrasound. So if you'll see 2 out of the 3, both are clinical things which you can diagnose. Coming to the prevalence of PCOS in India, it is around 8 to 9% prevalence in these small studies which we have. What do you do when your patient has or that typical age where it is around 20 to 25, they are probably getting ready for their marriage in the future, but not planning for pregnancy at that time. So what do you do at that time? How do you treat? So hirsutism at that time can be used for removing the hairs. They have a different many procedures like electrolysis, plucking, waxing, shaving. Treating the underlying cause, I think this is very, very important, where we come under play as physicians, that we need to treat the underlying cause. So it could be a OCPs, spironolactone, finasteride, flutamide, metformin, and then I would say most important, weight loss. What are the treatment options? So when the pregnancy is not desired, so first thing is you regularize the menses, you start OCPs with constantly, less androgenic progesterone or cyclic progesterone, because you need that endometrial shedding that increases the SHBG. Treat the hirsutism with spironolactone. Again, just concentrate probably on the dose. You can go as high as 50 to 100 milligram per day. Diet and lifestyle will be a most important factor. I would not go deep into that. And insulin sensitizers. I think most of the data of what we have is on metformin, because it has now clinically shown us the benefits. And now we have some emerging data which is coming on D-chironositol and mannitol individually and together as well. Pathogenesis, if I had to sum it up into one line, there is increased testosterone levels, which is happening, and then there is insulin resistance, which is very high, which is leading to all the clinical parameters. So coming back to the case, you have to take the history, do the labs, do an ultrasound. When it comes to management, you suppress the androgens, ensure that there is an endometrial shedding, and optimize the diet and lifestyle. Coming to the medications, oral contraceptives with less androgenic progesterone, spironolactone for hirsutism, and insulin sensitizers, metformin would be the ideal drug. Followed by, I think now most of us have that experience on inositol. I think that would come as a question which we can discuss it later. Coming to the next spectrum, that is the case 2, which is a known patient. So here we have a 28-year-old woman with PCOS, already a known case. Now they come to you about discussing about their planned pregnancy. History of menarche at the age of 10, PCOS diagnosed at 18 years, intermittently on oral contraceptives and spironolactone, started metformin 6 months back, has a gradual increase in the weight, which you can see. PP is 130/80, obese, with acanthosis, grade 2 acne, and no fertilization. Urine pregnancy test is negative. So this is one patient in the spectrum which we all get, which are already diagnosed, and they come to you or they come to our gynae colleagues most of the time to discuss about the planned pregnancy. Which of the following treatments in the woman with PCOS would be more effective in induction of ovulation? to achieve a live birth, we have many of the drugs: letrozole, clomiphene citrate, human menopausal gonadotropins, cabergoline. Studies have shown that you will see that when you give metformin, yes, metformin improves the insulin resistance, lipids, sometimes weight. But clomiphene, we all know, induces ovulation when you give it together. So you will see across the BMI in the lower slide graph and the above one, when together they are giving metformin and clomiphene citrate together are given, the chances of having ovulation and pregnancy is much higher. But letrozole is better than clomiphene. So here you will see this was a study which was published in the NEGM. 750 patients were started on their letrozole 2.5 milligram versus clomiphene citrate 50 milligrams, day 3 to day 8 for 5 months. Definition was anovulation, hyperandrogenism, or PCOS ovaries. Live births you will see which was higher, 27.5 versus 19% with CC, that is clomiphene. Congenital abnormalities were 4 versus 1. Ovulation rate, so again, which was high with you will see letrozole versus clomiphene, and pregnancy loss was 32% versus 29%. The side effects or the adverse events, you will see fatigue and dizziness with letrozole versus hot flashes with clomiphene. Here again, an interesting fact which comes out is, again, if you see across the live birth rates, across the spectrum of BMI, varying from less than 30 to 30 to 39 and more than 39, you will see a letrozole fares much better when you compare it with clomiphene. What should we do in patients like this? Should we recommend diet, weight loss, and insulin sensitizers? Yes, we need to give them all of them. I would not again discuss, it's already been discussed. What about the future risk? So this is again very important. You monitor the weight every 6 to 12 months, assess the individual CVD risk factors, lipids, and blood pressure, because they are more prone for developing metabolic syndrome. Going to my third case very quickly. So this is a 33-year-old woman with PCOS, that the last spectrum, I would say, persistent with irregular menses, have finished her, I would say, family planning, G2, P2 with need for induction of ovulation, stable hirsutism on metformin and OCPs, wants to know what are the long-term complications. So it is not just we are dealing with infertilities. There are increased risk of these patients developing the other comorbidities as well. So you will see the endometrial cancer risk is more. These patients are prone for developing metabolic syndrome, have increased cardiovascular risk, and you will see the risk of obstructive sleep apnea, steatosis, and now few studies also suggest there's increased risk of depression as well. Here you will see the obese PCOS patients compared to the non-PCOS obese, there is increased risk of developing obstructive sleep apnea. PCOS and NAFLD meta-analysis, again, you will see there are increased risk of developing NAFLD. Coming back to the case, screen women with PCOS at that age, probably who have finished pregnancy, for cardiometabolic risk, and do not leave them there, and treat to the guidelines, reduce the blood pressure, cholesterols, and monitor for any blood sugars. Optimize the diet and lifestyle, ensure endometrial shedding with OCPs or cyclic progesterone, evaluate for obstructive sleep apnea, and evaluate for fatty liver. One thing I would say is very important would be the risk of developing diabetes and GDM, which my fellow colleague Dr. Nandita would be speaking now. Over to Dr. Nandita.
Thank you, Dr. Faraz. Of course, before I start, I have to thank the organizers of PSG, Dr. Rutul, Dr. Supratik, and the entire team, and congratulate you on organizing such a lovely event. Thank you for inviting me. I will just quickly share my slides. Just to confirm, my voice is audible? And is my first slide visible as well?
Yes. Your voice is visible and slides are visible.
Thank you so much. Thank you, sir. Yes, the topic that Dr. Faraz has introduced so far is the initial part of our title here, as you can see, which is the link between polycystic ovarian syndrome and gestational diabetes. And rightfully, it's been called the trap. So PCOS and GDM, the trap, as the title reads. Dr. Faraz has very nicely alluded to and discussed the importance of PCOS. He's also very nicely discussed 3 case studies, which makes it a lot more easier for us to relate to. My job over the next 15 minutes or so is to carry this over and carry the link between PCOS and gestational diabetes. When I was looking at prevalence data, this is something that I found, which is a recent publication just a couple of months ago in the Times of India, prevalence that has actually indicated that the prevalence of gestational diabetes is in fact increasing in our part of the world, in India. And what is worrisome is that it's increasing not just in the urban India, but also in the semi-urban and rural India, as the newspaper cutting here in front of us shows. And of course, we also know that many of these patients do develop type 2 diabetes later on, post-partum in the future years. And the sad part is many of these women do not screen and hence end up with complications until they present to the doctor. Now, we all know, I think I'm going to probably just skim through the slide. We know that there's 2 types. There's pre-gestational diabetes, where the patient has pre-existing dysglycemia, whether it's type 1 or type 2, and then gestational, which is dysglycemia diagnosed for the first time during pregnancy. There is a common soil that exists between PCOS and gestational diabetes. And that is what this flow chart very nicely depicts, which we have in front of us here. Insulin resistance is the major pathophysiological feature, which is common between the 2. We have obesity, chronic inflammation, which leads to insulin resistance, in turn then leads to hyperinsulinemia. And all this together, of course, along with the hyperandrogenemia, we have manifestations in terms of hyperandrogenism, in terms of polycystic ovaries or anovulation, irregular periods, which then leads to infertility and complications during pregnancy. And last but not the least, the development of type 2 diabetes and cardiovascular disease. So it's all a sort of a continuum, and we can't really tease one out from the other, which is where the problem actually exists. Now, when we look at the risk factors for gestational diabetes, this is a publication in which they've actually done a statistical analysis to look at the independent variables in a regression analysis. And of course, as you can see, the significant factors is what is here in front of you. We know that, of course, overweight, obesity are major risk factors for development. We heard about that in the previous session. A previous history of gestational diabetes, a family history of type 2 diabetes, history of macrosomia, elderly primaries or pregnancy over the age of 25 or 35, multiple pregnancies, and last but not the least, what I've marked out over there in the red box is polycystic ovarian syndrome, which stands out as a significant independent risk factor for the development of gestational type diabetes. This is our own publication. Now, what about the risk factors that increase this risk? We know that the risk factors that contribute to that increase in insulin resistance, the so-called common soil, which I just presented to you, which increases the risk of gestational diabetes, increases the risk of polycystic ovarian syndrome, is increased waist circumference, increased obesity, dyslipidemia. Like I said, it's all one continuum. And here you have data that we recently published from our center, in which we looked at a temporal change, or whether there is in fact an increase in the risk factors among women between a time period of 10 years. So the last time that we had reported it was in 2006. We went back 10 years later in 2016 to look at whether there is in fact an increase. And we did find that there is a significant increase, which is quite worrisome. And this I'm presenting to you data among just women in both the urban and in the rural population. An significant increase, as you can see, the yellow asterisk, significant increase in waist circumference, significant increase in obesity, hypertension, and dyslipidemia. And obesity rates are increasing both in the rural and in the urban women. So, as I mentioned, it is a continuum. You have obesity and all these risk factors which contribute to polycystic ovaries, irregular periods, infertility, insulin resistance, which then presents with all the manifestations of hirsutism and, as I mentioned, irregular periods, which then causes problems during pregnancy, including gestational diabetes, problems and complications not just for the mother, but also for the fetus, which then in the mother can lead to chronic health conditions like type 2 diabetes in the future, dyslipidemia, hypertension, and cardiovascular disease. So the whole thing is one continuum. As I mentioned, PCOS does increase the risk of subsequent gestational diabetes, and this is a publication that points that out, that there is an undeniable scientific fact that both are definitely associated. And this is a meta-analysis to prove that. You have various studies that have been included, which shows that there is in fact an increased risk of gestational diabetes in women with PCOS compared to those without PCOS. So why treat gestational diabetes? We know that, of course, this is a very basic slide, but just for us to highlight the importance of it, we know that gestational diabetes does increase the risk of complications, again, in the mother and in the fetus. There can be macrosomia, neonatal hypoglycemia, nerve injuries, preterm deliveries, the increased risk of offspring obesity and diabetes, which is questionable. There are some theories about that. The consequences of PCOS, of course, was discussed briefly by Dr. Faraz in his slides as well. But PCOS, the risk factors being obesity and lifestyle and genetic factors, which together can contribute to PCOS, can have metabolic, reproductive, and obstetric disorders. So the reproductive disorders is infertility, menstrual irregularities, and endometrial abnormalities. Metabolic disorders would include diabetes type 2, gestational diabetes, and increased cardiovascular risk. Obstetric would be preeclampsia, premature birth, and gestational hypertension, and various others, which I'll be discussing briefly. This is data to show us that in women with or without PCOS, early pregnancy loss is also an issue. So these are the obstetric complications. As you can see, you have PCOS versus controls, and the forest plot all pointing towards the right to show us that there is an increase in risk of early pregnancy loss among women with PCOS as compared to without. When women are further stratified according to their body mass index, the higher the BMI, the higher the risk of infertility, and this is in women with PCOS, of course. We find that there is a higher risk with an increase in body weight and increased BMI. You have an increased risk of infertility and an significant increase in the risk of EPL, which is early pregnancy loss, which is what data in front of us shows. Insulin resistance itself can be an independent risk factor for fetal macrosomia and early miscarriage. And here you have in this particular study where they have actually grouped women according to their HOMA-IR, or an increasing stratified them in increasing insulin resistance, and they found that significantly higher insulin resistance can increase the risk of not just polycystic ovarian syndrome, but also increase miscarriage risk and fetal macrosomia. So PCOS, yes, does increase the risk of complications in the pregnancy outcome. It can increase the risk of preeclampsia, preterm labor, shoulder dystocia, and all these are significantly increased. Also polyhydramnios and PIH. In the fetus also, there is a risk of macrosomia, there is risk of neonatal distress, respiratory distress syndrome, and neonatal hypoglycemia, which all are increased in women with PCOS and gestational diabetes as compared to those without PCOS. So what do we do about this? And this is one of my final slides. And this is sort of to summarize what we've discussed so far, both Dr. Faraz and me, because this is what is the take-home message that we are tomorrow going to take to our clinics. When we have patients with PCOS and the association of PCOS with not just gestational diabetes, but also during pregnancy, is you can divide it into three phases, which is the pre-pregnancy phase, the pregnancy phase, and the postpartum phase. So in the pre-pregnancy phase, we know that PCOS, the risk that we have is overweight or obesity. And for such a condition, we'll have to consider weight loss as an option, intensive lifestyle modification, and maybe you could even consider use of some weight loss drugs. And we also have drugs like the GLP-1 analogs, which are available if you have presence of dysglycemia as well.
Pre-pregnancy PCOS is also associated with type 2 diabetes or dysglycemia, as I mentioned. So screening patients with polycystic ovarian syndrome for hyperglycemia or type 2 diabetes is also extremely important. Also screening them for systemic hypertension and to optimize the blood pressure in the pre-pregnancy phase is also crucial. During the pregnancy phase, the overall health of a person with PCOS is important to pay attention to the comorbidities that the patient may already have. Weight gain during pregnancy, which was also discussed in the previous session by the previous speakers. Gestational diabetes, of course, screen for gestational diabetes in the first trimester. If negative, again screen at 24 to 28 weeks. Screen for hypertensive disorders because PCOS is also associated, like I mentioned earlier, with PIH and preeclampsia. Preterm delivery is also something to pay attention to, and that's more of the obstetric from the gynecologist point of view. During the postpartum phase also, we do need to monitor patients. Patient education goes a long way, and that's something that we need to stress on, right? During the pregnancy, we need to, in fact, it's also discussed that even at the first visit of the pregnancy, when the patient presents with gestational diabetes, we must sensitize the mother about the fact that her risk of type 2 diabetes post-pregnancy or to continue to be diabetic, even if she turns out to be non-diabetic postpartum, she may have that risk of type 2 diabetes in the future, is something that we do need to sensitize them all through the pregnancy and keep reminding them about. Because many women do tend to neglect and forget about it, and then like I mentioned earlier, do present with complications only later on in their life. So post-pregnancy or postpartum, post-delivery, we need to focus on weight reduction, look for dysglycemia or type 2 diabetes, persistent hypertension, and of course address breastfeeding difficulties that patient may have. Last but not the least, postpartum depression is also something to be addressed. So in summary, PCOS and gestational diabetes do share a common soil. Obesity, insulin resistance, hyperinsulinemia, hyperandrogenism, all this together contributes to increased risk of complications, not just in the mother, but also in the fetus. PCOS itself is an independent risk factor for gestational diabetes, other than all the other risk factors, which include obesity, a positive family history for type 2 diabetes, previous history of gestational diabetes, elderly mothers, and so on. And as I mentioned, PCOS can worsen outcomes of pregnancy and with an increased risk of gestational diabetes. Early pregnancy loss, placental abnormalities, preterm deliveries, macrosomia are some of the risks. An appropriate intervention and timely intervention in the during the pregnancy and the post-pregnancy or the postpartum period can help alleviate this risk and address to reduce the risk of complications and improve outcomes in these patients. Thank you.
Thank you, Dr. Ranjita, for nice deliberation, and it's crisp deliberation, particularly the last slide in which pre-pregnancy, during pregnancy, and post-pregnancy has been taken care. So one question is there. So whether when we consider as a diabetologist or as a metabolic physician, when we consider GLP-1 analogs in before pregnancy, pre-pregnancy patients, so what is your message, as well as what is your opinion about using GLP-1 for PCOD? Because right now I think liraglutide has been approved for obesity, not yet oral sema, but liraglutide has been approved.
Yes, absolutely. So I think GLP-1 receptor agonists have been a boon, not just in the management of diabetes, but also in enriching management and also in helping with weight loss. I think we've all many of us have had good experience with these groups of drugs. And yes, polycystic ovarian syndrome is a condition which is often associated with obesity, associated with patients with a higher BMI or overweight patients. And as you mentioned, sir, the use of liraglutide has also recently been approved. So if we can achieve that, of course, lifestyle modification still remains the cornerstone. I cannot stress enough on that. But if we can combine pharmacotherapy along with LSM or lifestyle modification to further intensify the weight loss, that will definitely go a long way to not just improve outcomes in polycystic ovarian syndrome, but also help with improving chances of pregnancy, improving fertility in these patients as well. So yes, absolutely. If when and wherever indicated, and if it can be used in the right patient, it does go a long way. I can see Seshaya sir here.
Yes, I think we had a brilliant session. So Professor V. Seshaya is here, and a big congratulations to the PSG team for selecting the topics, which is very pertinent in today's discussion. And thank you, Dr. Nandita and Dr. Faraz, for beautifully presenting these topics of interest. And we would want to conclude this session because Professor Seshaya's talk is something that we had been waiting for. Just before I conclude, a big thank you to PSG as well as the MOS. I just wanted to share the data that we had presented, our first Asian data on liraglutide use in polycystic ovarian syndrome this year at ATTD, and it was well received. So there is a cohort of lean PCOS as well. However, our data was on those individuals who are overweight or obese. So again, I think we are moving in directions and a lot of new things are coming up, a lot of exciting places that we are venturing. And with this thought, I hand over the session back to Dr. Rutul.
So, thank you,
Dr. Rajesh, for chairing this session so nicely. Professor Swati is just caught up. I just got a message from her, and back to Rutul.
So thank you, Rutul. Thank you, Dharmendra. Thank you, Amit, and thank you, Supratik, for incorporating us in this session. Thank you.
Thank you very much, everyone, for joining. And that was really an excellent symposium of MOS, 2 symposium, and we really enjoyed it. And as we are running late, half an hour, I guess, so we'll move forward further to the next symposium of preconceptual counseling and management of pre-gestational diabetes. And for that, we have moderator Dr. Shruti Sheth. She is from Ahmedabad. We'll try to finish a little early. As Dr. V. Seshaya sir is awaiting. Sir, please bear with us for half an hour more. Thank you.
Yes, good evening, everyone. Quickly, we are coming to the next big session, pre-conceptual counseling and management of pre-gestational diabetes, which is another very important topic. And chairing this session is Dr. Ishita Sachdev, who is an associate consultant at Dr. Panikkar Specialty Care Clinic in Mumbai, and Dr. Dhaval Patel, who is the consultant diabetologist at Shriven Sugar Care Diabetes Clinic in Himatnagar, Gujarat. Over to you, chairpersons.
Thank you, Dr. Rutul, Dr. Amit, and Dr. Dharmendra for including us in this prestigious program. And without much further ado, let me introduce the first speaker, Dr. Yash Patel, who is a PhD, MD, and diabetes and endocrinology, diploma and multiple degrees. He is also the director and consultant diabetologist at Swasthya Diabetes Care and All India Institute of Diabetes Research, and the youngest diabetes endocrine specialist in the globe who got the PhD in diabetes. Over to you, sir. Dr. Yash.
Good evening, everyone. I would request chairperson to introduce my co-speaker because we are doing dialogues to save time, and that would appreciate that we have
okay, sir. Okay. And our next speaker is Dr. Piyush Desai from Surat, who is an MBBS MD internal medicine. He has multiple publications under his belt, and he has also received the award for excellence in diabetes care in 2019 by RSSDI at the national conference at Jaipur. Pleasure to have you, sir. Over to you.
Thank you.
So good evening, everyone, and it is indeed pleasure that I am taking on this dialogue with Dr. Piyush Desai, who is my co-speaker, and to all the PSG team and the chairperson, as well as the whole delegates around. Good evening to everyone. So the dialogue topic is preconceptual counseling and management of pre-gestational diabetes. So now, what is the definition around? So we will take on this lecture simultaneously with Dr. Piyush Desai and we would share the impressions on that line. So gestational diabetes. Diabetes not detected before pregnancy, but discovered during pregnancy, and nearly all, but not all, cause some of the type 2 which we missed during this diagnosis also. So pre-gestational diabetes diagnosed before conception and includes women with type 1 and type 2 diabetes. In that line, why preconception care is mattering to us. And that's the background for this whole dialogues. So we have some of the data from US journals which mention this about uh, pre uh, preconception gestational diabetes, where the preconception care is not available, where the chances of preterm, birth defects, and perinatal deaths are much more higher. And if we see the where the universal preconception care is available, the preterm births avoided, the birth detected, defects prevented, and perinatal deaths avoided are much more better appreciated than the routine care, which is not available for preconception diabetes. So now looking into preventable health and cost burden of adverse birth outcomes associated with pre-gestational diabetes mellitus in the US. And looking into scenario, the primary conception care is given to the pre-gestational diabetes. The direct medical cost reduction is by $770 million reduced. In lost productivity is $3.6 billion. If if seen undiagnosed pre-gestational diabetes mellitus, and in that the direct medical cost is $207 million and $960 million is lost in productivity. So ultimately, $5.5 billion is a preventable cost which we encountered during this preconception gestational diabetes management. Now, to manage these preconception gestational diabetes counseling and the care, I would see one scenario is diabetes mellitus type 1. I will invite Dr. Piyush Desai to step up ahead and go ahead for the same.
Yeah, so I will say here one thing is very important that during adulthood, type 1 diabetic patients are not taking good care. So this is the time to reinstate by screens. So this is the time where actually we can initiate a good care in type 1 diabetic patient, because that is, I think pregnancy is the phase where you can instead best care, and patient are highly motivated. So if patient is not having good control, we can enforce good control also. For type 1 diabetic, many a times HbA1c is around 8.5 to 9. So I will say no unplanned pregnancies. So whenever patient is coming to you in a regular period, just start discussion with teenage girl that you should never have unplanned pregnancy. Barrier method, IUD, whatever you want, you can go for. But this is something we have to talk to them. We have to talk to their parents in early period, even when they are not married, but they are in early adolescent, late adolescent to early young adulthood, so that we can prevent birth defect, which is ideally happening in first 3 months of pregnancy. Next. Along with that, that is very important, which I already told, a good glycemic control. Now, what is a good glycemic control for type 1 diabetic? Because in type 1 diabetic, if we are not going to achieve 6 or 6.5 or 6.1, but if patient is on around 8, 9, many times I have seen patients are taking pre-mix insulin instead of basal bolus regimen. So this is the time, more SMBG, turning them to basal bolus therapy. If patient is affording, then even insulin pump is a good boon. At the same time, we have to counsel them for the complication screening, especially retina and urine for microalbumin, because retinal and kidney complication may worsen during pregnancy. Along with that, nutritional management And awareness of that carbohydrate counting is something which we can add to their region, because many times type 1 diabetic are not putting more emphasis on carbohydrate counting. But pregnancy, if patient is planning for pregnancy, we can teach them, because they have to balance their nutrition. And as in my previous speaker told that PCOD and emotional problem, similar thing happens with emotional readiness, is that need, I mean, emotional disturbances are very common in type 1, type 2 diabetic patient who gets pregnancy. So they have to be ready. And last but not the least, folic acid, and preferably with B12 and vitamin D, and I will say even iron is something, if at all deficient, please replenish it. So this is what pre-conception counseling we can go for in type 1 diabetic patient. And at the same time, we can tell them, if you control from day first, or if you control even before day first, then pregnancy outcomes are no different from general population. Macrosomia, few later on things may happen, but it will not be as bad as it should be with uncontrolled diabetes. And we have enough data with type 1, and I feel we would have enough data with type 2 diabetes also. And I would say, I would like to invite Dr. Yash again for how we can advise patients who are type 2 diabetic and now they are becoming pregnant.
Wow. So we know that in this present world, what we see, the type 2 diabetic individuals, which are much more presented in the early life. Even we have the delay in pregnancies also, and the IVFs, these are the trend where we see the type 2 diabetes getting into the pregnancies. So in that line, if we see the new recommendation by AD, where the counsel all women of childbearing age about the importance of near normal glycemic prior to the conception, which Dr. Desai also mentioned about. And in that line, it is not on the first day of conception, but it is prior to that, the mindset, the lifestyle, as well as adaptability of monitoring is much more important. And from the major malformation directly proportion to HbA1c level in the first 10 weeks of pregnancy had been represented in the scientific data also. Even at present also, the strain in the time in range, if how we manage that, that is also important in first 10 weeks. Usually in Indian scenario, what we see is there are individuals who don't know even they are amenorrheic for more than 6 weeks to 7 weeks in their pregnancy, and that's where the planned pregnancy discussion of this pregnancy planning among the individuals who are childbearing in our consultation is much more important. So discussion, family planning, and effective contraception until the woman is prepared and ready for the pregnancy is much more important. As previously mentioned by the speakers, the pre-pregnancy evaluation for the glycemic control, the micro as well as macrovascular complications, specifically focusing the serum creatinine, urine albumin creatinine ratio, thyroid, as well as comprehensive eye evaluation is much more important. In that line also, preventing the pregnancy eclampsias, and the further line, the obesity is where we need to focus into this line. Along with that, medication review for possible teratogenesis, including ACE inhibitors and statins, are the one we would look into in much more extent. Considering the modification of medical regimen in pregnancy is anticipated, or if unintended pregnancy is likely to be there, then intensifying the insulin regime or insulin pump is what more we would look into. Above that line, even the statins, thiazolidines, ACE inhibitors, ARBs, even some we know the SGLT2 inhibitors are where we would like to step down when before or starting the pregnancy. And metformin glyburide may be continued if achieving adequate glycemic control. And like same way mentioned, the childbearing woman, if they are planning the pregnancy, it is better to plan that thing with medical therapy prior to the conception. Looking into this line, what we have scenario is also to discuss for. There are some individuals who place their pregnancy in the gaps, and in that line, they in previous pregnancy they were euglycemic, but diabetes mellitus type 2 is detected before second pregnancy. So I would invite Dr. Piyush Desai to share his
Yeah,
inputs on this.
Yeah, definitely. Because see, what happens, it is nothing different than what Dr. Yash told, that what type 2 diabetic patient should take care when they are getting pregnant. But what happens that in first pregnancy, patient was non-pregnant. And now in second pregnancy, patient is already diabetic and then she became pregnant. So here, one thing is very important. It's a correlation. So that patient will always correlate. In my first pregnancy, this thing has happened. In my second pregnancy, why you are doing this thing? But we should tell them that these are the conditions which were more enhanced because of your diabetic status, which was not previously in your previous status. At the same time, patients who are at risk, on the other side, like first pregnancy euglycemia, second pregnancy diabetes, instead of that, if patient is already having gestational diabetes in previous condition, then they should be screened early. So I will say, instead of picking up, this is the time we can pick up pre-gestational diabetes. So always screen them whenever they are going to plan, if patient has previous history of GTM. Pre-diabetes, many times at camps, patients are getting their HbA1c around 5.7, 5.8, 6.1. They should be screened properly. Patient with family history, patient with PCOS, patient with acanthosis, and patient who are overweight should be seen as a candidate who may have pre-gestational diabetes underlying at the time of conception, and they should be counseled before that to manage their weight, manage their PCOS, and manage their overall pre-diabetic status. Next. And if patient is having GDM in previous pregnancy, here again a correlation. See, GDM is a condition where usually a macrosomia or neonatal jaundice or some minor birth defect can happen. But if patient is type 2 diabetes, if patient is pre-gestational diabetes, and now patient is becoming pregnant, then the scenario is different. Patient may be at even more higher risk herself as well as for her baby. So here, this is very important. We cannot just correlate. So we have to explain patient regarding the care. Care, maybe insulin need of insulin is going to be same, but the requirement to insulin may be different. Overall, the high risk criteria for hypertension as well as antenatal screening, especially for anomaly scan, everything will be more precisely done in patients who are now type 2 and having pre-gestational diabetes. Next.
That's
and
true.
for that,
Yeah.
I think, yes, you will also agree that we should have national agenda for public health action also, to encourage, to support state programs, to develop prevention programs, to expand community-based health promotion, to strengthen advocacy, and to expand population-based surveillance also, because that is something we are lacking in our country many a times. And I think Dr. Sesa and all senior members has done a great job to do this thing as much as possible for India, to create an awareness regarding pregnancy and diabetes. And this is very important to educate community leaders also, to encourage healthcare providers to promote risk assessment, especially gynecologists, because they treat patient after patient becoming pregnant, and something that we should take care before patient get pregnant. And at the same time, we have to encourage the access to trained professionals, because they will fall into high risk category. And from all understanding, we should have our own public health research, so that we can modify, we can improvise our care to the patient with pre-gestational diabetes.
Yeah. So that is in the line. Thank you, everyone, and to make sure we are in the timeline what we committed, and looking forward to if any questions are there, as Dr. Sheshia would be stepping up for.
Great. Wonderful. You finished in very much in time. Thank you. Thank you very much, both the speakers.
Thank you, Dr. Desai.
Thank you to the speakers for a wonderful and crisp and a very precise lecture, I would say.
Thank you so much. Outside, I would like to thank Dr. Rutul, Dr. Dharmendra, and Dr. Amit for organizing such a wonderful event. Thank for making it a part of this. Thank you. Thank you so much to all the delegates and seniors.
Can we take some questions, Rutul bhai?
So we have a question also lined up.
Yeah.
Yeah. So someone WhatsApp me during the talk. So
Oh.
it is not directly, but if we have permission to go ahead, then I would ask for
Yes, I think one or two questions would be fine. We have
Single question and then we shall move on.
Yes, then we'll move on definitely.
Sure. So this is someone, UG doctor who had message of girl. I would not put the name as she is there to in the delegates. I think so. I love one boy, want to marry him, but he is diagnosed with diabetes, and this is the reason my parents are not allowing. Can you please tell me what would be the effect on my pregnancies and upcoming life? So, maybe Dr. Piyush, we haven't thought of this scenario in a different way.
Yeah,
This is what.
yeah. Actually, this is something which we forget to include, because this is also very important thing that many times patients are having in that thought that patient is type 1 diabetic, so my child will also carry the same risk of having type 1 diabetes, and that is a misconception. Actually, the carrying type 1 diabetic risk in offspring is very less than type 2 diabetes. One thing. And second thing, even if in type 2 diabetic, with good lifestyle, you can prevent to further extent, and patient may develop diabetes in later age. So it is about getting good control. That is one thing which is important. And I will say, I usually ask that girl or boy's parent to my clinic and tell them it is not diabetes. It is ignoring diabetes, which is causing more problem. And a proper preconceptional counseling is must, and not at the time whenever they get married, and whenever they are going to think about child, please come to me. We will evaluate each and every aspect, and then there will be no risk.
That's true. In the same line, I will put another question ahead. It is not always the type 1 status of the individual, but in pregnancy, what you should inquire is type 2 status of the individual's parents. That's what you are investing into, and that's where we will look into how you can prevent in your offsprings in upcoming time. Yes.
Very well said. Actually, recently even I had a patient who was diagnosed with GDM. She didn't have any history in the family or of type 1. She was diagnosed with GDM, and the only thing the couples were worried about was, will my newborn have diabetes, as soon as the child is born. So, that shows that how much of awareness is still to be put forward to all of our patients. And anyone who comes to the clinic, they have to be educated about this, whether they have or they do not have diabetes. It's not just the patients who educate. I think you should educate everyone. We need to educate everyone. Thank you for this wonderful session, chairpersons.
Thank you. Thank you.
Thank you. We'll move on to the next session, or
yes, Dr. Shruti, you are the moderator only.
Okay. So we'll move on to our next session. Just a second. We'll move on to our next session, which is the keynote lecture. Let me introduce our chairpersons, Dr. Tirthankar Satpathy, who is the consultant diabetologist at Dr. Mohan's Diabetes Specialty Center in Kolkata, and Dr. Rajesh Jain, who is the consultant diabetologist at Jain Hospital and Research Center in Kanpur. Over to you, chairpersons, sirs.
Hello. Hello. So this is a very important lecture by Dr. Sheshaya. So he's going to present on a very important topic, and which is new actually, a step toward primordial prevention of diabetes. So as we already know, Dr. Sheshaya is the father of gestation diabetes in India, and he has done a tremendous work on diabetes in pregnancy. And he has been recently awarded Padam Shri for his achievement, and he already have a lot of important awards to his credit, like BC Roy National Award, okay, and Lifetime Achievement Award by the International Diabetes Federation in 2017. And he has more than 150 publications especially in the gestational diabetes. So, so here is a new concept he's going to give today for the primordial prevention of the type 2 diabetes. Thank you.
Dear chairpersons, I would like to thank PSG, Dr. Ritul and other group members of this organization, and also the excellent speaking I was listening to. It so happened I had to listen for 1 hour the talk by the other people. Wonderful speaker, wonderful talk, wonderful talk. Now let me see here. I am going to speak on a latest concept, not latest, my own concept, how to go about, that is why I call Heart of the Matter 2020. What is that heart? Before going to that, this is what my topic will be, a step towards primordial prevention of diabetes. So this is a new concept, this step towards primordial diabetes. The estimations and projections of the number of people 20 to 70 years with diabetes in different editions of millions. They are just giving the prelude here. 2019, 463 million is going to be 537 in 2021, and 2045 is going to be 783. So it's almost double by the time to 2045. And that means the pre-diabetes approximately 318 million, which is likely to increase to about 481 million by 2040. So friends, diabetes is an epidemic of an unprecedented magnitude. Now it's going to be a pandemic. So this is the prelude I'm going to give. That means we are going to face the world is going to face a huge population of diabetes, including India. So now I want to introduce the topic here. Most of the people screen for diabetes in the towns, villages, everywhere. That's only detection of diabetes. Does not mean prevention of diabetes. What I am going to concentrate is prevention of diabetes, how to do it, how to approach this particular topic. So now our aim is primordial prevention of diabetes. Somebody asked what is a primordial disease? That is, disease should not develop. What steps can be taken for primordial prevention of diabetes? Let me see into the data. Now the evidence here, best evidence I can give only from states. Diabetes prevention program in the United States in September 2001, the Centers for Disease Control and Prevention CDC issued a press release stating that twin epidemics of diabetes and obesity continue to threaten the health of Americans. Not only Americans, all over the world is a problem. And diabetes prevention program was introduced. They did a proper method. What happened was surprising here. In 2001, it was 6.1% of the US population had diagnosed diabetes. Currently, 2021, it is 10.5 Americans developed. So, whatever method they use seems to be not working here, and so it has become double. So this, though we all think about CDC as an excellent center, but here they fail here. So obviously this is not a successful program of the United States. Then let us think what we can do. Then what could be the successful program which you are thinking about? Now I think I am a positive fellow. I think is it possible to achieve diabetes-free generation? Is it possible? Yes. Whom to focus? Having decided this free generation, whom to focus to see that diabetes doesn't occur in the world? That is more prevention of diabetes. Any interesting finding here, long time ago, Lice Kingo told female gender is key for diabetes prevention. So now I think most of you have understood what I'm trying to focus. Female gender is the key for diabetes prevention. How she is responsible. Now development origin of any disease will be here. The ovum is well supplied, the mitochondria, the sperm contains a few, even those few do not persist in the offspring. The statement is very clear that mother is very, very important because everything comes from the ovum, sperm doesn't do much. So here you see here at fertilization, it's only the nucleus of this protozoa, it enters the ovum, and thus all the cytoplasm, mitochondria, and the mitochondrial DNA are exclusively maternally inherited. So from this particular point, we can come to a conclusion the female gender is more important for us for prevention of diabetes. Now, David Barker, it's a wonderful study he made. He said the body's susceptibility to lifestyle disease was programmed intrauterine. Now he is giving the answer, intrauterine programmed. What do you mean by that? It will be here. What is intraprogramming? The gestational program is a process whereby stimuli, metal fuels or stressors that occur at critical sensitive periods of fetal development permanently change structure, physiology, and metabolism, which predispose individuals to disease in adult life. So this he has concluded saying that the fatal origin of adult diseases. So now we have come to conclusion female gender is very important, and most important will be the fetal origin of adult disease. That means fetal is the most important from where you develop all the diseases. Now we'll see how it is possible. Now here, as some people are telling about genetics. Now this is true. Development origin of health and diseases, phenotype has to be there. You may have genes from the parents, you may get diabetes, no doubt about that. Any disease can develop from genes. Now what happens here, it can be again intrauterine will be here fetal development, and then after the child is born, this is called postnatal development environment, both are called epigenetics. Now how far we can give importance to genes or to epigenetics. Now we will look into this, what has happened here. Due to a statement, genetic loads the gun. You may have a gun, but nothing will happen unless you fire it off. Genetic loads the gun and environment triggers stuff. What is the environment is the important, that is what we call this epigenetic. And that most important will be the intrauterine environment. Now, what is the clue for this? What is the answer for this? If you take diabetes mellitus, is it genetic or it is epigenetic? Inherited destiny is genetic, or it could be intrauterine environment. Which is more important, genetic or intrauterine environment? I will show the evidence here. We take animal experiment model. For Vista rat, the low genetic risk is very important slide. Vista rat with low genetic risk of diabetes when exposed to hyperglycemia media of goto rat utero significantly increase the risk of diabetes in adult life. So Vista rat is not genetic risk, whereas when it transferred into the goto rat utero, that will develop diabetes. That shows intrauterine media is very important. The animal. Now what about human being? So maternal hyperglycemia and progeny, the offspring of female Indians who were in utero, their mother had diabetes, have a greater risk of diabetes than early siblings born before the mother developed diabetes. So both animal experiment and the human has showed the intrauterine exposure is more important in transmitting the disease to the infant. That is called epigenetic. So here we compare both intrauterine milieu or it is inherited destiny. Intrauterine milieu seems to be very, very important in the transmission of disease, diabetes. Now, why we are concerned about the lots of times they are speaking, Uttil has given a number of talk were given. Why we are concerned about GDM? We take like this is a very beautiful statement. As Asli Mora Ferrari said, gestational diabetes mellitus may play a crucial role in increasing prevalence of diabetes and obesity. And again, if we continue that, insulin resistance, increased atherogenic lipid profile, inflammatory markers, hypertension, endothelial dysfunction lead to increased risk of for CV, cardiovascular disease. So that is how now we are discussing GDM because of these reasons now. That's why I call them as a GDM is the mother of non-communicable diseases. So it is obviously now we know we have to take care of the woman who's we want to prevent GDM so that the child will not become diabetic. How is it possible? Now, friends, detection, that is diagnosis of GDM, is possible. It is very simple. In DIPSI guidelines, there any guidelines you take, you can diagnose is possible. What I am interested, what I would like to share with you here is what we are concerned is the prediction of GDM. You can detection is not that difficult. Now, what we are concerned is the prediction. Who is going to become GDM? That is the most important part of my talk. How prediction is possible. Then, so what we can do to prevent diabetes development of GDM candidates consequences. So that once you know how to predict GDM, so you can definitely go for prevention. That prediction and prevention go together. So we'll see in the next slide when to test glucose tolerance to predict GDM. When to test. That is very important here. Now, fortunately, there is one study came into my knowledge. The blood test may identify gestational diabetes risk in first trimester. He just made a very broad classification of first trimester. The number of weeks are there in first trimester. Where do you get the blood test to be done? Now, let's say which week we should do the test. Now you'll see here gestational weeks for prediction of GDM. Which week we will get the GDM prediction. You can say, okay, this lady is going to GDM. Now we have almost 1 hour of discussing, we listening to all the talk. Now I'm going to say which week prediction of GDM can be occur. So it is a beautiful statement here. All of you will be able to appreciate this. A blood test conducted as early as the 10th week of pregnancy may help identify women at risk of gestational diabetes mellitus. So we are all talking about 24, 28 weeks. Now we see here a blood test conducted early as the 10th week of pregnancy may help. So what should be the criteria there? 10th week. It's very glycemic level will be here and higher A1C level, an average of 5.3% or 111 milligram per deciliter compared to those without GDM, an average of A1C 5.1. So either you can do the A1C 5.3 or it could be a postmortem blood sugar, PPBS will be 110 milligram. So that is the glycemic level, 10th week glycemic level 110. That's 2 points, you must remember this. This is this study. Now, what is the significance of 10th week? I told you in the previous slide, 10th week. What is the significance of 10th week of pregnancy? It's a very important message I'm going to share with you now here. Each islet cell functions as an endocrine organ. Very important. And then the human pancreas begins to develop 4 weeks after the conception and first insulin deposits can be found, but in weeks 7 and 8, pancreatic islet cell differentiates 10th and 11th week of gestation. After that, 10th week is very important. It recognizes and responds to metabolic glycemia at 11th week of gestation. There are 2 points here. One, 10th week is the where you can abnormality occurs 110 milligram. The child, the mother will develop GDM in the future. Why? Because the moment 10th week blood sugar crosses 110 milligram, 11th week their fetus will start secreting insulin. So the evidence was 10th week and then 11th week. This particular point is very important because the embryology here. Now we'll see next slide will be prandial glycemic level that can be considered as abnormal. Now entirely different concept I am going to give to you here. What is the prandial glycemic level that can be considered abnormal? So if you take this wonderful study, this Herman does, he says normal pattern of glycemia in non-pregnancy will be here. Fasting blood sugar will be 71 plus or minus 8 and 2 hour will be less than 10. So anything above this is abnormal. Any value above normal is abnormal. So this is particular point is taken for the whole study now we are going to discuss now. Now prediction of GDM. Now I told you detection of GDM is possible. Now which value predicts? The first time National Institute of Health study in 2018 suggested A1C of 5.3 or 2 hour postmortem blood glucose more than 110 milligrams at 10th week predict GDM. I give an answer. Now having no prediction how to prevent. Now Next slide, next point will be here. But so far, dear friends, no explanation has been given for prediction or as well as prevention of GDM. Nobody knows how to predict, how to prevent. Only thing we know will be 10th week predicts GDM. That's all we know. But how to go about is another big question. Let me see how I can answer this particular problem. Now, we conceptualize, otherwise we envisage the maternal, this slide again very important, maternal tour personal blood sugar, PPS, should not cross 110 mg at 10th week as fetal beta cells start secreting insulin around 11th week of pregnancy. That is the crux of the problem. 10th week and 11th week both are very important. 10th week more than 110 indicates the prediction. If it continues, if you don't treat that 110 mg, the child, the fetus will start responding to the maternal blood sugar at by 11th week and will start getting insulin. So this is a very important scientific data, fetal handling of maternal glucose, which we know about that, but now this is what I'm going to have as a point to argue how we can predict and prevent GDM. If we prevent GDM, we can prevent diabetes also. So fetal handling of maternal glucose. I told you 10th week fetus will be there, beta cell will start functioning, 11th week will secrete. Now that is what fetal, and how does fetal handle the maternal glucose? It's very surprising. Here you see here, fetal handling of maternal glucose. When maternal PPBS more than 110 mg, this figure please remember, the 100 mg, recorded in early weeks of pregnancy, it is advisable to take immediate step to bring PPBS less than 10 mg, lest she will develop GDM and consequences. So this is the final message here. So having known that, the obvious implication is that glycemic control needs to be optimized very early in pregnancy to prevent the establishment of fetal hyperglycemia. So maternal hyperglycemia and fetal hyperglycemia are a kingpin of the problem here. Now, contribution of glucose gradient from the mother to the fetus. This slide is very again important slide here. You take a maternal glucose, M maternal, F is fetus. Maternal glucose increases more than 110 mg. What could happen would be it immediately, maternal hyperglycemia pushes glucose to the fetal compartment. What does fetal does? Fetal insulin and fetal hyperglycemia pulls glucose from the mother. So this is very important message here. Maternal glucose is there. The fetus inside the mother's womb is there. What happens here? Maternal hyperglycemia pushes glucose to the fetal compartment. Not only that, fetus also supports the mother, but fetal hyperglycemia pulls the glucose inside. So glucose goes to the fetus. Fetus secretes more of insulin and again goes to adiposity. That is what happens. The fetal glucose steal across the placenta to the fetus. This is what is the most important changes that occurs in the pregnancy. Now, I will make it a simple understanding here, summing up. Guidelines to screen glucose tolerance at appropriate gestation week. How to appropriate week is very important here. Suppose we take women, example 10th week, now they go on testing the glucose these weeks here. When you know, normally most of us know after 22nd trimester, insulin resistance starts due to hormonal changes, tumor necrosis factor alpha, hyperplastic lactogen, but just all these hormones changes will affect the fetal, the mother and insulin resistance, and she will develop GDM. We are not worried about that. Now what happens here, if we take the usual recommendation for screening will be 24th, 28th. Keep this away in our mind. Now we will come to point here. 10th week, I told you earlier, if PPBS more than 100 mg, if you go, suppose you test at 10th week, if it goes more than 110 mg, that fetus at 11th week will secrete insulin. Fetal blood start secreting insulin. Then what we are doing nowadays will be, none of us are treating presently recommendation to test for the glucose tolerance to 10th week is not followed at all. Nobody follows because nobody knows about what's happening. This is a concept now I'm sharing with you. All the books will say 24th, 20th week. Now probably of late, most of the textbook says first trimester. Now even then, still a test week, 10th week is not followed. So what could be the consequences here? Is maternal hyperglycemia and fetal hyperinsulinemia. I hope this slide is clear. Maternal hyperglycemia, 110, fetal hyperinsulinemia, 10th is not followed. So hence, maternal hyperglycemia and fetal hyperinsulinemia promote fetal adiposity, resulting in the offsprings will be here. The child born to the mother will be, if you are a male child, you will be obesity, but IGT and diabetes. If you got a female child, obesity, GDM and diabetes, this vicious cycle continues. That is how the diabetes starts from 10th week itself starts, not 24th week. You don't know. The first time I'm sharing with you, 10th week itself, the prediction can be made that lady is going to become GDM. So having discussed that, now as I have told you, with 10th week, if it's more than 110 milligram, you are not going to save that woman, she will definitely become GDM. So how to prevent of 110 milligram at 10th week? So we must have the early action you must take. Ideal is to test for glucose tolerance at the 8th week itself, that is 2 months itself. So 10th week, too late, because next week she is going fetal insulin. So we must see that by 10th week, blood sugar doesn't come to 110 level. So that is why we must do 2 months. So I'll again repeat here, prediction of GDM is 2 or PPVS more than 110 milligram at 10th week. Prediction. That's all of it now we have followed. Now what happens here is at 8th week itself, PP plus has to be, that's an example. Suppose you are preparing for examination, you must prepare at least 2 to 3 months earlier, not 1 week before the examination, on the day of exam reading and going. So you must have some time, you must give it. So else at 8th week itself, PP base has to be estimated. Because if you do that, because in case of PPBS is more than 110 milligrams, when you test at 8th week, it's more than 110, a grace period of 2 weeks available to attain PPBS less than 110 milligrams at 10th week. So I have given answer here. So an important statement here. In case the PPB is more than 110 milligram to 8th week, 10th week if you go, it is too late. I will tell you again on following slide. So a grace period of 2 weeks available to attain PPBS less than 100 milligram at 10th week. So now we understand in this slide will be example here. Now weeks PPBS is 8th week. Suppose as a grace period, earlier you do the test 8th week. 10th week testing is not useful. So 8th week 110 milligram. So intervention with MNT or metformin. 10th week it comes to less than 110 because we already interfered here 110. So now this grace period 2 weeks available. So you are able to treat that pregnant woman, bring down less than 110 milligram. So at 11th week what the same again continue to be like that. Once the interview given metformin, no increase in fetal beta cell insulin secretion occurs because it is less than 110 in the 11th week. That is what happens if we start intervention 8th week itself. Suppose if we do the test for 10th week, what will happen? Already do the correct thing, you have done it, but blood sugar will be 110 milligrams, blood sugar will be 10th week, 11th week, what will happen? You want enough time is available to achieve less than 10 milligrams. So a simple change of within 2 weeks, what could happen? Saving the pregnant mother became GDM, you are going to push her into becoming a GDM because not enough time available to achieve less than 10 milligrams. So what would happen here will be fetal beta cells starts increasing. Once it starts secreting insulin, it will never come back. So this is a vicious cycle of maternal blood sugar and fetal insulin. What we should do here, then this is what I am suggesting. This is called less than 8th week embryonic stage, then be fetal stage. The embryonic stage itself, we can, that is less than 8th week. If 110 milligrams MNT and metformin 2 milligram, BD has to be started and continued target glycemic to obtain will be about 99 plus or minus 10. So that should be either you do MNT, but you should not waste your time in only MNT because Tuesday we have to bring it down by 10th week to 110. So you have to give metformin. The question comes, what about metformin? How can you use it? Metformin is safe as embryonic stage is over by 8th week. That's why I told this slide here. 8th week, by the time everything is over, embryonic stage, you can safely give this metformin. I think if somebody was talking about the GDM, PCOD, they all give metformin. Now, I am giving the evidence here, the evidence from the National Institute of Clinical Excellence of UK, multi-ethnic power with use of metformin as an adjunct or alternative to insulin in the preconception period and during pregnancy, when the likely benefit from improved blood glucose control outweighs the potential for harm. So that nice, as I already told in 2015 itself, but you're all breaking our head, should I give metformin, should not give it? No, not at all. Now we must read properly this particular point, nice guidance. Now, I want to share an important message here. Lately now, metformin is safe for use throughout pregnancy. How is it? In 2022, February, glucophage or metformin was approved as the first oral antidiabetic medication to be used safely for conception to birth. Now, I think friends who are listening to my talk now, there is no fear of giving metformin because it has been clearly told the best drug to be given conception to birth. So, your ethical committee tells them, show this reference. Metformin is safe for use throughout pregnancy. Please note this, February 22. So I'm coming up to last phase of my talk. Prediction is toward PPG more than 110 milligram. Then prevention will be 2 over PPG less than 110 milligram. That is 110 more is less than 110. So another thing also, administration of metformin after 12th week will not be effective in preventing GDM. So please, at this point you must note, if you don't give metformin and bring down the blood sugar to less than 110 by 10th week, no point in 12th week. If you give 12th week, nothing will happen. All these women, even if you give metformin, they will all develop GDM. So giving metformin 11th week is of no use because this again the paper published recently in randomized way. This study shows. So now finally I'm going to send a message, scope for prevention of GDM. What is the scope? First point, PPBS more than 10 milligram and 10th week is the crucial time during pregnancy for prediction of GDM. So this one has to remember this particular point, prediction of 10th week. So what next point will be here? Hence, intervention has to be started at 8th week itself if PPBS more than 110 milligrams because 8th week because fetal beta cell does not start insulin secretion, embryonic stage and metformin is safer drug. So that means by treating by metformin by 8th week itself, if it more than that means no point in checking. I initially told 10th week. 10th week they will develop GDM. But how to prevent 10th week hyperglycemia? So you have to act much earlier, just like preparing for examination. So friends, this is a message for you all. Prevention of GDM is possible if PPBS less than 10 milligrams at 10th week, as fetal beta cells won't secrete insulin which is desirable. So that is the message I am conveying to all these people who are listening to me talk. So message will be, yes, it is necessary to optimize metabolic control early in pregnancy. This will necessitate pre-pregnancy planning. So now I am going to conclude by saying categorization of glucose tolerance during pregnancy, prediction, detection. Detection is easy, you all know about that. Number of guidelines will be there. As I told you, DIPSI, IDPG, and so many countries have got their own guidelines. But what I am going to hear is, in GDM, pure PG, that's what we are following, 140 milligram, DIPSI guidelines, future type diabetes. Now, recently we introduced also one more category, gestational glucose tolerance, pure PG, more than 120 milligrams. And this also, as number of papers are there, dose penance outcome. What we are going now will be the prediction. Early gestational glucose tolerance, GDM, GJ, the latest classification which we are introducing will be the early gestational glucose tolerance at 10th week. So if you want to discuss, yes, I want to discuss saying early GGA will be the 110 milligram. So 110 EGGA, GGA 120, GDM 140. Even this EGGI, early gestational glucose tolerance, if you are not taking care of this, will prone to develop GDM in the female and IGT in diabetes male. So that is how EGGA has become important in the prevention of diabetes. Now, as I told you initially itself, Lance Kingo, female gender, the key to diabetes prevention. It starts with a healthy pregnancy, low birth weight, a large for gestational age birth weight, elevated risk for in the adulthood life will be elevated risk for obesity, diabetes, hypertension, and CVD. This intergenerational transfer risk will occur. So from mother, the link to the NCD epidemic will continue. So the important message is again I told you from the beginning itself, female gender is key to diabetes prevention. And screening at 10th week, if we bring down 10th week blood sugar less than 110 milligram, the chance that women will not develop gestational diabetes mellitus. If she doesn't become GDM, her offspring also will not become problem. So that's why we say the home is more important than the home. So friends, it all starts in utero. If you want to start a diabetes prevention, nowhere else, please take care of the woman in terms of utero. Else, again, I'm introduce the statement, diabetes free generation, focus on the fetus for the future. This is the only way to get prevent diabetes. If we have to take care of the pregnant woman from the early weeks, even pre-cancer period, then probably you can avoid this. The country can become a diabetes free. So one blood test prevents transgeneration transmission of diabetes. That is my final message to you all. I also request now here will be, let us all pledge to prevent diabetes by one simple test and take care of them. Thank you very much for passion sharing. Thank you very much.
Thank you very much, sir.
Thank the PhD group for inviting me to give this talk. This is a really difficult talk, difficult concept. But little people like little, I think all these doctors now will say to me, please don't worry about 24th week, 12th week, start 10th week. 10th week also late, 8th week itself must bring it down to less than 10. Probably I may appeal to the government of India. Almost they approved. I'm sharing happy news to you. Government of India has approved this concept. Now probably within a month or two, we'll be doing all over the country. Thank you very much.
Thank you, sir. So this is probably fifth or sixth time I'm listening to this concept and talk, but every time I get it a little different and I get some different message. So definitely it is a difficult concept and it is always good to hear again and again. Thank you very much, sir, again, and Dr. Rajesh Jain and Dr. Satpathy for joining. And if you have any question, we have Dr. V. Seshia sir here. You can directly ask to him.
Yeah, can you ask me? No problem. I'm waiting.
Yeah.
Sir, I have one question. My name is Dr. Shruti. Sir, I'm just a new budding diabetologist in Ahmedabad. At my level, a patient would come to me when she has detected with GDM by a gynecologist. At my stage, what can I do? Like, of course, I'll be talking to my gynecologist friends today. That is for sure, because it's such an eye-opening and such an amazing concept that needs to be shared more and more. Other than that, how can we put this awareness amongst our patients and other and to the masses?
You have to believe, Dr. Sashaya. You have to believe. Secondly, please to request your obstetric, please put on the notice on the board. Please come to me. I will try to prevent GDM for you and your child.
Yes.
We are here to prevent diabetes. So if you put both First of all, concept, in this word concept, I have enough evidences. How is it possible? Probably soon government is going to give the order, he will do. So it's a very simple message. Instead of now 120, we are come to 110. Of course, you wait some more time, but please put a board in your office. I am here to prevent diabetes. Contact me. So if you put it, then they will come and ask you. Then you can explain them. By the time I say Ritul, I think metformin I have given the guidelines.
Yes, sir. I have added in our DIPSI guidelines this time, and I'll circulate it.
Yeah. Now probably within by next month, I will send a circular for all DIPSI members and also all OBG people how to work on this concept of how this is. It's very difficult. 3 to 4 times I must listen to have understood. See, one more thing I want to tell you here. Metformin is start. Don't stop it, because already she has thrown her flag. I am going to be GDM. So you checked up early, it still brought it down. So if we stop it, she will become GDM. So from 8th till confinement, nothing wrong. When PCOD you are giving metformin so many months till delivery, why not give metformin prevent diabetes?
Yeah. So now we have sufficient data, sir. Yes.
To prevent it.
Yeah. So
especially in obesity and in obese ladies who are planning for the pregnancy, we can start it beforehand. The way we start folic acid and everything when they are planning pregnancy, we can definitely start metformin in at least obese planning to be mothers. I think that will also be a big.
Yeah.
So answer to Dr. Shruti, what she was asking to Visashya sir, that how we can prevent. We are just a diabetologist and patients are referred to us. But actually this is what we are working for PSG, and we are trying to do this crosstalks, and you can be part of our PSG regularly, and we'll invite you everywhere. Whenever we are doing these meetings in different districts, definitely we are going to invite you.
No, I'll take 1 more minute.
Yes, sir.
When we published 2009, 8 and 9, a single test procedure to diagnose GDM, lots of people don't know what is happening because they're all endocrinologists, like I call them American endocrinologists, IAD, PSG. So 1 year earlier we still published DIPSI guidelines, a single test. It took almost 2008. 2014 only Government of India recognized it and the guidelines was passed. 2018 again. So it will take some more time. I'm sure I will succeed. I succeeded in the DIPSI guidelines. Now I will also come for DIPSI guidelines to prevent diabetes.
Yes.
Yes. Great. Thank you, sir.
Thank you. Thank you all for giving me an opportunity. It's literally very good.
We are missing you here in Kolkata.
No,
sir.
I told you one day I predict Little is going to be the international figure.
He's already international figure, sir.
So Dr. Amit here from Kolkata, and Dr. Rutul has been carrying your flag high. I mean, he always keeps saying that I'm going to take this message forward. And the thought of the PSG, interconnection between the two disciplines, I mean, it is all his brainchild with your guidance and blessings. Thank you very much, sir. Thank you once again for all the insights, for all the guidance. Thank you.
Thank you. All the best to you all.
Thank you.
Thank you, Team PSG, and thank you, Rutul Bhai, thank you, Dharmendra Bhai, for giving me this opportunity, and especially this session to moderate. I think I got the jackpot. I feel like that. Thank you so much. Thank you.
Thank you. Goodbye. Good night, everyone.
Good night.
Good night.
For all of us. Again, excited for tomorrow in physical. Till then, have a great night. Bye-bye.
Thank you very much. Thank you all the delegates for joining. Thank you.